good buccal surgery. So we need to localize the breaks and mark them correctly, a 3-point localization for an HST and a single point localization for the break. When we assess the size of the buccal should extend about 30 degrees on either side of the break and about 2 to 2.5 mm behind the posterior margin of our posterior most break. For cryo, the most important thing is if you're doing a temporal cryo, your cryo probe should not extend to posterior. You can inadvertently cryo your macula, and also you have to ensure that it's the tip of the probe which you are seeing and not the shaft. For passing the sutures, a spatulated needle is used. We use a 5-0 ethibond sutures. What's important is that you have to do it under high magnification. You have to keep your field free from blood. You have to at all times see that your needle is parallel to the scleral surface. You have to keep your needle parallel to the sclera, and just in case you do a perf, you do not have to panic. You have to rotate your eye immediately so that the blood doesn't percolate to the macula. Check with indirect. If there is a retinotomy, do a pexy. And is 6 minutes over yet? No, you have to. Yeah, okay. So drainage, so there are two more common techniques. One is the cut down methods, which is less commonly used, and next is a modified needle technique wherein we at our institute make a small partial thickness scleral opening, and then we use a beveled edge towards the globe, a 24 gauge needle, and we enter the subretinal space, and that's the modified needle drainage technique which we follow. So endpoint of drainage is the appearance of the pigments, and what are the advantages of scleral buckling? So being an extraocular procedure, it is safe. There are less chances of intraocular infection. The vitreous base supports the treated breaks. There are less incidents of cataract or endophthalmitis. Post-operative positioning in most cases is not needed. It's a cost-effective and a cheap procedure. Lastly, it's an essential tool in any retina surgeon's armamentarium. It's a foundational component of surgical fellowship. It does have an advantage over vitrectomy in certain cases, and a proper break localization is the key to success of a good buccal surgery. I like to thank my mentor and my colleagues for the opportunity. Thank you.
Thank you. Isha, very nice talk.
Thank you.
A lot of take-home points, and definitely every resident should learn to do a buccal very competently.
Right.
Any comments from the panel?
Very insightful presentation, Dr. Isha. I would just
you.
like to know what's your take regarding Chandelier-assisted scleral buckling.
So for teaching, it's a good thing, but I feel that it is then making your extraocular procedure and intraocular procedure. You are entering the eye. So I do not practice it myself, but it does have its own pros and cons. So if you are in a teaching institute, it's actually a very good technique to teach your fellows, I feel.
Comments? Weber? Komal?
Just on the point of that chandelier assisted buckle, I agree with the fact that we do have a lot of resistance in converting something to an intraocular procedure, but you have to keep in mind if you're doing a drainage, it's already intraocular.
Yeah.
You're already inside the eye,
inside.
right? So from that perspective, I feel being in an institute, we should take that advantage and teach our fellows. I feel it's a very good procedure, and does give some advantages over a normal scleral buckle, especially if your visualization is not very good.
Correct.
So one more point, it says it's for beginners, so most of the people should be good in indirect ophthalmoscopy.
Right.
So that is the crunch of the takeaway. It should be the takeaway point. So
Yes.
This is what I feel. And one successful scleral buckling gives you satisfaction of maybe 20-25 vitrectomies. That is what I feel.
Yes, true. And you can sleep well for 25 years also, if it's well done.
Yeah, the retina looks beautiful even after 20 years of a buckle.
Yes.
True. Thank you.
Dr. Kaushik, any comment? Okay. So I'll be speaking next. Somebody else had to do this talk, but I'm stepping in at the last minute. So my topic is two-staged VR surgery, and I also would like to add that it is like taking a breather. I'll be presenting just one case about interim PFCL. So this is the case where a 60-year-old lady with uncontrolled diabetes for 12 years, she was on insulin, she was on OHA as well as highly anemic. And both the eyes had proliferative diabetic retinopathy with TRD involving the macula. This is the right eye with finger counting half meter, and this was the OCT. And this was after SOR in the right eye. She was about 2/60, and the macula was very good, and fovea was on with very little structural change. So this is the left eye with just hand movements close to face, and you can see that there is a lot of traction along with a degenerative hole at the macula. So looking at this fibrous proliferation, it is obvious that I was expecting a lot of intraoperative bleeding. So we always have the policy of giving an anti-VEGF 3 to 5 days prior to the surgery. So let's go to the surgery. Right. So here I always keep my fourth port ready because I know with the look of this, with so much fibrous proliferation, thin retina, sclerosed vessels, I know I'm going to have a problem, so I like to convert to bimanual very early on. So this is my dissection with the 25 gauge cutter. Then there is a posterior pole clot. I've tried to remove it as much as possible. There is some SRF also. Now there's bimanual dissection, and you can see progressively how the media is getting hazy because of the blood. Now I've injected PFCL, removing more membranes. And now I'm releasing the anterior traction, which is even more important now that it is more or less like a Regardi. We do a very anterior vitrectomy as well. So now you can see the problem that after FAE, there is this thick and layered blood clot on the posterior pole. I switched back to infusions, injected PFCL, did laser to the extent possible, and I left PFCL at the end of surgery. Now this is the post-op picture at 7th day, where there is a PFCL inside the eye, and she's only PL and PR is inaccurate. Now after about 10 days, I go back in. I think this was 10 days if I'm not wrong. Yes, this was 10 days. And this is the surgery for PFCL removal, and this is just a PFCL air exchange. You can see that it's a lot more forgiving. It was nice to take a breather. This is just an example of how you can prime a very greased utensil with toothpaste first, which probably rinses it off because of its chemicals, and then you do a wash, so you get the entire thing out. So I'm comparing the multi-layered clot to that greased pan, and maybe PFCL has a lot of high specific gravity which kind of rinses away the clot. You can see it's not, it's an unrecognizable fundus. What had a thick layered clot is now a very easily surmountable surgery, and all the steps we can complete, and we have injected silicone oil. So this was post-operative day 9, and she is still PL, but later after 1.5 months, because of the disc and everything being low, we knew the outcomes would be low, but at least we have the satisfaction of giving her some ambulatory vision. This is the degenerative hole that has closed as well. So this was the learning point, that it can be used as an interim tamponade. I'm sure a lot of us are doing it right now. I usually anywhere between 25% to 50% of my very complex VR surgeries, I'm leaving them PFCL filled and addressing the retina after taking a breather for after 10 to 14 days or even 3 weeks. It's perfectly safe even after 3 weeks. And so we did a small study and found that up to 30 days PFCL retention was fine. And resurgery within a month is an issue, because again, if the resurgery is an extensive procedure with residual membranes, blood clots, it becomes another extensive procedure. Some patients with chronic systemic disease, it may have some logistical problems for getting clearance again and everything. And I think ultimately electrophysiological tests must be done to analyze any functional changes because of the PFCL toxicity. So this is the end of my presentation. Thank you.
Hi ma'am, I have a doubt. What all surgeries do you use like PFCL for longer duration? Because I have seen only in reg RDs usually people do
No,
that.
yeah, you're absolutely right. Actually, I use it more for diabetic TRDs. Especially when the blood clot becomes a damper and you can't do your further steps. I just like to put PFCL and leave it for a week or two. In diabetic TRDs, intraoperative bleeding can happen because of various things. The one thing is from the capillaries and the fibrovascular epicenters themselves. If you don't address them immediately, you sometimes increase the pressure to 80 also, because 60 is a very arbitrary infusion pressure. It doesn't stop. And the other source of bleeding is the retinal surface itself starts bleeding. And that time you keep on doing diathermy, but where and for how many spots?
Bleeders.
Yeah, so then that is one indication. Sometimes unfortunately disc bleed if it happens, or we avulse a vessel or something by mistake. So such uncontrolled bleeding where you want to say that okay, this we can wait, put PFCL and just wait, it becomes like very easy after 2 weeks to go back in and just remove PFCL, put air, to complete the laser, put oil.
But since the visual potential was not much, removing the clot required, like, because
Of course.
we
We should
can
give
put in
anything, we should give benefit of doubt, no matter how. I think having an attached retina free of membranes and blood is the goal of any diabetic vitrectomy, and if it is possible after doing all this, then we should.
In diabetics, already the optic nerve head is compromised. Do you find any additional thing when you use extra PFCL for 2-3 days, 4 days, 5 days, and then again oil? So it
Further
enhances
compromises.
the optic nerve head.
Yeah, that's a very valid concern. PFCL is supposed to be toxic. And sometimes in one patient I saw that when I went in for PFCL removal, there were these small whitish deposits all over the retina. So it is a toxic substance, no doubt about it. Optic nerve toxicity, yes, it is going to compromise an already compromised optic nerve head. So we have to strike a balance between keeping it for too long and maybe go in earlier if it permits.
Ma'am, any incidences of subretinal PFCL? Because it is known that PFCL can permeate through even intact retina.
Yes, it did happen in one case, but when you have small breaks and especially in diabetic CRDs, it hasn't happened. But in one case, it was like every I have that video. I can't show it right now, but that was quite a nightmare. There was subretinal PFCL and nothing could be done.
Because subretinal PFCL removal in itself is traumatic.
I know, exactly.
Especially
Yeah, that did happen in one case.
Very nice video, Purva, but I guess one of the important take-homes from this presentation is that whenever you are wanting to put that kind of a tamponade, the first and the foremost is to remove all traction. So that is the only thing that you can do to prevent subretinal migration.
Yes.
Yeah,
So
if you
this
remove
the
all-
indication was this in when I use PFCL is never to take a breather to remove membranes. It's more of the bleeding that I want to take care of later. So definitely that's one of the most important, that traction has to be completely removed. So thank you. The next.
Can I get one more?
Yeah, sure.
Yeah, what was the PFCL fill you normally target? You fill it
To the brim, sir.
to a brim.
Yes.
And suppose, and any positioning you say?
Supine
upright,
position,
should be
yeah,
upright. And one more thing, if the patient has zonular weakness on something like that, you have done an IOL, it's a problem. And one more thing, if you fill a PFCL fully and it rebleeds, it almost acts as a
I know, like a expulsive, like a very
Exactly.
tense eyeball.
Exactly.
We monitor these patients very
so
closely.
silicone oil tamponade for temporary tamponade and then do a surgery, remove the clot versus a PFCL can be studied.
Yes, like a double sandwich you're saying, or only oil?
Only oil. Only
Okay,
oil.
only
Only
oil.
oil versus PFCL.
But oil we have to do only when we know, okay.
Uh,
Unless the membranes are not removed.
exactly.
Yeah, yeah, okay.
Thank you.
Yes. Sub-oil hemorrhage key stays there for a
Yeah,
long
yeah,
time. Yeah.
that's also
Then
a
that acts like a nidus for reproliferation.
Reproliferation.
So, thank you so much. So next we have Dr. Komal. She'll be talking to us about pediatric RD surgeries, highs and lows.
Good morning, everyone. I'm here to talk on pediatric retinal surgeries, but before that, I thank Apurva and the UC group for having me here. So why are we talking of this? What is so special about pediatric retinal surgeries and what is so different from the adult retinal surgeries? So we have anatomical considerations before we take up a kid for surgery. The eyeball is small, the lens is large, there's less movement of instruments, the cornea is steep, the axial length is small, we need smaller instruments. The sclera is pliable, most of the times we have to suture our ports. The way we make our sclerotomy ports also differs from case to case, from age to age. It's different in preterms, it is different in infants, it is different after 2 years. Vitreous is very densely adherent, and in most of the tractional RD cases, we avoid the PVD, but obviously in reg cases, we have to make sure all the vitreous is removed. Many of these cases will have a persistent PFV, which needs removal. A lot of preoperative considerations are also required, like general anesthesia, a very good parental counseling to adjust their post-operative expectations, a need for a strict follow-up, positioning, and obviously the management of long-term complications. So what I'm gonna do is just go through a few cases, my highs and my lows in this 7-year journey. So first let's come to the successes that I've had. This was a stage 5 retinopathy of prematurity, baby with leukocoria, where I started off with a horizontal entry, removed the lens. The pupil wasn't very dilated, so I prefer to remove a little bit of iris from these cases, remove the posterior capsule, and then start off with the dissection. These cases are purely tractional. We just need to remove the membranes as much as possible and not try to touch the folds or try to settle the folds. We will not have an attached retina at the end of the surgery, on the day of the surgery. So, and then I use the cutter to remove the vitreous as much as possible. We use air as a temporary tamponade here. 2 months later, what do we have? We have an attached macula, opened up funnel, few folds, but 1 year later, this previously blind child is now fixing and following light. So that was the high. Another case of an epiretinal membrane peeling in a regressed ROP, where the macula was totally crumpled because of a thick membrane. Now in this case also, I did not do a very aggressive PVD. I used a forceps to slowly remove that thick hyaloid or thick membrane which was crumpling the macula. You can see it is very densely adherent, and I was not able to remove it like a normal idiopathic ERM. So slowly and slowly I removed it, and then at the end I had to trim it because it was attached at a focal point. The high, it was an opened up macula again, better anatomical and a functional outcome. Now managing central TRDs in persistent fetal vasculature is similar, very similar to how we manage a stage 4A case. The main point is to make your sclerotomies very finely, cut the stalk, do a core vitrectomy, and then slowly peel the membranes to open up the funnel, which is closing the macula. Again, these cases are tractional, they do not require a lot of manipulations. Do as little as possible and then use air as a tamponade. But more than this, let's come to the lows, the failures that I've had over the years. Iatrogenic retinal breaks, they are a nightmare, especially in a case of ROP. Now in the first video, you can see it was a retinal fold with active traction, which I wanted to remove. I made the sclerotomy. I went inside, I saw a reg component, and I realized that the sclerotomy has gone through the anterior retina. So what was my lesson learned? A pre-op exam after the child has been anesthetized is very necessary to pinpoint at which quadrant you should not make a sclerotomy. Curvature of the eye. These infant eyes are small. The curvature, even the posterior curvature is much more steeper. The way you move your cutter is different than as in the adult eyes. Very simple case, I was just removing the vitreous hemorrhage. I'm not inducing PVD, and then I created a retinal break on an attached retina. So follow the curvature of the eye. That's what I learned from this case. Both cases we were able to save, but iatrogenic retinal breaks can be very, very difficult. Pediatric reg RDs and the struggle of PVD. Here I could remove the vitreous from the disc. I have put PFCL to stabilize the posterior pole, but you can see how difficult it is to remove the posterior hyaloid from the rest of the retina. Leaving the hyaloid in such cases can be detrimental because it will lead to PVR and very bad recurrences. Again, in this case, I removed as much as possible, settled the retina. Later on, the child had a recurrence. I reoperated, but ultimately I lost this eye. One of my very favorite cases, stage 5 surgery, beautifully opened, very nicely attached retina, a very nice functional outcome where the child was fixing and following the light, as you can see in the video. 2 years after this successful surgery, came with this total hyphema and neovascular glaucoma. So what I learned that it does not end with a successful surgery. The peripheral attached retina in these cases are avascular, they are ischemic, and they needs attention. So once you have had a successful surgery, you need to do an EUA, examine that retina, do a laser or a cryo to those parts so that this does not happen to your successful cases. Just to end the lows and the highs I had in one particular case, again one of my very favorites, a stage 5 case which I operated. I did the normal stage 5 surgery, and then later on I was removing the peripheral vitreous, created a break, and this is what happened. My heart stopped and I thought I'll just close after putting the air. I started putting air, but then I realized as I'm putting air, the retina is moving back again. So I realized the break was peripheral and did not have any traction, fortunately, did not have any fold, fortunately. So I did a cryo, said my prayers, and put oil. 1 month later, I removed the oil. I did not want to make a sclerotomy, absolutely. So I used the limbal approach and examined the retina, and to my surprise, this was the retina, absolutely attached, cryo breaks, and just a little bit of drag towards the nasal side. It does not end with the surgery. We have to watch out for cataract, glaucoma, eye-related complications, squint, amblyopia, ischemia, NVG, and we have to take care of them all throughout their life. So we have anatomical challenges, we have functional challenges, but the reward is unparalleled. Thank you.
Wonderful. Those were some really fantastic surgeries, Dr. Komal. Very inspiring also, and also gave a sense that we are not alone in having all this, you know. So any comments from the chairperson?
ROP surgeries, I don't think in every case, like you did stage 5, but in other cases like stage 4B and A, you don't need to induce PVD.
No, we don't. Yeah, we don't. I don't induce PVD, and that's the norm for most of the surgeons. But despite that, as I showed in the earlier cases, I was like almost starting ROP surgeries at that time. You have to get used to the eye and the space that you have inside those preterm eyes. Stage 4 again is a very, very small eye because the child is anyways preterm. Stage 5 is still a bigger eye. So.
Any experience with buckling below 10 years or 8 years?
Yeah, so buckling is the go-to procedure for any reg RD in a child. I've not presented here, but we have had cases, very bad chronic RDs with subretinal bands, but if you know that the break does not have a traction, which needs a vitrectomy, buckle is the go-to procedure for all of that.
Buckles tend to do
much better,
even with a lot of PVR and subretinal gliosis and chronic RDs. So, any more comments?
Extremely insightful presentation, Dr. Komal. Prakash Netra Kendra is my alma mater, and until 2021, ROP surgeries weren't being routinely performed over there. So, what were the challenges you faced while initiating ROP surgeries in a new setup?
So I would say I like training wise or surgery wise, I did not face any challenge because everything was already there, already placed. It's a well functioning center and a well functioning retina dominant center. So from that perspective, I do not have much of a challenge there, and I was already trained. So I did not need a mentor as such to train me there. The major challenge is anesthesia. So you have to, you know, sort of really convince your anesthetist that those kind of babies need to be taken, and when they are taken, they need to be taken care of anesthesia wise as well. The anesthetist also has to have confidence in you, that you will also listen to the anesthetist, and you also need to have a lot of confidence in your anesthetist. So that's the major challenging part. So I guess for very preterm babies, it's still a challenge, but I'm doing a lot of LSVs and stage 5s now, which from where the anesthesia is manageable.
Very nice. Thank you so much. Thank you. So next we have Dr. Vaibhav Sethi. He's going to talk about mistakes made and lessons learned.
I think I should have presented before Komal, because after Komal my presentation will look very bland. So after the inspiring talk, we'll be coming to a few perspiring talk. And you know, sometimes you always tend to make a lot of mistakes. I have so many videos that I can do a master class on mistakes, but just presenting a few of them. And adult eyes tend to be easier than pediatric eyes, but you tend to make those mistakes every time. So this is a ERM case. A simple case normally which we'll take care of very easily. I normally do a tricot stain and induce the PVD, and here PVD induction tends to be slightly difficult because in ERM the hyaloid is more adherent. So you can see there's a peripapillary hemorrhage that occurs sometimes when it's very attached to the optic nerve head. So after doing it, everything went on routinely well, and when I came and injected the blue dye as well. So after injecting the blue dye, the staining was piecemeal. Sorry, I'm sorry. I think I skipped it. So basically, sorry. So it was piecemeal, and as we expect in ERM, because ERM doesn't stain. So the routine staining, everything goes on well. I was able to find the epiretinal tissue and peel it off comfortably. But you know, when you see a lot, you tend to peel a lot, and that is a mistake I think we should tend to not make. So after doing your ERM and ILM staining from the parafoveal area, I think that should be your main goal, to remove the film there. But if you see too much, you kind of, so I saw a few islands of staining. I thought maybe I'll just pluck it. Yeah, good. I'll remove it. Yes, nice. Okay, I'll let it be. So this is one of the areas that I call a superficial retinal pinch, and that led to a break. So later on, I let it clot, increase the pressure like we normally do. So the second mistake in the same case, this is a case that operated sometime back, long back. So when you initially start, you tend to overdo things. So after doing and clearing the clot, I should have left it right now. But I guess your basics and your skills, everything, sometimes you tend to forget, and you tend to do the same mistake again. So I thought I'll just clear this small clot again, and the same cause. Basically, the moral story is you should not pinch and peel every time on the same area, because platelets have already caused a stagnation there, and otherwise you'll again cause a rebleed. The second case is very important, and this is a learning lesson for me. So this was an elderly female, and on antihypertensive. She came with very high eye pressures, and she had an exudative hemorrhagic detachment. So the plan was, there was some corneal edema, and the view was a little suboptimal. So I went ahead and stained with tricot, and tried to induce PVD, did peripheral vitrectomy. So the plan was that I'll do vitrectomy, and after that I'll inject subretinal TPA, and then do fluid exchange and close with gas. But when I saw that the detachment extended during the surgery, so I thought okay, I'll inject the subretinal TP. I injected, I waited, I created a small retinotomy there, and I thought I'll just drain out some of the liquefied fluid, the blood. But basically, the clot was quite big to handle from the small retinotomy. So very important to have a plan B. So the approach should have been that I should have gone more peripheral and started with a retinotomy, maybe a 180-degree retinotomy. So I went ahead, tried to remove the clot under air because there was some amount of bleeding. I did succeed in removing some amount of the clot, but as in retrospect, you can very easily say the opening was too small and the clot was too big. So in such cases, it's always much better to just lift up and make a flap of the retinal fold and remove the clots from the subretinal space. So I still waited. I did not realize that I should have done that time. I cleared whatever I could. Then I thought maybe I'll go with a plan B, which was not sort of, and made a retinotomy, but this was more mid-peripheral, as you can see. So after doing that, what happened was I already also placed PFC in the eye, kind of tamponed the break. So this was a kind of a mixture of all the wrong things that can happen in one eye. So I tend to, remove the blood clot from that particular area. I managed somehow to remove the majority of the clot, but the view was compromised. So I think I should have put in PFCL after clearing of the blood. Maybe that would have been a better staged approach and tackled it in the second case. But I guess I lost this case. So the patient post-operatively had a hyphema and vitreous hemorrhage and a Ragardi. So it was lost. So this conclusion would be that you need to visualize what you do, and minimal tissue handling to get maximum outcome is the key. So you should know your limits. That's very, very important, and learn from every case. Thank you.
Thank you so much, Vaibhav. We have all done this, so we relate very hard to everything. So very nice cases, I think. In the second case, sorry, I may have missed it was a massive subretinal bleed.
Yes.
Okay. Did you think of TPA maybe?
Yeah, I did inject TPA. So plan A was I'll do TPA and wait on, and then do partial FAE and inject gas and wait. Maybe it'll clear off, but the detachment extended during the surgery. So I thought maybe I'll remove the clot.
Right.
But the problem was that should be my plan A. I should have gone as peripheral possible, made a 180-degree retinotomy,
Yes, exactly.
flapped it, and then removed the clot. That would have been simpler. At least that would have given me a chance of success. This never gave me a chance of success. I just kept on making the same, more number of mistakes. So you went on a trail of making one mistake after the other, and then I realized on retrospect I should have done that only. It was too late.
So you have a nice recipe for an international case presentation or an award for this. Any
Kaushik
other?
wants to ask.
It was a hemorrhagic RD or just attached retina with subretinal bleed?
It was a hemorrhagic RD.
So actually these cases are very difficult, and whatever you do, the outcome is usually bad. But it is a good idea to do retinectomy peripheral and take out this, because it will not come through that, and it will create much more problems. And what I have seen that even if you operate, the retina is attached, but many cases go into phthisis even after doing everything. So these cases are, and some cases might have the hemorrhage is so much that it will touch the retina, touch the lens, etc. So these cases are very difficult, and you need to tell the patient that yes, we are trying, but we cannot say that what the outcome would be.
Thank you.
Dr. Vaibhav.
One non-academic question. Most people over here know that you have a quirky sense of humor. So how does that help you in your practice, or has it ever backfired?
I have never practiced with my patients. I only malpractice. So it's only for the colleagues.
Only for colleagues. Dr. Rajiv, Dr. Vaibhav, anything from your side apart from what you already spoke about this case, about the previous cases, anything?
I think the essence of today's session was we all have made mistakes, and it's important to not repeat the same mistake.
Yes.
So when the same case comes again, which it will, I should be prepared, and we should all be prepared.
Yeah. Thank you so much. So next we have our international speaker, Dr. Niti. He's going to talk about macular buckle using common buccal materials. And knowing how difficult they are to procure, I think we are all looking forward to his talk.
Good morning, everyone, and thank you for Yosi for having me here. It's a great pleasure to be here. Okay, today I'm going to talk about macula buckle using the common buckle materials. Have got just 6 minutes, so let's go. Okay, no financial disclosure here. Okay, when you see a case like this with the OCT like this, firstly, what are you gonna do? For me, I'm going to cry. Yeah, it's a little bit hard. Oh, no. Okay, so let's get to the point. We have two options, right? Vitrectomy or macula buckle. So what should you do? Okay, I'm talking about macula buckle. So what do you expect? Yes, macula buckle. Okay, so you know the basic. If there's the tangential treatment that cause the macula hole, you do the tangential treatment. And if there's the perpendicular traction that cause the schisis and detachment, you do the macula buckle. Okay? And there are various fancy silicone bands and sponges and metals. Yeah, there are a lot of genius that create these buckles. So what are you going to choose? Yeah, my wife advisor said that use this one, Maureen Devin T buckle, because it is the silicone band that is most similar to the buckle band that you use in the scalar buckle in RRD. This is the picture of the Maureen Devin T band. Yeah, it looks familiar, right? This one, it just looks like the normal silicone band. But, okay, I will try to get this. But I have asked all the suppliers, and they say, no, they are totally out. There are no buckle anymore. So I asked my advisor, what is the plan B for me? He actually said this. Please look at the Indian marketplace. So I look at the Indian marketplace. I've opened this and I see in the Indian mart. Yeah, it is so amazing. You can buy everything here. You can find the phaco machine in this website. I'm so amazed. Yeah, but however, when I search for the Maureen Devin buckle, it showed this. It's showing me the Moringa Divine buckle. What the hell is this? Okay. And then it showed the result for the moringa leaf powder. This is definitely the buckle we are looking for, right? No. Okay, and then I still cannot find the macula buckle or macula band on the marketplace. So I asked my advisor again, and he said, oh, if you cannot find it here, you are out of luck. You can advise me the better marketplace. Okay, so I asked him for pansies. He asked me if I'm good at crafting. You have to knit a buckle yourself. This is a photo of the buckle. Okay, I try to replicate the Maureen Devin buckle with the common buckle materials. I just use the 287 wide groove band and the 41 band, or if you don't have the 41 band, you can just use the 240 band, which is very common one. Let me show you the video. Okay, firstly, you cut the 287 wide groove band into 1 centimeter segment, and you make a slit like this, and then you insert the 41 band inside of it, and then you suture it together with, you can use the 6O proline to do that. You suture until you think it is strong enough. Okay, and I've done it again. For the sake of time, I will speed it a little bit. Okay. And then you test it that it is strong enough. You pull it. Okay, it is strong enough. And then you insert the 41 band into the groove of the 287 wide groove, and then you suture it together. You can use the egg or Velcro. Okay. That's all. Okay, and this is the final product. Okay, let's compare it with the original one in the bottom right. The chair is blocking the view a little bit, but it's okay. But I would say that it is quite similar. Okay, imagine it is similar. Okay, so I'm a little bit proud of my crafting skill this time. Okay, so no, it's okay. Okay, so this is my first surgical case. I will go it a little bit quickly because of the time. Yes, for the macular buckle, you hold the lateral rectus, superior rectus, inferior rectus, and also you have to find the inferior oblique. Here's the inferior oblique muscle. You have to hang it also. And then you put the inferior arm underneath the inferior oblique and inferior rectus, and the superior arm through the lateral rectus and superior rectus. And then you hold it temporarily with the, you can use the 5 or the polyester suture in both lower and upper arm. And then do the paracentesis to keep the IOP low. Or the time is out. Give me 1 more minute, okay? And then you put the buckle backward into the macula area, and you use the chandelier system. And you look at the position of the buckle and while you slide it underneath the macula. And then you suture the leg of the buckle, with also the 5/4 polyester suture, and then you suture all the bands together. Okay, this is such a suture. Okay, and then you close the eye. All done. This is my first case of doing macular buckle, so it's not going to be very, very beautiful. Can you see a buckle effect? No? Yeah, it's a little bit too temporal to the fovea. At 2 weeks post-operatively, the OCT, it shows a little bit promising result. But from the literature, they say that you can wait up to 3 months, so you don't have to be hurry. I'm still waiting and still praying that it get more attached later on. So in summary, in this case, for the first timer doing the macular buckle, you expect it to do it about 1.5 to 3 hours. And you have to do it under general anesthesia for the peace of your mind. Yes, and the good candidate, you have to choose for the first cases, you choose the patients with the wide palpebral fissure. It will be much more easier to do, and do it with your mentor for your peace of mind. All right, thank you very much. I'm sorry for the delay.
That was fantastic. I think we'll all try, and we would love it if you could share this video. Is it on YouTube or something?
Pardon?
Is this video on YouTube or something, so we can look at it again?
I will put it on YouTube. And
Thank you.
Yeah, and send it to maybe Diva or Karan.
Okay, thank you.
Yeah.
So what's the end point of trying to push the buckle backwards?
Yeah, you have to push it, and the end point is if you look at through the chandelier system, you see the buckle just beneath the macula.
Okay.
You don't want to push it too far, because if you put it too far, it will touch the optic nerve head, and that if you keep pushing, it can be devastating.
Yes.
Yeah, but first, before you look at the chandelier system, you push it until you feel resistance. Yeah, just a little bit of resistance, and you stop and you look into the eye. Yeah, to see where's the position of your buckle.
Right.
Dr. Barbara Parolini has suggested a nomogram so as to suture the macular buckle based upon the classification of myopic traction maculopathy.
Yeah.
So do you follow any such guide while tying the suture?
I have never tried the Barbara technique because I don't have the Barbara buckle. Yeah, the Barbara buckle is very, very unique. Yeah, so I have no experience in that, but yeah, it's very interesting. Yeah, I have heard a lot from Dr. Barbara, and we should follow her. Yeah, actually I have the classification system from her, but yeah, I don't have the time. Yeah.
Okay. Any comments?
Basically, I think if there was a system like some light or something which will show you the exact position of the buckle, then it the misplacement will be very less. There are some buckles which have macular buckles which have light, and you can see from inside that it is exactly at the position. I think
Yes.
that helps a lot.
Yeah. Thank you.
Has anyone in the audience or the panel done a macular buckle? Wow. Okay. Any thoughts?
I did one, and after that I never did it again. So, it is for me. I did it with my mentor again for my peace of mind.
Yes.
It was difficult. I feel again the placement for me for the first timers to place the buckle exactly at the macula. You're already very scared on not touching the optic nerve and not being beyond the macula. I mean that short distance is a thing. And again, I guess there are too many sutures involved.
Yeah.
As retinal surgeons, I think
We are lazy.
Yeah, we are lazy people. We don't suture that much. So there are too many sutures involved and too many placements to see. So I guess it's a very good technique, but I also feel that it has a very steeper learning curve as
Yes.
compared to normal buckles.
Definitely.
So, and again, choosing the right case for your first case
Yes.
is very important. That wide eye, wide palpebral fissure is very important. But I guess as compared to a normal buckle, it would take much more cases for you to get used to the technique itself.
Thank you.
Thank you.
So we've finished on time. Thank you, Dr. Nitin.
Thank you
for
very
being
much.
part of this as an international speaker. Thank you, Dr. Kaushik, Dr. Rajiv, Dr. Dipanshu, Dr. Kshitij. Thank you, audience, lovely audience. Thank you to all the speakers, and we had some amazing discussions as well as presentations. Thank you again. See you next year.
Let's have a group photo.
We'll just give away mementos for our speakers and panelists. I request Dr. Niti to please hand it over to Dr. Isha Agarwal. That's for her. Yeah. अच्छा नहीं नहीं अच्छा open okay sorry yeah ऐसे लगता है next किसको देना हाँ you go and give him अच्छा Dr. Vaibhav Sethi. उनको दे सबको देना. हाँ हाँ. Dr. Rajiv Gandhi. Dr. Komal. Dr. Dipanshu. Dr. Kaushik. Dr. Kshitij.
Dr. Apurva. Last, Dr. Niti. I would request Dr. Apurva to please hand over. Thank you.
So thank you Apurva ma'am for wonderfully conducted tales and travails of young retina surgeon. And now I hand over the podium to Dr. Kaushik Tripathi for conducting the next session, that is on medical legal aspects. Over to you, sir.
Okay, very good morning to all of you. I'll invite Dr. Tetsu Singh Mallia, our chairperson. Our co-chairperson is Dr. Chris. And I'll invite our panelists, Dr. Akruti, Dr. Anujit, and Dr. Mausumi. Please come on stage. So, Dr. Arti Heda could not come. I'll be presenting on her behalf. So I think let's not waste time and let's start. So, just let's tell about what we have been doing in medical team of EOC. So we have had almost 19 sessions every monthly on various medical legal aspects, and all of those have been uploaded to the YouTube EOC channel, and you can actually scan this, and we feel and these are very important issues, and this will be more prominent in near future, and definitely to be future ready you have to know the laws and you have to be very careful in managing patients. So this is the YouTube EOC web page link. You can go there and you can see our videos which have been uploaded there. So we have already had 19 sessions on that, and every month we have these sessions. I have been lucky to have Dr. Dipanshu, Dr. Arti, and Dr. Sayantan Ghosh in my team, and our mentors are Dr. Anand Deshpande, who is already a key person in making the consent of AIOS, Dr. Manoj Mathur, who is the current treasurer of AIOS, and Dr. Prakash Marathi. They have been guiding us from the beginning. So I'll be talking about the medico-legal aspects of teleophthalmology. So basically I'll discuss the controversies and initial resistance about telemedicine and what are the telemedicine guidelines and what to do in telemedicine. So basically previously Karnataka Medical Council warned doctors against using telemedicine because they said that it was playing with a patient's life. So, but when Corona came, the government found that it is illogical to prevent telemedicine which is happening everywhere around the world. So then they took out the circular and they said yes, you can do it, which should follow some terms and conditions. So there are multiple controversies regarding this. This was a case where the senior doctor advised over telephone and the patient died. So the doctor was penalized. So this is a famous case which was in the news also. A doctor couple gynecologists from Ratnagiri, they went to a conference and they were giving instructions by phone without seeing the patient themselves, and this was termed as a criminal negligence. So the government has brought out the act to regulate this. So basically any registered medical practitioner can do this. Their NMC was to develop an online course. I do not know whether this is there because it is not online. And so you can do it by using video, audio or text. So basically there in the guideline there are 7 elements. I will not go into the thing, but most important is that they have divided what is first consult, what is follow-up consult. First consult is when you are seeing, follow-up consult is patient is showing you within 6 months. So for ophthalmologist it's always video consultation. You have to ensure the patient's identity, and before you are giving drugs you need to see the patient in video. These are list A medications which need you to see the patient in video only. So in every follow-up of ophthalmology you need to do a video consultation. These are the sample prescription format which the regulation gives. So you have to give your registration number and you have to put your signatures and follow up instructions. So in emergency patients, you cannot manage it in telemedicine. You have to give first aid, you have to counsel the patient, you have to tell them where to go and advise in-person consultation in writing that you have, this is an emergency, you have to go to a clinic in person. So these are what you have to do in first consultation. In ophthalmology you have to always do video, identify the patient, and because patient has contacted you themselves, this is implied consent, and if it is emergency quickly send him or her to the emergency in-person visit. If it is not an emergency, then you can manage with education, counseling and specific treatments. So this is the follow-up guidelines. So what you cannot do, you cannot start consultation without identity. So, and do not treat emergency patients who need in-person care. Do not divert from prescribed flow chart and prescription. So I again thank my team, and I will request all of you to please visit this YouTube link. There are multiple resources there. So any queries from the panel or from the audience, which is sparse already.
Sir, very good talk. Sir, I want to know how do we take consent in telemedicine? You spoke about.
So basically,
consent.
this is implied consent because patient has contacted you. So this is implied that they want your care, and most of the telemedicine sites, they need the persons to upload some digital identity proof, like identity proof with their photos, so that the identity is done. But in telemedicine, what is important is if you think that there is some retinal problem, central retinal arterial occlusion, ocular emergency, then do not keep the patient seeing the patient online. Just say, sir, this can be something wrong. You have to visit in person to a specialist. So you can manage like allergy conjunctivitis or simple things like that, but do not keep grave things which can become worse if they do not take an in-person consultation.
Yeah, good morning. I'm Zan from the Philippines.
Yeah.
I know we have different cultures as well as policies in different countries, but may I know here in India, I mean for you, are you able to prescribe, give like an electronic prescription to
Yes.
patients?
Yes,
So you
yes.
are allowed by the government?
Yes.
Okay. So that was also a thing that happened to us, especially during the pandemic. So we were allowed to give that. So the pharmacists would also allow it as long as they have the prescription.
Yes, actually it was banned before the pandemic, and after the pandemic, when the government understood that this is not possible, this is not feasible for everyone to go in person and show the doctor, so that's when they started this. And we have, I think we have a Ophthalmology Society of India, Tele-Ophthalmology Society of India here also. Dr. Akruti, any queries?
Yeah, I wanted to inquire, do you record your telemedicine videos, or how are you medico-legally safe? Because it's implied consent, you don't have any documentation.
No, I don't think it is required to record the encounter with the patient, but some online systems, they do record this, but this is not mandatory. And as I said, you need to first do no harm. If you think that the patient needs emergency or immediate consultation with a consultant, you just send them. You can see cold cases or follow-up cases who cannot come to you.
I'm not aware of any cases that have been medico-legal cases that have happened or based
For
on
telemedicine, no, it is
there
not due to telemedicine, but it has happened when like the senior consultants are not there in house, they were not in the hospital, they were visiting somewhere else, and they gave instructions to the doctor who was there, who was a junior consultant. So there they have told, like this Ratnagiri case, the senior consultants, both husband and wife, were in a conference, gynecologist. There was this junior consultant there, and all the senior consultants did was that they gave instructions by phone. You cannot, if you have not examined a patient, you cannot take responsibility of that patient, and you cannot give the directions by phone. You have to see them by specifically if there is an emergency, and if you are not available, you give it to some other senior consultant. Like this senior and junior, the court doesn't know about this. They just understand senior and junior consultant. They think that junior consultant are less competent, and if you have done surgery, it is your duty to give the follow-up care to somebody who is equally competent to you, so that they can follow up the patient and they can manage themselves, not by asking some other person.
Okay. Thank you. I'm Dr. Teju from Nepal. So the use of telemedicine and medical legal aspect, I think it should be used judiciously, because like there have been times when because of this advantage, so the doctors are not being recruited from the local level, right? Suppose, for example, there is a local radiologist available, but instead of using his expertise, they are referring someone who is maybe miles away. So maybe this may create a problem in job security.
Yes,
as well.
there is
So,
this aspect
yeah.
also, and I know many radiologists who are doing work here, and they are like in a remote place they are reporting.
Yeah.
So this is
So
the
I
case.
think it's okay if there is no radiologist in the radiologist is just an example.
But you cannot force
Yeah.
that. You cannot force that. If somebody is
Yeah.
competent, somebody is willing to work, why
Yeah.
should not they get paid?
Yeah. So and the Nepal Medical Council has issued a notice that for us, like the electronic signature is not allowed. So because like lots of fake stuff have been going on, misuse of the signature have been used up. So I think that's also another perspective.
Basically, in ophthalmology, teleophthalmology has to be used judiciously. Actually, I have never done telemedicine yet. I can say that. I think this is a little risky because some patients do have retinal problems or some uveitis, etc., which you cannot say or cannot tell the patient by saying that. And if you are taking consultation, you cannot take responsibility if you are not seeing the patient. So why I have not done, but people are doing. Yes. Now I'll request Dr. Dipanshu, please come on stage, and I'll go to the next presentations, how to prevent medical legal issues. So I see very less spaces. Dr. Subratanu, like your 2 comments, 2 or 3 points, how we can prevent medical legal issues in practice, 2 or 3 most important points.
See, this is the days where the medical and the legal thing are coming together. So first and foremost, you have to have an informed consent, a valid informed consent from the patient you are treating. A valid consent is like anybody above 18 years of age who has competent enough to give the consent can be taken. And second, documentation. All legal documentation should be done very nicely. And you should third point, you should have a medical legal lawyer present with you. Any decision you make. I'll come with my presentation. Even the declaration of death shouldn't declare death unless you have consulted your medical legal consultant. All the documents should be in presence of a medical legal consultant. So that is what 3 points: consent, documentation, and advice.
Thank you. So I'll discuss what are the guidelines and what are the possible issues and how to prepare and prevent. So basically, when we are doctors, it is always about the patient. Patient is the center of everything.
It is not showing on the screen.
So patient is the center of everything. You need to show respect. That is, patient should have a say on their treatment. They should be the partners in the treatment. You should not impose your judgment on them. So, and your treatment should benefit them. And this is most important. You should do no harm. And there should be justice. So basically, the health and well-being of your patient should be your first priority. That is the most important thing which you should keep in mind. So from where you can have these medical legal issues? Their notices can come from people, the patient or his lawyer, organizations like consumer courts, medical council, other statutory bodies, and there can be cases online defamation or even violence. And violence is very common in India. So they can aim for monetary compensation, criminal case, they can ask for your registration to be cancelled, you can be held in sexual harassment, and there can be a complaint before human rights, or there can be defamation. So basically, what you can do in this thing? So basically, you need to understand complication is not negligence. Complications are known adverse events after surgery, and they can happen. What is important is that you need to manage the case properly. If there is complication, you need to manage it with guidelines. And I think rather than documentation, it is important to show the patient that you are taking care of him to the best of your abilities. It is the communication, it is the bond with the patient, that you are trying your best to help them. So if they understand that, if they perceive that you are a friend and you are trying to help them and you are trying your best to help them, they also know that not everything is in your hand. So if this bond is there, if you are able to form a trust between the patient and yourself, then most of the problems can get solved. So this is, compassion is very important, and many of us are trying to increase our patient load rather than increasing the quality of the seeing the patient. Actually, it is important to give time to your patient so that you can understand and you can listen to them. Your behavior obviously should be friendly, and if some wrong has happened, you tell them clearly, so that you do not, if there is a PCR, you do not say that there is this thing, there was a I broke the capsule and this. You say that this is a known complication of the surgery. Some cases have thin tissues and the tissues can get damaged, but in many cases people cannot put intraocular lenses. I was able to put intraocular lenses, and whatever extra medicine, whatever medicines are required, I have given, and most likely you will have a good outcome. And if there is some problem, I will be there with you, and we will solve it together until it finishes. So negligence can be something which you have done, or something which you have omitted, which is required by the which is done by a standard regulation. And do not do professional jousting. Like this colleague, he wrote that somebody did complication elsewhere. So this is how we are getting trapped. We are ourselves trying to hurting our colleagues. So this is not done, because you are living in a glass room and you are trying to throw stones at others. So you will ultimately get hurt. This is a double-edged sword. So do not do that. This is for your own benefit. So obviously hospital-related factors are waiting time, bad behavior of staff, or poor communication, poor infrastructure, or negligence. So basically what you need to understand is that each patient is a potential litigant, and mostly the litigations are provoked by somebody. So this is either your colleague who thinks you are their rival, or optometrist, or lawyer, because there is monetary advantages involved. Some lawyers actually tell people that you just make the case, if you win, we will divide it, if you do not win, it is my loss. And most of the difficult patients have something going on in their mind. Somebody might have died, and some stressing factor is there. So do not judge them. If they are violent, what I do is I have told our staff to find people who exhibit certain criteria, who are violent or who are restless. So you see them early. You have to take them out of the system very early, and you see them, and the senior most person should attend to these people who are very restless, or who are potentially can create trouble. There are some patients who will tell, I had shown this doctor, he said that this doctor is bad, or he said that this doctor has done some complication. They can tell that to you. You do not judge. You say, sir, I do not know what has happened. I can see your eye, and I can tell you the ways how we can move forward. I cannot go to the past, and I cannot say who has done some wrong. So do not go there. You go positively. Go to the future. Be positive and try to give them ways how we can improve their situation, and set realistic expectation. And they say, I have done this surgery in the other eye on elsewhere, and this eye is bad. So, and they want guarantee. Do not give guarantee. You cannot give guarantee. It is illegal. So how to prevent, as Dr. Subratanu said, document, consent, under promise, and over deliver. Expectations should be set right. You give time and discuss. Before surgery, you involve the patient in decision making, and treat your colleague with respect and awe. So this is obviously you have to prepare. We have had episodes on consent. Just see them. AIOS has prepared elaborate consent. You can access them on AIOS site. Talk with the patient personally to tell so that they understand the risks, benefits, and alternatives. So the compensation can be huge. So there is this AIOS has come up with Suraksha plan. I think if you have not got it done, try to add it, and if there is a compensation, there is interest added to that. So if the case is going for 10 years or so, you will have to give compound interest on that. So record keeping is very important. There are guidelines on how long you have to keep the records. If you have not got medical indemnity insurance, take it now, at least 1 crore. And this AIOS Suraksha is there, so you can apply for that. Teleophthalmology I have already told. So when there is a case, there is a notice, you do not panic, and you consult with your medical legal consultant and insurer. We have AIOS legal cell is there. They can help you if you have such a problem. So my take home will be, each patient is a potential litigant. In your mind, your conscience should say that you have not done harm. You should do no harm in your all practice. Try to do no harm, follow protocols, follow medical etiquettes, be truthful, and encourage. If the patient is not happy with you, you say, you can take second opinion, and you can go to these places, give them 4 or 5 names, and get professional indemnity insurance. Thank you.
Thank you, Dr. Kaushik. That was very insightful. I would request Dr. Tetsu to, if you have any comment.
Thank you. So my query is, has YOSI received any request for assistance from its members during such kind of cases? And are there, beside UC, maybe AIOS, has the...
AIOS
there,
has...
no, I'm focusing on UC, but my second question is, is there any data related with medical legal cases and whether they were prosecuted or not?
So you see, as of now, directly, no consultant has contacted us directly, but we know of multiple cases in nationwide which have been, people have contacted AIOS. AIOS has a legal cell in which Dr. Anand Deshpande is a key person. So he usually sees, and because these are controversial things, it is better not to give the details in open forum. So most of the cases pertain to cluster endophthalmitis or cluster toxic anterior segment syndrome. So when such cases happen, the doctor themselves, they contact AIOS, and AIOS has a robust team, and once you involve the society, and now AIOS also has this indemnity insurance, so it becomes very easy, and definitely documentation should be there. So AIOS has a strong we did not receive anything, but we are Dr. Digvijay sir, are we in talks with this medical indemnity? I think because AIOS has done yes.
So I just want to add that regarding hospital violence, so one thing is beside everything, there is a group of people who benefits a lot from hospital violence, and they, I don't, maybe in Nepal and in India, is since the culture are almost similar. So what they do is like they roam around the hospital and find out who the patients are, critical patients are, and when the casualty occurs, they go to this kind of patient party and say your relative is gone, the hospital bill is lot. So we will come here and we will deal with the hospital. Your bill will be reduced or will be waived off, but we will do all the talking. And then they start bargaining. So that's one of the reason the hospital are having problem and the doctors are getting beaten up. So we are facing that a lot. So we hope that this kind of things will be dealt strictly by the government as well.
That's an interesting thing, sir, actually, but I don't think we have come across any notorious group like that, or we have heard of any notorious groups like that. But yes, they may exist because people do come out loud in open.
We have an alternate version of this. We have aggregators, like who are trying to make doctors as Uber drivers. So they'll keep the list of all the doctors. They'll decide where the patient goes. They'll give discounts, like you get discount in a coupon in ordering a pizza. So they'll give discount. I want to see a retina consultant. Okay, this doctor charges 500. You go to this doctor is 100. So this is they have made the medical profession a commodity. So which is derogatory, I think, and we are many ophthalmologist forum has strictly objected against that. But some of our own colleagues are going into that because they want patients. But ultimately, you will be their slave because they'll have all the data, they'll have the patients, and they'll decide who gets surgery and who doesn't get surgery. So this will be like Uber driver or Ola driver, you will be like that. So I think that's in the long run, you are the loser if you are joining them.
Yes, one more. So for here in India, for the medical legal cases, for ophthalmological cases, do you go up first to the YOSI, for example, and then raise it to the AIOS? And then from AIOS, does it end there, or do you go up to another regulation commission?
No, basically AIOS is not a regulatory authority. So they are just like All India Ophthalmology Society. There is a group of people like YOSI. They are an association. So they have a strong mechanism in place. They have people who can help you because these are legal issues. You might not understand things which can go against you. So they can help you, and if you can show from a person with high caliber, like president or secretary of a international program, if they say that standard protocols was used, there was a complication, but the doctor tried their best and they gave the best possible treatment for the patient, and there was no delay in treatment, and standard treatment was followed, then court is more likely to listen to that. Yes, basically you are negligent if person with good repute and good practice, they think that whatever you have done is according to standard practice. So if there is a violation of standard protocol, then there is negligence. If there is no violation of standard protocol and things have been done as per protocol, then even if there is a complication, it is not negligence.
Okay, so for us, just interesting, for us, sometimes there is a professional regulation commission or the Philippine Medical Association that would look into the legal aspects of cases. So sometimes if there are problems related to ophthalmology, for example, there's a case against a doctor, an ophthalmologist, so they would get the opinion of the Philippine Academy of Ophthalmology, who will then make its own investigation and then give it out to the regulation commission.
It also happens here also.
So in India, so in India, basically there is something called illegal service providers. Now these are aggregators, like what sir said. Few companies, they have like IMA, Indian Medical Association. They provide you help with the senior ophthalmologist opinion. They provide you help with the lawyers, getting a lawyer, hiring a lawyer, doing all the paperwork. They have a minimal premium. I'll be talking about that. So those companies, they take care of these parallel activities apart from the court case which is going on.
Yes, and also something that I think is nice to know, there have been cases of cataract surgeons who've been, doing illegal cataract surgeries, or they're fooling the patients about giving intraocular lenses that are for example, multifocals, but are not, for example. So there's been cases wherein members of the Philippine Academy of Ophthalmology were suspended from the academy, and then they were not given a recommendation to get a license or like an insurance commission or compensation from the Philippine Health Insurance. So that's something that we do also. Thank you.
Thank you. I think the session was very.
I'll invite Dr. Dipanshu for his talk on financial implications of medical legal issues and professional indemnity insurance.
Thank you, Dr. Kaushik. Before starting, I would want to know if anyone has faced any, like it should not happen, but has anyone faced yet any medical legal case? I think we have one candidate there. And do you know like how much amount do you have to, or was the case in your favor or has it gone against? It's going on. Okay. So I'll be talking about financial implications of medical legal issues and professional indemnity insurance. Basically, why is it required is nowadays there is a lot of awareness among the patient regarding potential complications which can happen, and people might sue you despite the best of your efforts. So we should know why are we burdened that, because it is a high cost of technology is being used in ophthalmology, increasingly competitive environment, and there is a social demand as well. The pressure to progressively lower cost to consumer and to keep costs down, there is tendency to do as many surgeries as possible. So since we have a lot of people here and they might be of different specialities, I'll be highlighting few cases in which court has given compensation to the patient because of if they have found any deficit in the operating system. So this one is from the cataract specialty, where it happened in Madurai in 2018, where 66 cataract surgeries were done and 61 eyes lost vision. The compensation awarded by session court was reduced from 92 million to 22.5 million for victims of negligence in eye camps. And the remarks given was that there was no approval to run the hospital, consent to operate was not taken from the State Pollution Control Board, no proper design and maintenance of the operating room, there was no anesthetist, no pharmacist, no facility to do pre-operative laboratory tests. So these were the fallacies they found in this case, and that's why they had awarded a heavy compensation. In the second case, which happened in Uttar Pradesh, where 88 eyes were operated back in 1989 and all eyes developed endophthalmitis. So in addition to the 5,000 compensation which was given by the hospital authorities, another 12,500 rupees compensation was given by the state government. And they stated that only the camp should only be performed by experienced ophthalmic surgeons registered with Medical Council of India or any state medical council, and the camp should not be used as a training ground. And there should be a pathologist available for routine screening pre-operatively, and all medicines to be used should be of standard quality. Coming to a third case, which is from cornea subspecialty that happened in Delhi in 1993. Patient was advised drops of mitomycin C post-surgery for pterygium, but the patient did not, and the patient kept on putting it for longer time, leading into complication. And they found that it was the guilty of the guilty not only limited to medical negligence for not having put down in writing for how long the drops have to be put. So whenever you are advising medications post-operatively, please mention for how long the drops or medication has to be taken, and a compensation of 50,000 was awarded to the patient. Retina specialty has especially seen a rising trend in these medical legal litigations being filed against the doctors, and they are being like compensation is probably reaching crores. In this case in Chennai 2015, it was first addressed in the National Consumer Forum in 2009, where a compensation of 5 lakh was awarded, and then it was later taken up to Supreme Court of India. It was against the government hospital pediatrician who had failed to inform the parents regarding the ROP screening, and accidentally the child was detected to have stage 5 ROP later on during a routine eye examination. So a heavy compensation of 1.8 crores was given to the parents. This was calculated as past medical expenses, future medical expenses, and mental agony which had caused to the parents, and which had occurred to the parents. And also nowadays it is not just the compensatory amount, they also add the interest from the day case has been filed to the day the final decision has been made. In another case in Hyderabad 2015, there was a reported loss of vision following injection of Avastin, and it led to development of endophthalmitis. Because there were huge quantities of Pseudomonas and Klebsiella bacteria present in the drug, the court said that Avastin is a single-use vial without preservatives, gross negligence in administrative off-label drug Avastin. Both parties have to use the said drug as a single use, but not by withdrawing the drug into multiple syringes. So 5 lakh compensation was awarded. In pediatric ophthalmology, again Ernakulam in 2016, a child underwent squint surgery under general anesthesia, but routine consent was taken and not really an informed consent was taken. Retrobulbar block was given, and anesthesia notes were did not mention about that. Word glyco was used instead of glycopyrrolate. So these were the fallacies they found, and they awarded a heavy compensation to the parents. Another case of neuro-ophthalmology where the patient was diagnosed to have dengue and the patient developed intraocular hemorrhage. Ophthalmologist was informed late, and the doctor presented late, and the patient eventually lost the vision. So compensation of 35 lakhs was awarded to the parents. Now coming to some medical records related litigations. In Mumbai 2018, pre-operative consent form was not taken and systemic workup was not done, and because of that, when the patient developed endophthalmitis due to corneal injury, when they later checked the record, these findings were missing. So that's why they had awarded 25,000 compensation. In another case in Delhi, where it was taken up in 2 courts, it was alleged negligence of the care of premature baby, casual improper ROP screening by ophthalmologist, and the child eventually developed stage 5 ROP. So they almost gave more than 75 lakhs as compensation. So in also last cases of post-op instructions that had happened in 2015, post-cataract surgery patient who was a coolie did not take proper rest or follow post-operative advice, and this was found to be missing in the post-operative notes as well. So a compensation of 55,000 was made. So as you can see, these compensations have ranged from thousands to crores, but despite best of your efforts, you might sometime be found guilty of these in these court cases. So we need to cover ourselves, and because of that, indemnity insurance plays an important role. We recently conducted a survey which we have published in IGO as well. When we inquired the respondents regarding the awareness of the professional indemnity insurance, 82% were aware of the insurance, but surprisingly we found that only 54% respondents do possess the indemnity insurance. So these are some of the companies which people who had acquired indemnity insurance, these are some of the providers which they have taken. Out of this, ICICI Lombard, United India Insurance and Oriental Insurance were the top preferred agencies. Then, as I said, legal service providers are the companies who help you with getting good lawyers, who help you with getting advices from the senior ophthalmologist. They take care of the lawyer fees, parallel activities of the court paperwork, they take care of the all. So you can continue your clinical practice despite having a case going on during your practice tenure. When we asked respondents regarding the ideal amount, so like almost 50% of them thought that it should be 1 crore or more, and that is what we suggest as well. So consumer protection, where we are actually, it excludes, earlier in 1986, it said that we exclude free service from purview of Consumer Protection Act, but Supreme Court has said that doctors providing free service also would be covered under this purview. There is an increase in number of cases, and there has been an exorbitant penalty being charged to the doctors, so it's better to have a good indemnity cover and also take some help with these legal service providers. So you should have you should counsel the patient well, good documentation is important, clear instructions should be given, and a good indemnity cover is important. Thank you.
I think we'll take questions later. I'll invite Dr. Subratanu for his talk and on how to respond to legal notice.
Interview. Okay. Good morning, everybody. My topic is how to respond to a medical legal notice. Okay. Before coming, understanding legal notice. A legal notice is a formal written communication to inform the recipient about the sender's intention to initiate a legal proceeding, making them aware of their grievances, rights, obligations, and potential consequences. It is a very important pre-litigation tool which actually resolves disputes outside the court. And even if the matter goes to the court, it acts as evidence. The parties can settle these disputes to ADR mechanisms, which is called as alternative dispute redressal system, like mediation, negotiation, or arbitration. So do not sway away by the politically influenced people around you or the angry patients that time and try to pay money under the table. This is not to be done. It should be done legal way, that is through these ADR mechanisms. The notices are typically sent through a lawyer and must be acknowledged by receipt or refusal. Even refusal of a notice is considered to be served. The difference between legal notice and a court notice. A legal notice is just a notice sent by one party to another through a lawyer, warning or demand for action. It is not mandatory to reply to those. Ignoring it may lead to further legal actions. Whereas a court notice is a summon by the court to inform them of a legal decision, and it is mandatory requirement. And non-compliance to a court summon can lead in penalties or judgment by default. So how do you respond? The first, you get a notice. Upon receiving the notice, we should stay calm, read it carefully, and understand the demands and timelines. We have to determine from whom the notice has come. It can be through an advocate, through an individual, through a police. A police notice can come through a CRPC 91, CRPC 160, 164, mostly for documentations and evidence, proving evidence. The consumer court can come, it has a time limit of 30 days, the police has a time limit of 7 days to reply. The first and foremost, we have to seek advice from a medical legal counsel, especially if the notice is from a consumer court. And obviously, you have to inform your indemnity provider. Crafting a response, definitely your medical legal counselor will be helping you with it. You should clearly state whether you have to admit or deny allegations, but you should avoid admitting guilt. Remember, avoid admitting guilt or liability without any legal consultation. You should provide documents, plead new facts if you have, and give specific but not evasive responses. You should propose solutions if amenable, like willing to engage in a mediation or ADR resolution methods. You should proofread and send a response in a certified mail and keep a copy to that. Now I come to resources available to young ophthalmologists. So these days, where medical practice and legal obligation converge, the healthcare professionals face challenge of balancing their medical expertise with the legal intricacies. So navigating through this, a healthcare professional should have a well-rounded arsenal of resources. First is legal resource. Access to a specialist medical advice is very critical. To understand the rights of the patients, rights of the doctors, navigate to legal procedures effectively and represent their interests in court. A medical legal insurance is very important. That should be customized to you. All the latest procedures should be covered, and even out-of-court settlement should be covered too in the insurance. The doctor should have proficiency in documentation, like basic counseling, obtaining a valid consent, filling preoperative, intraoperative notes, and should be done according to the standard SOPs. Most of the cases can be dealt in a pre-litigation process by drafting a well-structured reply. Always try to go for an out-of-court settlement. It saves you time and harassment. Indemnity insurance will only cover if it is legislated right now, and if the policy states that it will cover out-of-court settlement, you should go with that insurance. The ethical and psychological support. Ethical resources, various SOPs and guidelines provided by medical boards serve as a moral compass. Like accreditations like NEBH, ISO accreditation actually is benefit for both the professional and the patient. Support from organizations like AIOS, EOC, Legal Cell, State Ophthalmic Bodies, IMA, Medical Legal Society of India, they offer peer consultation and support and reinforce the commitment for ethical practice. The stress associated with medical cases can be overwhelming. The quotation, "My death may prove my innocence, don't harass innocent doctors, please." This is a statement from Dr. Archana Sharma, who died of suicide in Rajasthan. She was a gynecologist, and she was given a case under section 302. We should understand that doctors cannot be arrested in a civil case. The Supreme Court has given under section 302 a provision that criminal liability cannot be put on doctors unless it has been confirmed by a competent authority. Most civil and consumer cases can be set up out of court. And even if the case is there, leave everything to the insurance company, because you have indemnity. The last is having education and continuous learning. You should keep on learning about medical and legal updates. Case studies, the real world case studies should be done. There's good websites are casemind.com, indiaqanun.com. They have a lot of resources. Just type in cataract, type in ophthalmology. You get lot of cases, study through it, and develop communication skills and risk management skills. Thus, the holistic approach of medical legal issues, where strategic and use a variety of resources empower doctors to uphold justice, fairness, and focus on patient care amidst all the adversities. Thank you.
Thank you, Dr. Shubhantu, for covering it so well. I would request Dr. Piali to please come up on stage and deliver her talk. Sorry. Can we take the comments later, because we are running a little short on time.
Good morning. A very good morning to all. I'm Dr. Piali Konar. Before I start, I would like to thank Tripathi sir and YOSI for having me here today. I'll be discussing about medical legal aspects related to violence against medical professionals. We'll discuss the topic under the following headings as in the trends: causes of violence, effect on healthcare professional, how to prevent violence, how to handle the situation in case of violence, and is there a possibility of a legal deterrence. Now, as we all know that violence against healthcare professional is a worldwide problem with detrimental consequences on both the individuals involved and the healthcare system as a whole. WHO defines workplace violence as incidences where staff are abused, threatened, or assaulted in circumstances related to their work, including commuting to and from work involving an explicit or implicit challenge to their safety, well-being, and health. Violence not necessarily should be only physical, it can also be psychological, like verbal abuse, bullying, mobbing, psychological violence, cyberbullying, threat, defamation, etc. Now, what is the extent of the problem? As of now, it's a global problem, and not just the developing nations like India, Pakistan, Bangladesh are facing it. We also have the developed nations like USA, UK, and China are also reporting increasing trend of violence against the healthcare professional. Data shows that in UK, 1/3 of the healthcare workers have faced violence at the workplace. In India, almost 75% of doctors have dealt with one form or the other of violence during their practice. Similar trends we can see in Australia, South Africa, Thailand, and so on. The causes have been very wonderfully taken by Tripathi sir, so I will be skipping those. What are the implications? This leads to unhappy doctors, lack of focus, who make a lot of mistakes, poor job performance, anxiety, stress, depression, psychological repercussions are reported in people who have faced violence in the workplace. Now, prevention is not a one-man's job. Everybody has to work together to prevent the violence in the workplace, including the government, employer, professional associations, and the healthcare workers as a whole. What can the government do? They can issue plans and policies to combat workplace violence. They can revise the existing laws, introduce special legislation where necessary, ensure enforcement of such legislation, launching awareness campaign, and collect information and statistical data on the spread, cause, and consequence of workplace violence. What can the employers do? They can promote awareness, assess the incidence of violence routinely, provide adequate reporting system, develop policies and plans, consult with workers and their representative, collect data and information, and provide adequate information, training, and assistance to those who have been affected. Now, in workplace intervention, what can be done? Increase the staff, especially during peak period or during crisis time. Introduce a management style which is positive and caring. Give the patients and public timely information regarding their patient, and display codes of conduct explaining the obligation as well as right of the patient and their relatives. Provide safe access. Security services should be installed at every main entrance. Checking for weapons should be mandatory. Waiting areas should be comfortable. Activities like reading material should be provided so as to reduce their boredom. Silent alarm system and surveillance camera should be installed. Patient flow and appointment should be tailored to suit the needs and resources so as to avoid crowding, and waiting time should be kept to a minimum. A standard operating procedure should be there in all the clinical establishments, and mock drills need to be conducted where each and every member of the staff should be very clear about their role if a situation arises. Quick response team should be available. What can healthcare workers do? They can contribute toward workplace policy and procedure, cooperate with the employer to reduce and eliminate violence, attend information and training program, report incidences including minor ones, contribute to promoting awareness of the risk of violence, support colleagues who have been affected by violence, and seek treatment and counseling. Professional association like YOSI, IMA, how can they contribute? By incorporating in their codes of practice and codes of ethics clauses concerning the inadmissibility of any incidents of violence at the workplace, promoting the incorporation in the accreditation procedure for healthcare institution and facilities of a requirement of measure aimed at preventing violence at the workplace, encouraging the development of policies and plans at the workplace to combat violence, providing support to the victims victims of violence, including legal aid if required. Now, as a doctor, what more can you do? Do not overreach. Do not attempt to treat and do procedure beyond the scope of one's training and facility. This will either lead to violence or a negligence case. Consent, a valid and informed consent is very important, as it has already been described in the previous presentations. And do not do any procedure other than what consent has been taken for, unless and until it is a life-saving procedure. Proper documentation is very important. This will not prevent the violence, but it will help you in the aftermath of the violence. Communication skill is very important. Improving communication skill will prevent the doctor from facing violence in the long run. Now, how to handle the situation if a case of violence arises? Avoid direct confrontation, remain calm and mature, don't react, but respond with proper authority. Preserve the medical records. Your subordinates should be capable to call the police and your lawyer. Your team members should film the whole event, identify people and give this responsibility, and vacate the premises as soon as possible if the need arises. What to do after the event? proper response plans should be there, reporting and recording should be noted, medical treatment should be given to those who have been affected, debriefing and counseling should be done, management support should be available, representation and legal aid should be given, and grievance procedure should be followed. And lastly, not the least, rehabilitation. Recovery from workplace violence may involve a long period of rehabilitation. Workers should be supported during the entire period of rehabilitation and should be allowed the necessary time to recover, but also should be encouraged to return to work. Now, is there a possibility of a legal deterrence? We had seen during the pandemic the authorities had woken up and they introduced the Epidemic Disease Amendment Bill. This was to safeguard the life of individuals, of healthcare service providers during the pandemic. We can see that in the act of violence definition, they had included obstruction in discharge of duties of the doctor as well as the person who has been, when persecuting a person for causing grievous harm to healthcare service personnel, the court will presume that the person is guilty of offense unless the contrary is proved. However, that was valid only till the pandemic was there. Then we also had the Prevention of Violence Against Healthcare Professional and Clinical Establishment Bill of 2022. However, it was withdrawn because according to the Home Ministry, many of the elements of violence which are defined in the draft bill are already there in the IPC. However, the obstruction to discharge of duty by healthcare professional was not specifically covered. Also, the bill made the violence cognizable and non-bailable, which is also not available in the IPC. Next, we have the Medicare Act, which is currently functioning in 19 states. However, in 11 states and union territories, we do not have any specific Medicare Act has not been started yet. These are few IPC which can be displayed in the hospital and they can act as a deterrent against violence. However, an RTI was filed by the Medical Legal Action Group Trust to see the number of people who have been persecuted under these state acts between the year of 2010 to 2015. And it was seen that nobody has been punished under these state laws, because either the cases were not filed, even if they were filed, they were withdrawn. Because as soon as the doctor files a case of violence against a patient, they do a counter case of negligence. So the doctor gets scared and they reach a compromise and the case is withdrawn. So we can see that though there are existing laws, they have very limited enforcement. So it is unclear how enactment of a special central law would better address the issue of violence if existing state laws and IPC have limited enforcement and structural issues in the Indian criminal justice system are not addressed. The fact that existing provisions of IPC or similar laws that currently exist in Indian state have seen limited enforcement also point to the limited value in deterring act of violence. Therefore, unless structural factors like underlying causes of the violence and enforcement of offense by the police and timely persecution by the court are addressed, a targeted law with higher punishment is unlikely to effectively deter violence against healthcare professionals. Thank you.
Thank you, Dr. Piali. That was very extensive. Thank you so much for being part of it. I think we have come to the end of the session. Quick comments from the chair and co-chair.
Thank you. I think 45 minutes is not sufficient. So interesting topics, and in the third presentation, financial implication. So very interesting. Case 1, case 2, case 3, case 4. Everything interesting. And what I think, like in case 4 retina case ROP screening, I think these kind of things should be better addressed, and we as an ophthalmologist should better communicate with pediatric societies and show them the importance of ROP screening. This is a very, and I think ROP screening should also be included in immunization during that period. So just 2-3 questions, then they can know how to refer. And regarding case 5, I would like to inquire whether who was prosecuted, because it was because of the pseudomonas in the medicine. So was the doctor found guilty, or the company, or who was found guilty?
So this is an interesting finding in St. Joseph case. The Ringal lactate had pseudomonas, but the makers of Ringal lactate, they sold another batch, and that was not having pseudomonas. So the court absolved them of any wrongdoing. So this is how justice works in India, and the court and basically the hospital and the doctors were penalized.
Okay, so I want to proceed. Like in presentation number 4, how to respond to legal. So I would
Dr.
like to
Subramanian.
know what is the difference between legal notice and court notice, because I always thought that it was almost similar.
No. Legal notice is just a communication between the parties. It is not mandatory to reply. There is no time limit also. But it should be replied in specific terms. But a court notice is just a summon to call you for any legal proceedings or to show evidence, and that should be complied, because that is a non-compliance leads to a penalty or a judgment against you directly. So that is mandatory. Court
What's the difference between, you said that don't pay the money, right?
Yes.
First hand.
Yes.
But then what's the difference with outside the...
outside court settlement is, it's a legal procedure.
Legal.
Where there is a dispute mechanism, alternate dispute mechanism. Actually, Supreme Court says that there is so many cases lying around. If there is no alternate sort of mechanism to dispose of cases, the Indian system will be like hanging out. But every time there's a lot of cases coming out, if some of the cases get solved outside the court in a legal way through arbitrator, that is the best possible outcome for the Supreme Court. That's from the Supreme Court judgment.
Okay, thank you. And in the final presentation, very interesting, since I'm also involved in Nepal Medical Association as an executive member, where we have been forced to recall all the doctors from a city because the doctors were in threat and the government, the local government would not respond properly. So I think the mock drill, we are lacking in that. And I think now what, not only the Ophthalmic Society, not only the YO, but the Medical Association also should focus on mock drills.
We have in the NABH accreditation system, we have code violet, in which is for violence, and mock drill is mandatory for all the institutions who are getting NABH accreditation. So the accreditation procedure should incorporate this as in their code. And also the government should take active interest in this, because this is a rising trend these days.
Dr. Chris, would you like to? Dr. Akruti, Dr. Mosmi.
Hey, no, I just like to say that this is very interesting. There are a lot of good discussions here. One thing that I learned is here in India, it's required that the doctors would have indemnity insurance, and we don't have that in the Philippines. So that's something that I can bring home, and tell them. So thank you. We learned so much here.
So doctors have to pay out of the pocket?
Yes.
Okay, all right. Mosmi?
So one more thing, just as you spoke that negligence and complications are two different things, right? But most of the cases are because of secondary to surgical complications and patients are unhappy. So my question is, if everything is followed properly and the results are in favor of the doctors, then does the doctor get the compensation? Or is it like...
There's no compensation awarded to the doctor. But
will be providing best services and there will be no complication. This is the rule. You are not getting compensation for that. Your professional satisfaction is the compensation, और कुछ नहीं है उसमें.
Dr. Akruti, you want to?
One last thing I wanted to say is it's not just indemnity insurance for ophthalmology. Since I practice oculoplasty, if you're practicing aesthetic surgeries, then you need to take special premium indemnity insurance for that as well. And also with time, you learn to pick up, not like Dr. Kaushik said, that every patient is a litigious patient. But with time you learn to pick up which patient is likely to be unhappy. A patient with unrealistic expectations or has gone to multiple doctors prior and is criticizing everyone is a patient you should try to avoid intervening in, and probably say something like, I may not be the best person to manage you or deal with you. That would, although it can happen to the best of us litigious cases, but that could be a way to minimize the damage and reduce the chances.
Thank you, everyone. I would like to thank our international delegates, Dr. Tetsu and Dr. Chris, for accepting the invite, and also Dr. Akruti, Dr. Anujit, who is not to be seen, and Dr. Mosmi for being the panel. Can we gather for a group photo, quick group photo, and later mementos, please?
Invite the people on the dais for the next session to come in who are with me. Dr. Madan Gopal, Dr. Azam,
Can we have the mementos?
Dr. Sufyan, and Aditya. Dr. Ashraful has not been able to make it, unfortunately, due to visa issues.
Our international delegates will get their mementos in the inaugural ceremony. Can I request Dr. Tetsu to hand over the memento to Dr. Agriti? Dr. Akriti, can you collect your memento, please? उनको दे, Dr. Tetsu को दे. Dr. Anujit, can you collect your memento, please? Next, can I request Dr. Chris to hand over the memento to Dr. Mosmi Banerjee? Photo, please. Can you take the photo? Next, I would request Dr. Shubhrantanu Chakrabarti to please come and collect his memento. Ma'am, can you stay back? Dr. Chris, can you stay back? Dr. Chris, can you come back? We have a couple of more mementos to give. Next, I request Dr. Piali to please come forward. Ma'am, can you stay back? Dr. Chris, one last. Sorry. Thank you, everyone.
Big hand for the Panshu and medical legal team. So after a very nice session on medical legal aspects in ophthalmology, we have what really gets you into trouble nowadays. It's called the first session of live surgery. I would call on Dr. Digvijay is already here. Dr. Azam. Can we have Dr. Azam? Sir, please come. Would like Dr. MVG please come on the dais as well. Dr. Sufyan. Dr. Ashraful didn't make it, as sir already pointed out. Karan, you want to come sit? Come. We'll get more, get you to stick around for longer. So we have a great battery of speakers here. We have Dr. Raghav Malik. Raghav, come in front, please. We have Dr. Bhupesh. We have Dr. Karan Bhatia is already here. And we have Dr. Dipankur. I would request all the speakers to come in the front, please.
So for the first talk, we have Dr. Aditya Sethi, who will be speaking to us about enhanced depth monofocal IOLs. Over to you, Aditya.
Thank you, sir. Can we have the slides, please? All right, so all of us use monofocal IOLs, and a lot of our patients in 2024 demand little more than just monofocals. And sometimes the answer to all of that is right in front of us. So I'm going to talk about greater degree of spectacle independence for intermediate tasks, enhanced monofocals. So advancement in IOLs has been happening for a while now, and we are all using what we so call as premium IOLs. But now the treatment option catalog has grown even more. And we have these diffractive, bifocal, trifocals. We have accommodating or pseudo-accommodating IOLs, which are yet the latest version of accommodating yet to hit the Indian market. We have the EDOFs. And now we have something which is already tried and tested, but a little bit more, something called monofocal plus or enhanced monofocals. So let's talk about that. So again, there are different types of category of IOLs which are there, but what really catches the eye nowadays is the tried and tested monofocals, which are giving a little extra, which is called enhanced monofocal, with an idea of trying to get your patients a little more intermediate vision friendly, because everybody uses their phone in as simple terms as that. So it's a personalized approach. This talk does not generalize that everybody should get this particular IOL. There is no one size fits all. We are playing around with focal points, and we are playing around with ranges of vision, so we have to be careful whatever we are advising. So a lot of chair time with your patient really works. And what you, in the end, it all boils down to Snellen's acuity versus patient satisfaction. Monofocals, the benefit is they are age-old, tried and tested versions of care provided already. And what's more impressive are they are nowadays available is enhanced monofocals. So pre-op evaluation is still the ultimate. Patient visual goals. Do they really want spectacle independence, or are they happy with getting what is usually tried and tested? And maybe you can give them a little cherry on the cake. Wherever there is a compromise, wherever you add a specific layer, there's a little bit of compromise, and that compromise is acceptable to the patient. This is the question you have to ask, and always educate everybody around you, the patient, the staff, and your colleagues. So prerequisites, an accurate biometry is required. You have to look at the ocular surface. Trifocals are a rare breed nowadays because they require very healthy eyes. EDOFs can be a little more forgiving, but enhanced monofocals may be the ideal recipe. So enhanced monofocals, are they coming back in vogue? Has the circle completed, and monofocals have still become very important, because all we are trying to do is we are trying to expand the patient's horizon. So the scientific difference, this is well documented that distance monofocals are the best. EDOFs and trifocals do well, but they're not as great as monofocals, and intermediate enhanced monofocals have been giving good results here as well. Whereas near is something where you use a trifocal, which is a clear choice. Halos and glares, of course, with the monofocals, enhanced monofocals, is much more negligible because of this design and how it's made. So this is my approach to every patient. I ask what is the patient's current refraction. If they are myopic or hypermetropic, I base my choice of IOL right there. What are the patient's post-op visual goals? You have to sit down and speak to them about it, because otherwise you'll be making a mistake which can lead to your previous session, which is medico-legal aspects. And what can the patient afford? Again, the benefit of enhanced monofocals is the affordability is great as compared to the more so-called premium IOLs. And in the end, it boils down to what the surgeon feels great in his gut. So what we are here to talk about is the Impress IOL by Vivinex platform of Hoya. And this is, it's already got the Vivinex platform. We've all used it. We all know how good that is. It's a hydrophobic material with UV and blue light filter. It has a C-loop design with texture rough haptic surfaces. And the injector is just awesome. It's basically an enhanced monofocal technology, which is basically a novel aspheric design tailored for improved intermediate vision, and that's what we are aiming at. And it gives a wide range of focus as compared to a monofocal, but not so much that the patients will complain of side effects. So in short, a standard monofocal will give you X amount of that. This will give a little bit more towards the intermediate side. So formally, it has a 1.62 millimeter base spherical surface, and this is on the recent EMY design. It's basically a transition zone which gives us a focal range around the monofocal area, focal point, and this provides a superior intermediate vision performance compared to a standard monofocal. And the incidence, you can see the zone right there. The incident intensity of photopic phenomena is similar to seen with monofocals, not beyond that. And the anterior surface, you have that central 2 mm zone, which gives an optical element with a smooth surface profile, which is ideal for almost all your patients. So this is how it improves. At 66 centimeters, there's a minus 1.5 diopter defocus, which gives a more than one line. And we always target a emetropia in these cases to get ideal outcome. And this is how the thing fares in basis of chromatic aberrations, and it gives great contrast even in intermediate zone. This is the injector. This is the favorite part. My favorite part about this lens is how amazing and how repeatable this injector is. And if we've all used it, you have both the two-handed technique and the single-handed technique to use this. This is what comes with the lens. You have the A constants. There's a way of modifying your A constants also available, and you have personalized A constants available, so it makes a great job. A quick indication of why I love this is because of the injector. See how smooth. This is absolutely an unedited video, and just see how beautifully it goes, and it's repeatable. Every time it's repeatable to get the same with this platform. And this is a case that I can share with you. That's the first post-op day where the patient was operated for, and within a week, this patient with a micro monovision actually did really well, even for near, which is a bonus. So I have impressive results with this Impress, and it's something that I make a repeatable practice in my practice. And of course, you have to have the correct intraoperative pulse that you need to do, and listen to your unhappy patients and answer them with these lenses. So that's what I would want to end with. Thank you.
Thank you, Aditya. So what's the counseling that you do for a patient? What is his expectation setting that you do?
Yeah. So I think like I showed, I like to ask the patient what they want to achieve post-op. I do not sell them a dream. I sell them reality. I always tell them that, okay, these are the side effects. There's no perfect lens yet. If there was a perfect lens, we won't have a battery of them. We just have one of them. And that makes my job easier. The qualification I would go with for an enhanced monofocal is, I always tell them I'm going to implant a monofocal. I don't talk about the intermediate vision. So when that comes, it comes like a cherry on the cake, because the pricing lets you do that. And I think that's the difference between this and other premium lenses.
Thank you, Aditya. We have the next.
Yes. So that very interesting, very good presentation. So in terms of financially, how does it affect for patients?
So most of the hospitals that I know, they place their monofocals at around, I would say 35,000 to 42,000 rupees. The enhanced monofocals come with an additional bump of about 3 or 4, 5,000 maximum. So that extra benefit that comes with it is something that makes you
very much pocket friendly, I guess. Right. Thank you.
And with regards to biometry, any specific thing you'll be looking at, and what would be the IOL you would like to have?
Yeah. So I think enhanced monofocals are the most forgiving, closest to monofocals, I would say. So they tick all the boxes when the patient is concerned. What I like to do is I also like to personalize my A constant. There is a website called YOSIcon. I feed in my data. I get personalized A constants for each IOL, which is there in the market. I use that. That makes my emetropic target much easier. I also, in a lot of cases who are, say, a little more greedy like me, those patients, I decide to do a little micro monovision shift. So I aim at a -0.5 in the other eye. So that is something that I also do.
Do you use a optical?
Yes, yes, sir. We use
what power do you use, the emetropic power or first myopic?
I prefer to do a emetropic power in the Impress. It changes with the other lenses as well.
Yeah. All right. Thank you, Dr. Aditya. We'll now have Dr. Raghav, who's going to speak to us, who's also going to impress us about the YOSIcon Impress. Come.
Thank you, Dr. Karan. Good afternoon, everyone. I'm Dr. Raghav. I'm from Center for Sight. I will be showing you a short surgical presentation with the implantation of the Hoya YOSIcon Impress. So just to start with the surgery, this was a 56-year-old female who came to us with a painless diminution of vision, and she wanted better vision. So she had a cataract, so we started her cataract surgery, a grade 2 cataract, not very hard. So the patient was a housewife, just wanted to go for daily activities. She did not want a trifocal lens. She did not want to spend so much. So we thought of going ahead with the Hoya YOSIcon Impress. So I start with the surgery. The surgery itself is a routine cataract surgery. I go in with my side pods, and then we prefer using Ocuron or phenylephrine for all our cases. So that gives us a little bit of more anesthesia during the cataract surgery. Once we do that, the patient does have the patient says that meko thoda bharipan feel ho raha hai. So that is when you know that the patient has been anesthetized very well. We go in with a viscoelastic. I prefer doing my rexis in retroillumination. So once I have the retro on and I am focused on the capsule, I start going in with my bimanual technique of rexis. With my left hand, I do tend to stabilize the globe, and then I go in with my cystotome, and I'm aiming for a 5 to 5.25 mm of rexis. The rexis, yes, is very important. Let's say you do have a complication. If you do have a sulcus, you are always safe. You know that you can put in a 3-piece lens. So this is definitely one of the most critical parts of the surgery. So you see that the capsule is getting a bit tangled there. So I try to use my second instrument and I detangle the capsule and complete my rexis. The rexis itself was easy. Once that is done, then I always, if I have a grade 1, 2 or 3 cataract, I always prefer doing, so this is a 2.2 millimeter keratome, and this is important why once I go into the implantation of the lens, that will come into play. I'll explain why. So I make the incision, and then in all my cataracts grade 1, 2 and 3, I prefer doing a hydrodelineation first, followed by a dissection. What that does is that it gives me a very good nucleus to chop. So now I go in and I do my delineation. So you can see a very beautiful golden ring that just forms, and with that I know where my nucleus is. I can chop that easily and do a dissection. I don't need to rotate the nucleus because I know I've got a good delineation. Once that's done, I go in with my phaco probe. I use not a very high setting for this case because it's not a very hard cataract. So I go in with a vacuum of a 380 to 400 and a power of about 35. I do a direct chop. That's what I've learnt. That's a chopper I'm using. I go in. So I just bury my probe, eat the loose cortex, I bury my probe into the center and I go from the mid periphery and try chopping the nucleus. I fail the first time, but then I continue on and I can see a pretty decent chop. Rotate the nucleus 180 degrees, complete that chop, and immediately once that is done, you can just pick up that heavy nucleus. So you see, with that same thing, I go into the quadrant mode and I just pick up that nucleus, and it's pretty easy, not a very hard cataract, grade 2. This is all unedited, it's real-time video. The other heminucleus I can pick up pretty easily, and because of that delineation, you can see how clean the chop is, and also with the dissection, the epinucleus also comes along with the cataract. So that's the phacoemulsification, and once that is done, I again go back to my retroillumination mode and I do my cortical aspiration. I use the coaxial. So the thing with coaxial is that if someone is starting new, what I would suggest is go under the capsule and make large curves and large pickups of the cortical place. So you see, I'm going under, I'm making large sweeps. So what that does is that gives us a second wave of dissection, and once the cortex is loosened, it's pretty easy. So in this particular case, you will see that once the cortex is removed, there is a small piece of cortex that is stuck on the posterior capsule, which I will remove. So subincision is the one that creates the most problem, but once that is taken care of, so you see now there is this plate that is stuck on the posterior capsule. So what I'm going to do is I'm going to go into the polish mode and I'm going to just peel that off. You have to be careful because otherwise punching the capsule is pretty easy. So remove that and I go into the polish mode again. You see that fiber which I have to clean. If I don't do that, the patient will not have any problem. He will be 6/6 the next day, but he will have an early PCO. We try and polish the remnant cortical fibers. So now coming on to the best part, that is definitely the injector system. So once I put visco inside the capsule, it's a pretty decent and round capsule rexis. So now this is a preloaded lens, and getting the lens ready is pretty easy. So you see, this is how first you fill visco in that well. You fill visco up to a dotted line, but I tend to overflow it. So you see, once the visco is done, then you remove the clipper. Sorry for this being decentered, but you remove this clip, and then there's this plunger over here which you just push towards the center, and the lens is now ready. So this is, you can go with a sub 1.8 mm also, you can go in with a 1.2 also, that's why I said my keratin was 1.6, so it was 2.2. So once I put in the injector, this has a both, it has the push as well as the twist. So once I go in, you can see there is still so much space. And the advantage is there is no wound damage with this injector, and you can do a very easy in the bag implantation. Just see how in a control where the lens is coming out and the lens goes straight into the bag. That's it. I just do a visco wash and the surgery is done. I don't need to go with my second instrument or push the lens. So it's actually very beautiful surgery. Once you put the lens in, I just go and remove all the visco, and I tend to go behind the IOL also to remove some of the visco. So till now at Center for Society, we've had about 900 plus implantations of the Impress, and we've got about 97% patients who get 20/20 at day 1, and 97% get 20/20 or 20/25 at 66 centimeters. So, so you asked whether you counsel the patients. So our practice, all our patients, our go-to lens is a monofocal plus. We don't counsel the patient, we don't tell the patient we're going in for a monofocal plus. So it has cannibalized our practice for monofocal lenses as such. We don't tell the patient that you're going to have any change in the intermediate vision, but what we've noticed is that yes, patients are now requiring only a 1 to 1.25 near ad. From 3 they've gone down to 1.25. And also we've also noticed that patients, like in this lady, her non-dominant eye was done with an Impress a week back, and I've just done a small monovision, and this actually works like a trifocal combination. The patient is spectacle independent just with a micro monovision, and no photic phenomena. Patients are very happy, and also the patients are very I would say adjusting to a small remnant residual spherical error also. If we do tend to leave a minus 1.25 also, the patient will not be complaining. With that micro monovision, the patient is very happy. So thank you.
Do we have any questions for? All right. Thank you, Dr. Rahul.
Thank you.
I'm going to have Dr. Bhupesh, who's going to talk about getting rid of glasses completely with a trifocal IOL, and he's going to talk about those patients who push for even the near. So Raghav, I have a question. What is your, I would say, tolerance for a toric version of enhanced monofocals, and what's your experience with them? Because Impress is yet to come, but in other enhanced monofocals.
So yeah, that is something that we are waiting for. Once we do have the toric version of the Impress, again, it should be a very big game changer. Why? Because now we have gone down to 0.75. Even patients who have a 0.75 diopter cylinder, we are going in for toric lenses. So yes, that 0.75 to 1 is the one where you think of whether you want to go for a toric lenses. But yes, those 0.75s also are doing very well, because if you can give your patient the best vision, why not? So if you're giving the patient intermediate vision as well as toric correction also, the patients do very well.
Thank you, Raghav. Over to you, sir.
Okay. So, hi friends, I'm Dr. Bhupesh, and I'll be speaking on trifocal lenses, and thank you Yosi and thank you Karan for including me in this wonderful program. And so this is a frequent situation that we encounter nowadays when your patient demands complete spectacle independence. So what you should do? So the answer is trifocal. So no financial disclosures in the project. So the vision with the standard monofocal IOL is like this. You see distance vision very clearly, but you cannot see computer, you cannot read your newspaper without glasses. So ultimately you need something more than independent standard IOLs. So with the change in the profile of patients now, older patients are also involved in these kind of activities like photography, painting, golf and all. 10 or 20 years back, the patient is 65 or 70 years of age used to play with their grandkids, go to the garden, walk in the park, and that was their standard daily routine. But now 70-year-old patient also work on the Facebook and Insta, watch videos and play all sort of sports, photography and everything. So with the change in the need of the patient, you need to change your IOL. And this is the most common thing, taking pictures with the phone. So if you are taking the picture with the phone, either you have to focus on your phone or a distance object. So the main problem comes here. The surgery, that point should be clear to the patient before surgery. Always explain the pros in detail and cons in some limited words. Otherwise, if you explain the cons similar to pros, patient will not go for trifocal anyways. So always the rule is under promise and over deliver, so that your patient will be happier with the results. This is an interesting chart that I found in Google while making this presentation, and this makes your job very simple. If you divide the patient depend on their needs and then choose the lenses, like if the patient wants complete independence, you should go for EDOF or trifocal, and then see patient is driving, non-driving, what is his profession, what are the things that he routinely does. If patient is not considering monofocal independence completely, you can go for monovision either, or can go for monofocal plus or enhanced monofocal. So this is the thing. And then coming to the trifocal that I am doing from last 1 year is Vivinex Geometric IOL, and this is a wonderful lens, as Hoya is always known for its good quality lenses and with the best quality injector system. I am really impressed with the results of Vivinex Geometry. And if we talk about the different parameters of these lenses, the optics is trifocal, spherical aberration correction, and it's tolerant to coma, and this lens also has a toric option, so you can so toric is a very important aspect of any IOL practice, whether you're going for monofocal IOLs or going for EDOF or trifocal. If you are seeing that patient is having astigmatism more than 1 diopter or up to 1 diopter also, always consider toric option to give the clear, crystal clear vision. And the material is hydrophobic, the trusted material, and this is a glistening free, and opacification is almost nil. This is a C-loop conventional design, 13 millimeter diameter and full 6 millimeter optic. And this has a preloaded injector system that goes with 1.6. So if you are doing your surgery with 1.8 or 2.2, you don't need to enlarge the incision. Enlarging the incision means inducing the astigmatism. If you're not enlarging, that means you're reducing the astigmatism or at least not increasing it. So these lenses comes in 2 varieties. One is geometric and other is geometric plus, and both have similar ads, 3.5 for near and 1.75 for intermediate. This lens has truncated diffractive optics in the central anterior 3.2 millimeter zone, and this also has a proprietary spheric optic design for improved image quality. So they have the patented truncated design, and this is a negative aspheric lens so that it corrects positive corneal spherical aberration. So most of our patients have positive aberration, so it's always better to use negative spherical aberration to compensate that positive spherical aberration. And 3.5 and 1.75 add. This is a chart showing the MTF functions at 3 millimeter and 4.5 millimeter pupil size, and you can see there is not a much difference in the image quality for distance, near and intermediate. This is a graph showing the contrast sensitivity, and this is also good at both the pupil size in a daylight condition or in a dim light conditions. You can see excellent near vision in good light, distance dominant vision in low light, and low level of nighttime dysphotopsia with this lens. And coming to the light distribution, you can see with geometric lens, the light distribution is 50.8% for distance, 17.3% for intermediate, and 21.8% for near. Whereas with the geometric plus, the distribution slightly changed, and for distance is 39.2, 16.9 for intermediate, and 32.8 for near. So in geometric plus, they have increased the light distribution for near vision. So if you pair these lenses, the patient can see good distance as well as good near at the same time. And this lens provide excellent lens stability in a toric version. The studies have shown that the rotation is around 1.1 degree, and so excellent lens for toric conditions also, or astigmatism conditions also. And this is a defocus curve at 4 to 6 months, and the studies have shown excellent results in all sort of vision. So so they have compared that whether you're going for geometric with geometric plus in one eye, or you can go for both eye geometric, or you can go for both eye geometric plus. In all the 3 combination, the results are similar. So you can choose anyone depending on the need of the patient, and these are the different parameters of the lens. So in the end, the very important feature of this lens is the injector system. We all should know, if we have not used Hoya in our practice, we should try this injector. This is a wonderful injector system. Can you, why video is not playing here? So you have to inject the viscoelastic here, and visco has to go up to the nozzle, tip of the nozzle, and once it is filled, this is the step 2. All the numbers are mentioned, so there is no confusion which step has to be done first, which step has to be done last. So it is nicely mentioned there. So just remove that plunger and then push it, so that lens will be loaded in the front part, and then you have to lift the lens. As already discussed, this lens has a pushing as well as screw system, and just you have to push the lens, and the opening is very smooth and very quick and gentle. So excellent lens, and we all should try Hoya trifocal lenses. Thank you so much.
Any comment on trifocals from the panel? Anybody in the audience has any questions so far?
So I think Karan will tell the surgical parts now.
When it comes to trifocals,
Yeah.
when it comes to trifocals, even if the patient wants a trifocal, there are some patients who really don't, get used to it because of neuroadaptation. Are there any, points that tell you in the OP that, don't go for trifocal even if the patient wants it?
So if patient wants trifocal and there is no contraindication of trifocal, we should give trifocal. The rule that I follow in my practice for trifocal as well as for EDOF lenses, always listen to the complaints and ask them to wait. Almost every patient gets settled in next 3 to 6 months time. I have not seen any patient that comes after 6 months saying I'm not happy. Patient complain initially, every day he'll call you, he'll come, he'll message you, I'm not happy, I'm not happy. Just keep telling them, just wait for a few weeks, wait for a few weeks. Every time change some lubricant, change some medicines, and past 3 months or 4 months, patient is going to settle down. So that's my practice pattern. Thank you.
So our next speaker is the dynamic Dr. Karan Bhatia, who's going to show you how the surgery part of geometric is. So Karan, would you like to say something before you start operating?
Just a second. Lunch is from 1:30 to 2 p.m. Okay, it's outside where the tea was there. So let's get straight to it. Dr. Bhupesh has already told the details about the geometric IOL. So it has a beautiful injector system, as sir has said. It has got about a 6 mm optical zone, and out of which the central 3.2 millimeter is the diffractive zone, which has got about 4 pairs of rings, meaning 8, and the periphery is about 2.8 mm is the refractive zone. The injector is one of the beautiful things. Now this haptic also has, the haptic has roughened texture, and the edges are also, it's got a roughened texture and the edges are also rough, and the optic also has a roughened texture. So because of this, what happens is it gets a very good rotational stability for the IOL. Let's get to the surgery straight up. So I prefer to make my incisions with the MVR knife. It gives a much better incision, and I use 2.8 mm incision for my entries because I use the Laureate machine at my practice. I use the two-hand technique, and I prefer to make the incision first, and then I don't want to remove the OVD inside. I use HPMC in most of my surgeries. This is the bent 26 gauge needle to a cystitome, and mostly all of us are doing this. The rexis under the OVD, and it's fairly easy to be done. So you want to have a good central rexis of the ideal size. Then follow this by a hydrodissection and a delineation. So I'm using a 1FR microscope and a 1FR Pro microscope. I slide tight to rotate the lens. Very rarely I go in with the dialer at the stage, and as Raghav was doing this, I also do the same thing. I increase my flow, or I turn on my irrigation after going inside the eye, a direct chop, and similarly on the other side. The settings are about 45 power, about a vacuum of 360, and a flow rate about 30 to 34. So this is a fairly NS2 grade cataract. This patient was about 62-year-old female coming from Noida. So Noida patients are also coming to Meerut. So very simple surgery, not a big deal at all. Using the epinucleus mode, ate up this epinucleus. All done part, fairly simple. Once this is done, OVD was put, and this is when I just loaded the lens. Sir has shown beautifully how to load the lens, or it doesn't take any time, it's very effortless. I use bimanual IA for all my cases. The IO was done, and I do a good central polishing at least. This patient had a slight PCO. I decided to go in with this trifocal lens, the geometric one, and I felt, and the patient was very comfortable post-op, did not have any problems. N6, 6.6, that was the visual acuity. So this injector system is beautiful. I really love this. This is the best injector system, I would say, in the market that is there. You can directly implant the lens into the bag. You can see the rings are very nice. And I'd implant all my lenses under hydroimplantation except the 3-piece lens. So I don't use visco apart from one or two steps in the surgery. So since I have done a hydroimplantation, I don't need to go behind the IOL and wash. Somebody please take a picture of mine as well. So and this is done. Remove the whatever OVD came out with the lens, and hydrated the wounds, and then the surgery is done. Yeah. Any questions? Yeah.
So thank you for completing it well in time and helping us catch up questions from.
Hi, Dr. Karan. The lens is beautiful, but your surgical technique is so efficient, I will say.
Thank you so much. Thank you, Dr. Asam.
Thanks, Karan. With your skill, I don't think you'll have too many complications, but just in case, what are the words that you would use in case you had to, go for a lower lens? I mean, you had to put something in the sulcus, something else was promised and something else had to be done.
If there is space in the bag, if I have a rim, I would put this.
Okay, this goes into the sulcus as well.
In the bag.
In the bag.
If there's a rim where I can put the haptics inside, I would put it in the bag.
Okay.
I have done with torics also. A lot of Hoya torics that I've implanted. I had a very bad rent in a mature cataract with the grade 4 nucleus. There was a posterior extension from the rexus, but still I managed to implant in the bag. The IOL is very stable. In fact, the other eye I have put a monofocal, non-toric. He's much better in this eye. Where there was rent. If only when I don't see that the capsular support is good enough, that is only when if I can put a monofocal, if I can put a single piece lens, I will not change the IOL. If it's only when I have to put a 3-piece IOL, that's only when I'll change it. Does that answer the question, sir? Yeah. Okay. So thank you.
Okay, thank you, Karan. I now invite Dr. Aditya to speak to us on IPCL, the new revolution. So we are getting to see a lot of the, a lot of the latest here.
So before I start, I would like to ask how many of us are doing phakic IOLs, ICLs and IPCLs? Great. So I would expect by next YOSIcon everybody's hand to be up, because this should be that inspiring. All right. So I think the market for ICLs and IPCLs is increasing day by day, and most of our patients are very conscious of their glasses, and they want to get rid of it. And a lot of cases now are coming up with a lot of dry eyes and other areas where you wouldn't want to do a refractive procedure. And in those cases, I think the use of an IPCL makes all the difference. And yes, IPCL has been available for a really long time, since 2014, and its level of customization and ease of injection makes this a very favorable choice for all of us. It's available globally almost everywhere now, and we have IPCL users in different parts of the world. The design makes it one of the most appealing factors of this particular lens. It has a unique design with a central thickness of as low as 80 microns and 0.08 millimeter interface, reducing scattering of light. and this has a central hole of about just less than a 0.38 millimeters diameter for good aqueous flow, and the water content is as low as 26% in these lenses. And it's available in a lot of powers, and often they customize it to the level that other companies may not. Again, the design advantage, the vault size and everything is very efficient. The central hold is there, which prevents any sort of scare that surgeons generally have with ICLs of glaucoma. And there is less light scattering, and that gives greater visual outcomes for the patient. So the design is where we are focusing today, and the version 2 actually makes the white-to-white errors that you would generally be very scared of making more tolerable, because if the white-to-white is even less than actual, the lens will not undersize because of this design, and it will fit beautifully in the space provided in the sulcus. And if it's even more, it will not oversize to at least the wall size may not change even more than 10 microns. And aqueous flow does not get interrupted because of the prevalence of the central hole in these cases. It's specially engineered with haptic pads, which has a spring effect, and when you see the live surgery next, you'll notice how beautifully it unfolds right where you want it to be. Because that's the scare for most of the beginner surgeons, that it should not unfold in a very harsh manner and cause damage to the lens capsule, and that's where this trumps. So it's made of high biocompatible material, and it mimics as close to possible as natural tissue, and even in some extreme cases where there can be touch, it will treat it like a body tissue, and there'll be less chances of any sort of capsular cataract. Alright, so I'll skip this video. I think it's not working. So the surgical technique is you make either two paracenteses, you inject your viscoelastic, giving yourself ample room. You do. I generally prefer a temporal clear corneal, and you can make it as big as 3.2 millimeters for ease. Then you inject the IPCL, which is very, very easy to load, unlike its competitors, where loading may be a task. You can position it beautifully behind the iris, and then later on take your time in doing a good INA. Surgeons often implant it under hydro as well, so that's something that you may do after you've done certain amount of IPCLs. You can go to the next level and implant it in the hydro. So again, loading is very simple. Like I said, IPCL is injected through the injectors. The cartridge requires a sub 2.8 millimeters. For the beginners, I would suggest go for a 3.2. You mark it, you orient it. Easy to load like you would load any other lens, and injecting system is also very similar. Let's try this. Okay, not happening. All right. I'm sorry for the glitches. So in all, I think this is one of the favorable choices for all of us when we think of correcting our patients with any ICL or IPCL or phakic lens. And this does a great job in producing repeatable, efficient results. It also comes in toric versions. And the design of the toric version makes it that you don't really have to align it. It implants exactly a 0-180 axis. It's customized for that thing, so there's no chance of any getting it wrong with your rotations, or even the rotations post-op are very negligible. And now we have something called the presbyopic IPCL, which I think fits beautifully in that segment of 38 to 55 age group, where patients are looking for independence of glasses at that age. They've never owned glasses and suddenly are prolonged to a progressive glass. So in those cases, this works beautifully. It has a bifocal apodized system, which gives us great intermediate, decent near, and amazing far. So it takes care of the entire range of vision like a trifocal would, without actually doing the cataract surgery, and gives great results. And it's been compared with implanting or RLEs, and it says it's got decent results comparatively, and it's, I think, a very good stepping stone for these patients. And I'm very excited to try more of these presbyopic IPCLs in my practice. and the scattering halos and glares are less than a trifocal or at par with a trifocal that you would have implanted otherwise by doing a more aggressive refractive lens exchange in these cases. I would stop here, and I think the next surgeon will take care of the surgical part of it, of the whole procedure, and justify about using IPCL in your practice. Do I have a video? I can try. So somehow the videos have decided not to work. All right, I think we can take questions. So what about the panel? How do you do RLEs and or do you prefer an IPCL? Do you think presbyopia IPCLs are a good option for this age group rather than doing a early RLE?
Honestly, I don't have much experience with presbyopia IPCLs.
Yeah.
But what would be your cutoff for an IPCL in general?
So yeah, so we do wide to wide measurement. We look at the
refractive wise.
Refractive wise.
Yeah.
Refractive wise. I generally prefer in high myopes. In hyperopes, of course, the ACD is very low in most of the cases, so that they get excluded. Yeah, I've started doing it in high cylindrical cases. With dry eyes, I give them a treatment for dry eyes for a long time. With the lenticule-based procedures, that has become more favorable now. But yeah, IPCLs I feel are being implanted more and more because I think it's easier for most of the surgeons to adapt to it, and both financially as well as the outcomes are very favorable.
Okay, I have a question for you.
Yeah.
If you are recommending IPCL, why not recommend for them to go for refractive lens exchange instead?
Yeah.
What would
So you're talking about the age group between 40 to 55.
Yes.
I think a lot of patients are now mentally there to get a cataract surgery. So when you're speaking to them and you say, okay, it's like a cataract surgery, and then that particular stump hits them. So they are in a dilemma whether they require a cataract surgery because their father or grandfather had it when he was 80. So they don't see why they need to get it early. So that's where I think it comes as a blanket right in between two zones that the patient would want to be in. So I think it's an innovative way. It's fairly new, so it will have its road, but I think it's a good start.
Eventually, people would require cataract surgery, just as
Of
you
course,
guys were
of course.
discussing. But would your suppose you have an IPCL patient coming in from somewhere else, how would your biometry change?
So
Anything
biometry, it's
particular?
very easy to do with the optical biometer. You don't really need to make any modifications. So, but if you have previous data, because if you're implanting one, you can compare the two and you get a more accurate way. And I think we are getting better at treating refractive surgical patients with their post-op outcomes now.
Yeah, I think that's what I was trying to say, that it's important to have your previous data and also give it to the patient because he may be going elsewhere, and then it helps kind of take the next step decision. Any shortcomings or any places where you found that, who's the candidate who's not really suitable for this?
Hyperopes, I think. Hyperopes are the most difficult to treat refractively, even corneal wise as well as lens-based or phakic IOL based.
Yes, one has to be very cautious there because it sometimes works out the other way.
Other way.
Any other comments? Anybody in the audience wants to ask any questions before we'll wrap up the session, and we've got about 2-3 minutes.
I think.
Yes.
Great.
All right then.
Thank you.
Perfectly on time, and
excellent.
Thank you for the
Thank
session
you.
to my panelists, the speakers, and we'll just have your. Let's have a group photograph here, and then a faculty memento.
Oh, he has a talk.
Yes, Dr. Dipankar has come. I was looking for you.
Why was I looking?
Yes, of course. Come, Dr. Dipankar. Yes, of course. We invite Dr. Dipankar. So good, we have the surgical part also, clarified.
Hi, good afternoon. Sorry
Dipankar
to
is
keep you waiting
practicing
for your
in Delhi, and my apologies. I got a message saying that you're probably not in, but good. So good for us. We'll have now the surgical aspect of it.
So very good afternoon to all of you. Mine is just a deferred light surgery. I'm just going to straight. It's a 8-minute thing. It's essentially unedited. Loading has been talked about a lot with IPCL. It's a hydrophilic material that we are all used to. Very easy to handle with a McPherson. We try to make sure that we are not touching the center of it. It is loaded just like a normal butterfly cartridge that we have for all other lenses. Just need to keep the convex side up, Handling is absolutely beautiful with this. Regarding the incision, normally a 2.8 is more than enough to put it through in contrast to the competitor, but with some practice, with some experience, even 2.2 is fairly good enough. It goes in very well without having any problems. So you can see I am making my main port incision here. I always prefer 2 side ports, not 1 side port. I have my reasons, which I will show later in the video. So you can see I am making 2 side ports here. As I said, the surgery is essentially non-edited. It's a total 8 minutes of surgery. That was the time that I was given initially. Yeah. So after making 2 side ports, so the patient in this case had a very high zygomatic arch. I had to tilt his head just to get a clean area for making the inferior side port. I had tried shifting a bit to the hydro implantation of my IPCL in between, but once in a while I used to get some problem. I shifted back to the visco thing. Visco does not really make a difference if you overfill it, underfill it, but as a classical teaching, I keep to leave it this way, where the ribbons are still being seen. It is not formed into a single gel. It just gives you that advantage that IPCL does not remain on the top towards the corneal side, and you have the area where you can take your second instrument and push it down. The IPCL opens beautifully. I still go the traditional way, in, out, giving it small jerks. There is next thing is where I change my technique. I try to go a bit bimanual with my haptic tucking. So initially with version 1 design and even with ICLs, the haptics I felt were normal haptics. We used to push with one hand towards the center, leave it, and used to just slide under the iris. With this, I have realized the haptics are so beautifully thin, but when we try to take it to the center, sometimes the tip of the haptic turns upwards and there's a difficulty in putting them around. So in this case, I pull it with one instrument towards center and just give a small nudge with the second instrument on the top of the haptic, and it then flows beautifully inside. Again, so you can see the 2 haptics are already done. It is a quickish surgery. Another haptic that we are pulling towards the center, just a small nudge would be given. You can see here, yeah, that's it. A small nudge goes inside and you can just leave it here. We have to remember this has 6 haptics, so even the middle haptics on the either side need to be given a small nudge at times. So our IPCL is all in place. This was a toric case, so we just need to align our markings with the 0-180 marking that they have been done pre-op, and then we can do a simple viscoelastic aspiration. I personally do not use any pylo, and I feel I am getting fine with it. So there's no extra thing that needs to be done here. The whole surgery might be around 4 minutes. The visco aspiration in my case is another 4 minutes. That is the only thing I do. I have not seen much of IOP spikes. I have stopped making my patient wait for 2 to 4 hours because I've hardly got spikes after doing a thorough visco aspiration. And rest of the thing is visco aspiration. Towards the end of surgery, you might just need to recheck whether your alignment of your toric axis is on the, so you can just see the toric alignment. In meanwhile, I will just take a couple of minutes and just put my bit of my opinion onto things. I would be more interested to see a EDOF IPCL come in. I believe 40 to 50 have that residual, let's say, ciliary power that they can accommodate a bit. So why to give them the disadvantage of trifocal, plus the trifocal is now farther away from the focal point of the eye in comparison to IOLs. EDOF, even if it gives around 1 diopter of add, will be good enough for patient to continue for a longer time. And second thing, I would not want to give these patients RLEs unless I have another choice. I just do not want to fiddle around much with the normal mechanics of the eye till I have no other option. But yes, we do get good results, but you never know. So yes, the viscoaspiration is still going on in my case. We can just skip this part.
I think that's the most important part.
Yeah, but that is the only part that is taking time. I think towards the end, I just give you can see that the axis of the IOL is slightly tilted. We can just, one thing I must say, the customization of 0180 on toric is one of the most important things that we did. Nowadays, I do not target a vault of 400. I try to keep it higher. Make sure that it does not have a chance to rotate post-op. 700, thousands do good if you are not having pigment dispersions, and you generally do not. That makes sure that the IOL is not rotating post-op. For past 3 years, I have not had any version 2 that has rotated post-op. In contrast, whenever we try to move from the normal axis here and there, I have had problems once in a while. So I think that is it. That is, I do my wound checking every time after I have closed my case, make sure there is nothing leaking. So that is that. Thank you so much for your patient watching.
Thank you, Dr. Dipankar, for that wonderful surgery, and I think that has kind of completed the IBCL part of it. And how's your immediate post-op regime that you follow, and in terms of when does the patient get his, when do you tell the patient this is what you'll achieve in terms of your vision?
So I don't think there's hardly any problem. See, patient is usually 6/6, or let me put it this way, patient usually achieves BCVA or better the next day. Patient gets more comfortable in coming 2-3 days, but there is not much of surprise that I see that patient would be 6'9", or let's say you need to understand that BCVAs in quite some of these patients is already compromised to 6'9", 6'9 parts. So anybody who is having a myopia of, let's say, more than 8-9ish, having a BCVA of 6'9 parts, 6'9, would most likely be 6'6 parts or 6'9, as in a half a line improvement within 24 hours. My post-op is I ask the patient to come the very next day. I check for vault. BCVA is generally improved 99% of patients. The rest of the feeling that it improves, I usually defer the 2 eyes by a day or 2. I always check for the vault as a matter of habit. I almost never do the cases the same day, bilateral cases the same day. So within a week, patients all fine.
Right. Thank you. Any comments that you want to do? Okay,
Thank
great.
you. Thank you so much.
And yes, sorry.
No.
Thank you. Come, we'll just have the mementos in a group photo.
So just for information, we have a lucky draw. You must have received this with the registration as well. So you have a placard with all the stalls in it. So the prizes for the lucky draw are Redmi phone, JBL headphones, and a noise watch. So for that, you need to get stamp from all the stalls and then submit it in the registration area to be eligible for it.
Ophthalmic wars. We have 4 teams going ahead, head to head. Can we have the teams getting ready, please? So audience, please take your seats. We'll be having a set of questions for you too. You will be participating as well in ophthalmic wards. We have 4 sections, a medical section, a surgical section, a quiz, and an impromptu skit going ahead. So we begin this season's ophthalmic wars at YOSIcon 2024. I'm pleased to invite our referees for today, Dr. Prashant Bhavankule sir, Dr. J.S. Bhalla sir, and Dr. Bhupesh Singh sir. Sirs, I would like to request you to please come on the dais, please. Thank you so much, sir. So going with the theme of the country for 2024, our ophthalmic wars will be a fight on our system, elections, and much more. I would like to invite our judges for today who will be judging the 4 teams going ahead. Dr. Sonal Kalia ma'am, Dr. Nikuj Kang sir, Dr. Chris Zana Akuba Arao madam, Dr. Mohammed Azam, Dr. Niti Ratpasatron, Dr. Ketsu Singh, and Dr. Saminda Farid Nawale. Judges, you will be getting a mark sheet with you. We will be explaining to you before we begin how to mark the contestants. There will be 4 rounds once again. A medical round on 40 marks, which will be judged by you. A surgical round on 40 marks, which will be judged by you. A quiz round of 100 marks, where we will be judging the candidates and giving you the marks. And a skit of 20 marks, which will be judged by you. Total marks for the candidates for each team is 200. So they will be competing for 200 marks. So the moderators for today is Dr. Nilesh Kumar sir, Dr. Ayushi Agarwal, and myself, Dr. Anujit Paul. And without further ado, we can go ahead. So we start off with the very first team, which is Team Active against Panophthalmitis, or Team AAP, led by Dr. Divakant sir, who is acting captain in place of Dr. R.T. Mehta ma'am sir, welcoming you, Dr. Dipanshu Agarwal, Dr. Sunandini Bose, and Dr. Neelam Khatwani. Next we have the best judges of pseudo exfoliation, or BJP, led by our esteemed secretary secretary and our captain for today, Dr. Karan Bhartiya sir, Dr. Kaushik Tripathi, Dr. Arjun Arora, and Dr. Zain Khatib. Next, we have the innovative neutralizers of cataract, or INC, led by our captain, Dr. Aditya Sethi, and Dr. Vaibhav Sethi, Dr. Sahiban Sethi, and Dr. Bhavya Gokani. And finally, last but definitely not the least, we have the Desmith Membrane Knights, or DMK, led by Dr. Prasanna Venkatesh, their captain, Dr. Maria Banu, Dr. Nupur Goel, and Dr. Prachi Grover. Yes, sir. Okay. Thank you, sir. Thank you so much, sir. So without further ado, let the war begin. Dr. Bharat Mehta, sir. So we'll be having a lucky.
I'll announce the marking.
Yes, once
So to all the judges, thank you for agreeing to be a part of this, and this is going to be the most fun session of the entire YOSIcon. And there's going to be the first medical case. Medical case is going to be of 40 marks. Out of 40 you have to score. Then there will be a surgical case that will be again out of 40 marks you have to score. And then you have the quiz that we will be scoring and telling you the score. It is going to be a rapid fire for 1 minute, a maximum mark of 100. There is no negative marking in that. And then we have a skit. And I just urge you, because it is going to be it is going to be for the audience, so we have to take the audience cheer into account. The loudest cheer for the team will get most marks in this skit. So that is there. I welcome Prashant sir. Prashant sir, welcome. Thank you.
So we'll be having a lucky draw to see which team will be going first. I would like to invite the team captains to pick up one chit from my hand, and there will be 1, 2, 3, or 4 written on the chit. So please let us know. Accordingly, the judges will mark you as well. Devakan sir. So who has number 1? So best judges against pseudo-exfoliation is team number 1 or team A for the judges mark sheet. You can write BJP next to that as an acronym. Who has number 2? So team number 2 is INC. Judges, you can write INC next to team number B. Who is number 3? So number 3 is DMK. You can write DMK next to team number C. And goes without saying, last but not the least is AAP as team number 4. So we'll start off with the medical cases. All teams will go in this order to represent their medical cases. So I would like to call team A, which is BJP representative. Team BJP, your medical case. First medical for all 4 teams, then surgical for all 4 teams, then quiz for all 4 teams, and then skit for all 4 teams. Team BJP, are you feeling nervous?
अब की बार 40 मार्क्स, अब की बार 40
अब की बार 400 पार.
So hello everyone, this case is called Wading Through the Fog. A 39-year-old female presented with left eye painless progressive blurring of vision for 2 weeks, and this was the presentation. Vision at presentation was 618 parts. There were 2+ cells in the anterior segment, and there was a dense vitritis. There was this yellowish white lesion adjacent to a pigmented scar, and Going by the history, patient did not have any significant history of eating undercooked meat or with exposure to cats or anything like that. And differential diagnosis based on this presentation was toxoretinochoroiditis, viral retinitis, and syphilitic retinitis. Lab investigations were advised, and everything was negative except the ESR. Patient was also advised to get the toxoserology, but patient did not get that done. And going by the appearance, the factors favoring toxo were the dense vitritis, then typical retinochoroiditis adjacent to the pigmented scarred lesion, and the Chiarelli's arteriolitis. So going by our top differential, we started treatment for toxo, which was Bactrim DS, and intradental injection of Clinda and Deca, and the patient responded beautifully to this. Vision improved to 612 parts, and after 4 injections, this was the final result, and we were extremely pleased by the amazing outcome. And yeah, that's it. And taking the OCT through the lesion, we note that there was a scarring and complete healing. Thank you.
I would like to invite the medical case for team INC. Judges, you can mark team BJP. In the meantime, I would like to invite Dr. Prashant sir to give his comments on the case.
Yeah, clinically I think...
Sir, typical BJP case, everything was negative.
I think it was a clinically obvious diagnosis was written on the clinical thing. So most of the times we go ahead, though we do confirm it with the investigations, most of the time it is a clinical diagnosis. Well done.
So you can go ahead.
The presentation should go ahead first.
Team INC can't expect anything better.
Punching machine घपला है. When history solves the mystery, a 76-year-old female came with redness, swelling, blurred vision, pain in both her eyes since 4 days. She had undergone left-sided radical mastectomy for CA breast done 6 months back. On examination, she had lid edema, circumcorneal congestion, chemosis, subconjunctival hemorrhage, corneal edema with descendant folds, fibrinous AC reaction, posterior synechiae, pigments over the lens, cataract, vision on right eye 20/40, left eye 20/60 parts. Intraocular pressure was raised in both the eyes. The fundus examination was hazy. However, a few choroidal folds were seen, which was not very evident on the fundus examination. It was clearer on the OCT examination, as you can see here. On B scan, we were surprised to note a significant amount of subtenon fluid, and there was a positive T sign in both the eyes. So this was a bilateral posterior scleritis, but what was the cause? Did we miss something? So, when we went back to history, there was an injection called zoledronic acid, which is a bisphosphonate, which was given just 3 days prior to the symptoms. But what does that mean? When we do the literature search, bisphosphonate is a drug which is very routinely used in carcinoma patients and in osteoporosis, and this can cause an entity called posterior scleritis. Zoledronic acid induced posterior scleritis was the entity which was diagnosed. Patient was stopped of zoledronic acid after oncologist consult. Oral steroids were started along with topical steroid and cycloplegics. 2 days later, there was improvement, there was marked improvement. Vision became 20/20 both the eyes. Intraocular pressure became normal. Corneal congestion went off. AC reaction became fine. Fundus became clear. There was no choroidal folds now seen, and the B scan had no almost minimal subtenon fluid. So what we learned that the patient is improved, and proper history taking and good literature search can help solve mysteries in cases of rare clinical scenarios. Thank you.
Team INC, all's well that ends well. I would like to invite the judges. Aise taali mariye. Judges, Dr. Bhala sir, any comments regarding zoledronic acid? Have you seen any case, or is it something which you would want to comment on?
I think I was not aware of this entity, this choroidal folds and posterior scleritis, because of this agent bisphosphonate. Bisphosphonate is very commonly used for osteoporosis even senile osteoporosis, bisphosphonate is used. I think it's really, I was not aware of this. Well done.
सर स्विस बैंक से लेके आए हैं, स्विस बैंक में रखा हुआ था इसको छुपा के.
Team DMK medical case.
Just like Shashi Tharoor's vocabulary, our cases are.
Dr. Maria, you can go ahead.
Good morning. On behalf of the team DMK, today I'll be presenting a pancreatic puzzle. Good morning. On behalf of the team DMK, today I'll be presenting a pancreatic puzzle. A 14-year-old girl came with the complaints of abdominal pain on and off for the past 5 years, vomiting for the past 2 days, and diminution of vision in both eyes for the past 1 day. She is a known case of pancreatitis, had recurrent episodes in the past 1 year. Radiological investigation showed pancreatic divism with pancreatitis. Personal history was not significant. General examination, only icterus noted, otherwise normal. Systemic examination, per abdomen examination showed a tenderness noted in the epigastric region. Rest all systems were unremarkable. Ocular examination showed a best corrected visual acuity in the right eye of 1/60 and in the left eye of 3/60. Fundus examination showed the disc and the vessels appear to be normal, whereas the background retina showed a pusher-like flecken surrounding the disc. This is the fundus picture at the initial time of presentation, where there was a pusher flecken surrounding the disc. Investigations also supported the diagnosis of pancreatitis, where the total bilirubin was elevated and the liver enzymes are also elevated. This was the OCT taken on the initial day of presentation, which shows edema in the parafoveal region. It was also in the left eye. A USG abdomen showed a probe tenderness in the left hypochondriac region, and we also subjected the patient on repeat radiological investigations, which showed features supportive of acute and chronic calcific pancreatitis. The patient was treated with both for the acute pancreatitis and for the retinopathy. The patient was started on steroids. Initially, intravenous steroids was given, followed by oral steroids. The response to the treatment was checked on the subsequent days, in which the visual acuity in the right eye improved up to 612 partial and in the left eye up to 612. And fundus reevaluation also showed a resolution of disc edema, macular edema, and there was a clearance surrounding both the discs. This is Pusher's retinopathy, is defined as a chorioretinopathy associated with indirect trauma. In the absence of trauma, it is referred to as Pusher-like retinopathy. The most important clinical symptom is the painless diminished vision. The most frequently encountered fundoscopic signs were the cotton wool spots in 93% of the cases, followed by retinal hemorrhages. The diagnosis matches at least 3/5 criteria, which the following: Pusher flecken, retinal hemorrhages, cotton wool spots, and a probable explanatory etiology. The pathogenesis is disseminated pancreatic proteases, embolization, which causes complement activation, and an infarct. Treatment remains, with the various studies show that high dose steroids remains the state of treatment. These are my references. Thank you. DMK, Jai.
We should have a best dressed marketing scheme also for.
If you come underprepared, sir, nothing we can do about it. Prashant Saman Khanna, sir, would you like to add a comment? Meanwhile, I would like Team AAP's medical case to please come up. Sir, any comment?
See, I've seen cases of Pusher's retinopathy improving by steroids. That's a very, witness the case following pancreatitis or anything. Prashant sir will be better.
Right. Sir, you can go ahead.
Thank you, everyone. My case is
not on the screen.
यही तो scam है. So this patient was earlier had presented in a constituency run by BJP, and she was a 45-year-old female who was diagnosed as some kind of vein occlusion with macular edema, and in the right eye she was perfectly all right. In the left eye vision was 20/160. And then, since it was a scam, so they had advised her intravitreal ranibizumab and was injected one injection.
Made in India.
So then patient had presented to us where we looked at the right eye as well, and we found that there was a retinitis patch in the right eye along the inferior temporal arcade, and presence of a big retinitis patch involving the superior margin of the fovea and superior macula. And when we looked into the history, she had a history of fever 3 weeks back, and for which she had taken treatment. The fever subsided, but the retinitis patch remained. So when we did an OCT through the in the right eye, fovea was clinically okay, but in the there was a patch in the right eye as well, and we can see intraretinal thickening along with some vitreous cells on top of it. In the left eye, there was presence of significant intraretinal thickening and subretinal fluid, along with presence of these few vitreous cells on top of it. So we diagnosed this patient as post-fever retinitis. Then we subsequently started the patient on oral steroids of on dosage of 1 milligram per kg for 1 week, and along with antacids. So patient was followed on 2 weekly basis, and we can see on subsequent visits the lesion had is reducing. Edema has also reduced. At follow of 15 weeks, patient was the lesion had almost nearly gone. There was presence of some hard exudates, and edema had completely subsided. So this is visit on visit comparison of the lesion as well as of the macular edema in the right and the left eye. So the conclusion is history is very important, and since there was history of fever 1 month back, the strict follow-up needs to be done, and you need to judicially treat this patient. Thank you.
So did you find out the source of the scam from
BJP.
Team BJP?
BJP.
We'll move on to the surgical cases. I would like to invite Team BJP once again, surgical case. Do you have anything in your defense, Dr. Zain, regarding what has been accused?
So these people are, very fond of just putting accusations, that it's always the case. We will defend by our work.
ED laga do bhai.
Anyway, so I'll be presenting a refractive surgery case, and in refractive surgery, we know planning is important, so I'm not going to be showing the video. I'm just going to show step by step how we managed this refractive surgery case. So this was a 35-year-old female who was operated for LASIK done 6 months back by the opposition members, and she was very unhappy. Right eye vision was 6/6, left eye was 6/36 unaided. You can see she showed a significant myopic astigmatism against the rule in the left eye. And when we refracted her, she was just accepting a minus sphere, and she improved to only 6/18. We can see the contrast sensitivity is much low compared to her age. If we see a modulation transfer function and stimulated retinal image, it is quite bad. So we went ahead with the topography, and we can see the right eye shows a very good myopic ablation with a central flattening as what we are supposed to see. But when we look at the left eye, we see this odd shaped central steepening, unexplainable, and there also is a significant cylinder on the anterior cornea, and there's no sign of any ectasia. So this is the epithelial map seen. At this stage we were quite confused, we didn't know what to do, so we called up the opposition member who operated, and they said no, the surgery had gone off well, everything was fine, I don't know why this has happened. So as usual, not taking responsibility for their past deeds. But anyways, look at the epithelial map. The right and left show significant difference. If we see the raw image of the right eye, we can see a good flap, and it's a meniscus type of flap, which suggests it was a microkeratome. But now the left eye, this gives us the first clue as to what could have gone wrong here. So we see that the flap merges in the center, and this actually was a buttonhole. Let us understand why the vision is low in case of a buttonhole. So this is the right eye, this is how the epithelial map looks. In the left eye, when a buttonhole happens in the center and the flap is lifted, there is a central island which is left back of epithelium. And if we just see the stimulated image, we make the flap with the central buttonhole, we raise the flap. The surgeon does not realize that there's a buttonhole because sometimes it's not seen, and then you apply the laser. The laser goes and it hits only the epithelium in the center, only epithelium is ablated, and the central part of the stroma is ablated. So there's actually epithelium in the center. When we put this flap back, initially it takes up the shape, so the patient is very happy on post-op day 1, but then now the epithelium realizes that it has to grow back to its original size. Once it grows to the original size, it starts to compensate. So the center will become slightly thinner and the periphery will become slightly thicker. So you will get this sort of a picture with a central stromal bump, and that is why the patient is not happy. So our patient also had this sort of a pattern with a central thinning and a peripheral thickening. So the treatment is to do a transepithelial PTK to eliminate this bump. When we go up to the maximum epithelial thickness, the stromal bump gets eliminated. but what also happens is peripherally stroma gets ablated. And so we went ahead doing a 66 micron PTK, but because of the stromal ablation in the periphery, in the early days of epithelial regrowth, we can expect some amount of myopia. So this is the refraction. Vision was not so good, but once epithelial remodeling sets in, the gaps are filled up and you get a smooth anterior surface. At this point, the patient showed this sort of good epithelial pattern with a smooth surface. Best corrected vision was 6/9. And you see the pre and post-op PTK, much better than before. Now we do a second treatment, which is another transepithelial PTK, but this time with a topo-guided treatment. So we do 63 microns of transepithelial PTK. And now, because the stromal surface is smooth and we've got it mimics the original anterior surface, we do the topo-guided treatment with the final correction which the patient has. And finally, once this is done, post-op 4 months of epithelial remodeling, we've got a good topography, very good, much better than what it was at initial presentation, good modulation transfer function, and uncorrected vision of 6/9. So after 1 year of hard work and planning, finally the patient is happy. So this is what BJP does. It always tries to, mend the earlier bad work that has been done by the previous opposition party currently. Thank you.
Excellent presentation, sir.
इतनी सर्जरीज की फंडिंग कहाँ से आ रही थी?
That's a secret.
Mr. Shah, sorry, Dr. Khatib, first of all, only BJP could do this. In a surgical video case, there was no surgical video.
I'll do the surgical video for you now. It's the surgical video is. That is what you wanted to see.
I was worried there'll be a surgical strike, but that's okay.
So team INC will present a surgical video.
Can I have the audio as well?
अचानक से कोई दरवाजे पे खटखटाया, बोला देखा मैजिक.
So basically, this is how the patient presented to me. He was a one-eyed patient with a bad corneal edema, with vision of CF at 1 meter, pressure of 60 millimeters of mercury. Poor guy had undergone multiple surgeries in the past, an SICS, lens drop, a vitrectomy with a secondary implant. And by the time he came to me, his last surgery was 3 weeks before that, and he had end-stage glaucoma with an IOP of 60. And this is how the conjunctiva and the sclera looked like. There was a 180-degree conjunctival opening. Sclera was cut open. Now, ultimately, glaucoma surgeon को अगर conjunctiva और sclera भी नहीं दोगे तो कैसे काम करेगा, right? But still, like how we belong to the Congress and Rahul Gandhi never gives up, still great things take time, so we did some planning. So the little conjunctiva that I had left, we planned to do a valveless implant with that, and I used an Ahmed clear path, and what I thought was that I'm going to fold the plate of the tube into a taco so that I can slip it in through a very small conjunctival opening which was available for me. And a pre-placed suture is being placed because it's a valveless implant, chances of hypotony can happen, and so the fenestrations are also made, and each fenestration can bring about an IOP of about 8 millimeters of mercury. So you can see how small the conjunctival opening is. It is just about 3 mm. The tube is folded into a taco, the plate, it is pushed inside with a good posterior dissection, and once it's in place, it can be unfolded. So this is how, so beautifully, you may have never seen a plate being pushed in with such a small incision. And now the tube is being put into the sulcus because there is a PCIOL in place over here. The tube end is being checked. This is a ripcord suture which the tube lumen already has, is just being tucked under the conjunctiva for removal later on. And this is a scleral patch graft which is being placed on the tube to avoid exposure. And at the end of this, the conjunctiva is closed using 3 simple interrupted sutures. There is no complicated suturing or closure required because there is very minimal opening in the first place. This is the first post-operative day. The cornea is fine, the patient is doing well, the tube is well placed. This is 3 months post-op, patient's vision is 6/9. The tube is in place, the graft is well opposed, conjunctiva is fine, and at the end of 3 months, when the fibrosis was enough and the IOP was rising, the ripcord suture removal was taken out with a very simple procedure of a small nick, and then you cauterize to close the incision. and the IOP is 16 millimeters of mercury on 1 AGM, and that was from 60. And अब मुझे जानना है पोते का छोटा बीम शुरू हो रहा है. Thank you.
Astronomical, stupendous, gigantic, wonderful.
This is the most INC has spoken in the last 10 years. I feel.
It's called Haath Ka Kamal.
Dr. Bhalla sir, I would invite you if you would add some comments to this case. Meanwhile, I would like to invite surgical case of DMK.
I think it was very nicely managed, and through a very small incision by this taco technique, she could manage it very nicely. Wonderfully done.
टैको से वाल्व बना लिया.
Maria, open my video. Right. So we are team Decimet's Membrane Kings from the south. So we are going to hit with the magnitude of videos on surgical mix. So is Delhi ready? Is YOSIcon ready? Can I have my videos? Yeah. Can I have my video? I'll start. No, my video is still not. So thank you for the applause, my dear friends. I'm going to welcome you into the world of mix. So not one but multitude of cases. Tilt your microscope 30 degrees towards you, tilt the patient another 35-45 degrees away from you, and start the direct gonioscopy. As you can see here, with a simple 3-dimensional Sinski hook, take it inside, orient yourself in a 3-dimensional plane, and even this is very much reproducible even in a live surgery environment, a handless technique that I've demonstrated, where you can see even without holding, you can visualize with both hands, which will be very helpful in advanced mix. So this is a case where I need to get the IOP in low teens, a 26 gauge needle, just bend it opposite that you do to a Rexus, just economical mix. You take it inside, clockwise and anti-clockwise, the trabecular meshwork is excised, and there it is. So again, a modification, a Kahoot dual blade. On this part of the video, you can see that it is an oppositional angle closure. Even there, if you insert it into the Schlem's canal in the right plane, you will be able to pull it off and the root of iris will fall back. And this is again another novel observation. When you do it, there will be some overhanging trabecular meshwork on the edges. Take an ILM peeling forceps and take it out to make sure that there is no PAS in these type of cases. And this is a micron level trabecular meshwork that I am showing in the post-op. So when you move into the mix, there is a stenting devices when you need to get control, not excision. But this patient wanted his IOP to be in low teens in a stenting device. I placed it and you can see a beautiful paralimbal blanching even on the plane, suggesting that the episcleral vessels are perfused. Not one but two. So when your time comes, you get not one but two stents, and you can see again here the tissue reacting with a paralimbal blanching. So these are signs that really motivates us to take things forward. And when you have a superficial implantation like this, in one of my cases where the opposition did send me, so you can see that I had to first secure myself, place the second stent first, then retrieve this. So at that time I didn't have the wisdom to close the trocar, I again lost it. So these are some challenges that happens. So I was lucky to have it in the phaco wound. So I was always able to go back, take it in, and then again put it back into the right place. So this, my dear friends, will happen where heart in the mouth movement, no financial disclosure, but 2, 3, 4, 5, 6, 7, 8, 9, 10. You can just keep on going once you started. Opposition will just get panicked if you go like this. And then you have the iStent W. You can see that the W, the broader base. With this broader base, when you go in and place the stent, it doesn't go into the Schlem's canal. It stays exactly in the place where it wants to be set. So that's being done. So can we move to reducing the aqueous production? Yes, this is one of the patients referred from my good friend Aditya, my opposition. So I did go back and just reduce this aqueous humor production by reducing the painting the ciliary body. It's called a cyclomodulation process where we use ECP to get it done. And then the last, another economical mix, a suture GAT, where you can see deferred from BJP. And this patient, I just put a nick, and to bring the IOP under low teen 8 millimeters at the post-op, I used the suture and made a mushroom 360 degree. You just rotate it, and then you can excise the trabecular meshwork 360 degree. Highly cost economical. Mix is not only costly, it's very economical, and right there you can see the suture GAT. And this is one of the novel observations. Glaucoma is moving from sclera, my dear friends. We have the ciliary body where the aqueous is produced, and we have the trabeculum meshwork where the aqueous is getting drained. So I think it's going to be just a matter of time. Not mix, my dear friends. First time in YOSIcon, a combined mix. You would have heard of combined procedure. Reduce the aqueous humor production, increase aqueous humor drainage. That, my dear friends, is going to be the future. All the cases have been validated. We have published the W sign post KDB. There is a remnant in bang where you can see, and this is the suture gad where there is a bird beak sign. So all of my cases, these are the multitude of mix that I wanted to hit all the three oppositions and finish them off with this particular novel technique as well as the publication. Thank you.
Thank you so much, sir. All parties want to know what happened to their patients after referring them to you.
Totally, I took all their patients.
This is what it does, takes the pressure off from other
Absolutely.
parties.
From the south he comes and takes. With that, I would like to invite surgical case presentation from team AAP. In the meantime, can we have a comment from Bhalla sir on his take on MIGS, combined MIGS?
I think there are two ways to say. One, they say minimally invasive glaucoma surgery, but your opposition says minimally effective glaucoma surgery. But you have combined the two and make it maximally effective by combining the decreasing aqueous production by endocyclophotocoagulation and increasing the drainage. I think it's a fantastic technique.
What were you doing with your both hands? You said you don't need to use both hands.
Sir, he came to your VR OT to take your ILM forceps.
Election commission in place.
So thank you so much. Now, just for YOSIcon, I have been allowed to present directly from Tihar jail. So, so that is the power of YOSIcon. So I'll be presenting a surgical video about subretinal cysticercosis. So here is a case of a 25-year-old male patient who presented with loss of vision for 2 weeks. The visual acuity was counting finger 1 meter, anterior segment was absolutely normal, and we could see this lesion. We did the usual investigations like USG, CT scan, brain, and neurological consult. On OCT, we could see a well-demarcated hyporeflective cystic lesion with a hyporeflective wall with something that looked like a scolex attached to the wall of the cyst. Now then we planned to diagnose this as a subretinal cysticercosis, a clinical diagnosis, and went ahead with vitrectomy. So you can see the 3 ports are being made, 25 gauge, followed by core vitrectomy is performed. Here now you can see the classical undulating movements of the worm right there. These are the movements that can be observed now. Now we went ahead with our vitrectomy. First we tried vitrectomy without triamcinolone. Then after that, since I was finding it difficult, so I went ahead with triamcinolone assisted PVD induction. Now during the injection of PVD, I feel that there was a macular hole that had also formed, which will be apparent a bit later during the video. So we went ahead with the vitrectomy, and just at the base of this cyst, we did a very small retinotomy, which was made. And with the help of our active suction at high suction rate, we will then just remove the cyst, and the compressible nature of the cyst can be observed here. Without much collateral damage, the cyst comes out beautifully.
Ooh.
And the macular hole is more apparent right now here.
In toto, mate, in toto.
So now at high suction and high cut rate, we will get rid of this with the help of the cutter. Now with the advanced systems, this is possible without much inflammatory reaction in the cavity. Now the fluid air exchange is done, and the subretinal debris, the inflammatory material, and the small amount of fluid that is there, that will be sucked out with the help of this suction very carefully. Now I've not done any extra maneuvers in an attempt to close the macular hole, because the retina looked very fragile. ILM peeling did not seem possible here, and we did not perform any lasers also.
So SF6 gas was injected, and right. Yeah, so this is the post-op after around 1 month. The patient is maintaining 6/18 vision. The macular hole was closed, and the patient is doing well now. Thank you.
Superb.
Was the macular hole after you noted after the tricot?
Yes,
you injected?
because before that, not even on the OCTs was not there. After the injection of tricot, probably because of the gush of the fluid, the tricot.
So you use glass syringes or the normal?
Yeah, I use glass syringes.
Right, so we are done with 2 sections of ophthalmic wards. I would like to invite Dr. Pranita Sahay ma'am to deliver the keynote address at this point of time. Her topic is intracameral mydriatic assisted cataract surgery.
Everyone, and thank you, Yosi. At the outset, I would like to thank Yosi for this opportunity to come here and present in front of these esteemed faculty and all the delegates that are here. So I think cataract surgery is something that almost every ophthalmic surgeon, every ophthalmologist over here is performing. So how many of you are doing surgeries under topical anesthesias? Can you raise your hands? So I think almost 50% of the surgeons are doing surgeries under topical anesthesia. So the topic here is intracameral mydriatic assisted cataract surgery. As we all know that in the current scenario of phacoemulsification in today's era, the patients are really fussy. They want no injections, they want a quick surgery, they will lie down on the table looking at the clock, and when they get up they will say, Doctor Sahab, aapne bahut time le liya is baar. They want minimal medication, rapid recovery, they want to get back to their work immediately. So the current scenario is very much different from what was there in the past. So phacoemulsification, currently majority of the surgeons are preferring under topical anesthesia, as patients do not want blocks or injections. What is important while doing surgeries under topical anesthesia is, first you need to counsel your patients well so that you have a good patient cooperation. You need a good topical anesthesia that can give good patient comfort, and you want a stable mydriasis that will help you in doing a proper surgery. Now, intraoperative meiosis is something that we all dread. We don't want to get into that area because that ends up into use of Malyugin rings, iris hooks, makes the surgery all messy. The risk factors for intraoperative meiosis are diabetes, IFIS, uveitis, pseudoexfoliation, and intraoperative iris touch, obviously. The complications that happen once you have a meiosis is the surgery becomes prolonged. You have, again, add-on iris trauma. The risk of rent and post-operative inflammation also goes up. So what you want is a good mydriasis and a stable mydriasis. To facilitate all the surgical steps like capsulorhexis, cortical cleanup, capsule polishing, IOL implantation, and especially for toric IOLs, you want an accurate positioning of the axis of your toric IOLs. So stable mydriasis mitigates the risk of intraoperative complications. In a study published in the European Observatory of Cataract Surgery survey in 2013, they found that the overall mydriasis is not as important as is a stable mydriasis for an uncomplicated cataract surgery. So is topical mydriasis a solution? The disadvantages of topical mydriatic drops are, you have at least a 30-40 minutes of a pre-op time where you need to dilate the patients. So there is delayed onset of mydriasis, limited bioavailability of these drugs. Use of multiple drops like tropicamide and proparacaine causes surface toxicity and causes punctate staining, can cause superficial keratopathy. You may have an inconsistent mydriasis and intraoperative meiosis. So is there an alternative? The answer to this is yes. An intracameral injection of mydriatic is something that can solve these problems. Now, what everybody routinely uses intracameral adrenaline, but is that the answer? First, you need to understand that adrenaline that you use is not for ophthalmic use. They are basically for intramuscular, intravenous use, and they contain preservatives. So there is no standard drug of adrenaline that is available for intraocular usage. Next is that you need to dilute these drugs. Most of them are in 1 in 1,000 concentrations. You need 1 in 10,000 concentration. If your assistant is not, very vigilant, does not prepare a proper dilution, there is always a risk of task. And in patients who have a cardiac history can develop tachycardia, and not always that you're going to monitor, you're going to be monitoring your cataract patients with a pulse oximeter. You may be missing that. So what do we need to do? We need an intracameral mydriatic that is safe for use. So that is safe for ocular use, is preservative free, has an appropriate dilution, does not need to be diluted on table, and is free of systemic adverse effect. Now there are various intracameral mydriatics available in the market like Midracert, Midrain, and Phenocane Plus. Now in the Indian market, what is usually available and is routinely used is the Phenocane Plus, that is by the Antod Pharma. Now the composition of these three drugs that you see on the screen is common, that is tropicamide, phenylephrine, and lignocaine. However, what varies in this is the dilution or concentration of phenylephrine, which in Phenocane Plus is 0.3, and in Midracert was slightly higher. 0.38 was the dilution they used. So now coming to Phenocane Plus, because that is what is available in our Indian market for use. So it's an intracameral mydriatic with anesthetic. It is DCGI approved, comes in sterile ampoules, is preservative free. So it comes in a set of 5 ampoules, the cost of which is around very cost effective. It is 750 rupees for 5 vials. Each vial is 1 ml, and what you need for every patient is just 2.2 ml. So even 1 ampoule is sufficient for doing at least 3 to 4 cases. And you can store this in room temperature. Now this is just a short video. So what these company people recommend is that you can even use it in patients without any preoperative mydriasis. So here this patient was not dilated preoperatively, and you can see within 10 to 20 seconds you achieve a mydriasis as good as 6 to 7 millimeter, which is good enough to start your surgery, and you achieve at least 7 to 8 millimeter of dilation once you start doing your rhexis. So this is the effect of intracameral mydriatic. Now the advantage is you get a prompt mydriasis. Just in 20 seconds you achieve a mydriasis of as much as 6 to 7 millimeter. Mydriasis remains stable throughout the surgery till the time of IL implantation. It's a safe and effective alternative with less risk of systemic exposure as you can have with use of intracameral adrenaline. There is less pain or sensation of pressure since you're also using intracameral lignocaine as your patient might be under topical surgery. Now going back to literature review, what these studies say about intracameral mydriatic. So this study was published in Acta Ophthalmologica. This study was done with the use of intracameral Midrain, the combination of which is similar to that of Phenocane Plus. Now in this study they used it as an add-on to topical mydriasis during surgery, where they found that the dilation improved by 1 millimeter and the mydriasis remained stable in 86% of the patient. This is another one which was used in pediatric cataract, where they found that the vital parameters did not show any notable change with the injection of intracameral tropicamide, phenylephrine, and lignocaine. Now this study was done in patients of POAG, wherein also they said they compared Midracert, Midrain, and topical mydriasis mydriatic agent, and they found that the mydriasis was equally good in all three, and all three are comparable. Now there are 2 Indian studies that have been published with intracameral mydriatic, and they are with Phenocane Plus. This was done in patients wherein manual SICS surgery was done. It was a prospective clinical study. They found that there was no adverse event like TARS or corneal decompensation, and these drugs attained a rapid and stable mydriasis with a good analgesia. There's another one that was published in by the PGI group, which was for cataract surgery in children using intracameral mydriatic. They found that there was again an effect, it is an effective method of pupil dilation, and it alleviates the need for topical dilators or additional intraoperative supplementations like adrenaline. Again, reduces the preoperative nursing time. Now this was to look at the cost effectiveness of this drug. They found that as the preoperative nursing time goes down, it improves your patient's circulation time and is ultimately cost effective in your private practice, as a lot of you may be doing. So to conclude, intracameral mydriasis achieves a quick and sustainable mydriasis. Simultaneous injection of anesthesia is an advantage. It improves the patient comfort during and after surgery, reduces the patient waiting time, and does not cause endothelial cell loss. Thank you. And to conclude, please, I do not have any financial disclosures. This is a sponsored talk for YOSI. Thank you. But personally, I'm convinced with the use of this drug. I've used this in quite a number of patients, and the results are really good.
Right. Thank you so much, ma'am. I would like a comment from each one of our referees on their practice patterns in the OT and their experience as well. We can start with Aman sir and then come.
I don't use them very regularly, but yeah, in few cases which are not very well dilated, or I sometimes use them, but not very frequently. But yes, otherwise I have noted that the patient feels better of this.
Comfort level, yes.
I've used in few of the patients, but I find that in some cases where there is about 3 to 4 millimeter dilatation, even if a 1 millimeter dilatation can help you get over with surgery without the use of any invasive agents like iris hooks, and but it is not effective in all the patients.
Yes, that is
true. Where you find that even with topical mydriatic pupil is hardly moving, there you find even intracameral mydriatic agents are not going to help you. You will require to use hooks and other dilating agents.
Yes, definitely. It is not an alternate for all cases. If you have a pre-op dilation at least 4 mm or 5 mm, this is going to help you to achieve another 1 millimeter or 2 millimeter that can help you go away with the surgery. But yes, if the pupil is stuck at 2 or 3, then it's not going to be beneficial.
Yeah, exactly. If it is a rigid pupil, you need your various hooks or rings.
Right. So that brings us into our first half. Before beginning our second half of ophthalmic wars, for our international faculty who are not aware of the theme of this time's ophthalmic wars, so India is going through the general elections as we speak for the next month. So I would just like to invite each team captain to share 2 lines about their team to the audience for the benefit. The team name in specific. So, Team BJP.
BJP is refusing to give a statement about why they are there.
Ab ki baar Modi Sarkar.
BJP is the ruling government right now,
the ruling
and that's why our secretary is ruling the YOSIcon, so he has taken the BJP. And
Team
then we
INC.
have INC.
You can just elaborate on what Team INC is.
So INC are neutralizers of cataract, and currently India is going through some scope of blindness in certain sectors. So the job of this particular party is to clear that without
Prejudice.
financial benefits.
And this party has most number of family members, as you can see.
Everyone is in the party, everyone is a leader.
So this is a party from the south, DMK. So currently they are the ruling party in the south, but they are trying their level best to enter into the northern part also, the national level also. So it's MK Stalin, yeah, you would be knowing. It's okay, don't worry, don't be intimidated, Aditya, it's okay. So I think they are doing a good job, just like our team, very innovative and very novel, as you can see. So that's all about Team DMK. Thank you. DMK, vulgar.
Last but not
No, not
the
vulgar,
least,
vulgar.
AAP.
Okay, so our team active against panophthalmitis is based on the Aam Aadmi Party. The leader, the supreme leader of the party is behind bars. I mean, not the team captain. I'm talking about the leader of the original party. But that party is supposed to stand for honesty and corruption-free government. We are yet to see what's going to happen. But let's wait for the election results and the Supreme Court judgment also.
You can change your slogan like BJP has slogan, "Ab ki bar." You can say "Ab ki bar" behind the bar.
Okay, now let's move to the rapid fire round. Before that, let me tell you the instructions. So with every right answer, you get +10. There is no negative marking. And I would request all the teams not to prompt either the right or the wrong answers, because then the question can get cancelled, and that will waste your time only. And last but not the least, quiz master's decision is final, and quiz master is always right.
and only one of the team member is going to give the answer. That will be going to be valid. So designated from BJP, the spokesperson, Sambit Patra. You are the Sambit Patra.
No, I think whole team will be there, or
Okay. You have to stand here, look at the screen, and you can give one answer, and there'll be 1 minute on the clock. So,
Dr. Anujit will be
yes,
keeping
so
the
I will
timer.
be keeping time. 10 questions. If you get 10 right in 1 minute, 100. You can pass and go to the next question. Right. So, Ayushi, are you ready?
Yeah.
Right. So, your time starts now.
This is the common side
Neta
effect
Shudil, next.
Okay.
Oh, Neta
That's
Shudil,
correct,
next.
That's correct, plus 10.
हाँ.
Apneek is a recently FDA approved drug for ptosis. What is the composition of this drug?
Options.
There are no options.
Next.
Identify this
Granular corneal dystrophy.
Correct, plus 10. This is the fundus picture of a case of Sturge-Weber syndrome. Can you tell the...
Choroidal hemangioma, diffuse choroidal hemangioma.
Correct, plus 10. He is the only ophthalmologist to receive the Nobel Prize for his work in ophthalmology. Can you name the scientist? Correct.
Helmholtz.
The final one is wrong. Okay, so we won't.
Let's go.
He said the right answer.
Identify the instrument and if,
RF ruler.
do you know the full form?
Royal-
Yeah, correct.
Royal
Plus 10. Identify the possible
Time
site
up,
of
time up.
pathology.
Pituitary adenoma. Pituitary adenoma.
That's all. Yes, we'll take this. That's it, Team BJP. So, 50 marks for Team BJP. Team INC, please come.
Kaushik was supposed to be in our team, but they bought him. So.
That's the standard statement of INC everywhere. Some wrong was done to them. Okay, again 1 minute on the clock. Ayushi, are you ready?
Yeah.
Okay, so your time starts now.
Identify this instrument.
Pass.
What does this gonioscopy finding indicate?
Blood in Slem's canal.
So what does it indicate?
High Sturge-Weber syndrome, high episcleral venous
Correct,
pressure.
plus 10. What is the dietary modification that we strongly recommend for this condition?
Gyrated trophy. Pass.
Name the syndrome with this clinical presentation.
Eye syndrome.
Correct, plus 10. Can you spot the scientist?
Kelman. Charles Kelman.
Sorry. Name this eponymous sign of keratoconus.
Munson sign.
Correct, plus 10. Name the syndrome based on the cues given below.
Neurofibromatosis.
Which type?
NF1.
Correct, plus 10. What does the FDA approved drug VT for presbyopia contain?
Pilocarpine.
Okay. Do you know the concentration?
Diluted pilocarpine.
Okay.
That's it. That's it.
Identify this muscle.
Time
sign.
up, time up. You can answer this. Please
Identify
quickly.
this muscle sign in a case of
Quickly.
thyroid eye disease specifically
Pass.
for...
Pass. Pass. They've said pass. They've said pass.
Yeah.
Team INC 50 points. 50. So Team DMK. Right. So Ayushi, are you ready?
Yeah.
Team DMK, are you ready?
Yeah.
Right. So your time starts now. 1-1.
A 24-year-old male status post blunt trauma with high velocity object. What is the spot diagnosis?
Perseus retinal.
Sorry, this is not the right answer. Identify the instrument.
Gonioscope.
Which one?
4 मेरे gonioscope. Zeiss 4 मेरे gonioscope.
Wrong. Name the autosomal dominant syndrome associated with this condition.
Pass.
This recently FDA approved drug is a bispecific antibody against VEGF-B and angiopoietin-2. Is it true or false?
True.
Sorry, it's false actually. What was the earliest method of cataract extraction
Couching.
known as?
Couching.
Correct, plus 10. Identify the ophthalmologist from the cues given below.
One graphic.
Correct, plus 10. Spot diagnosis, this fundus picture.
Pass.
Name the systemic condition associated with this cataract.
Myotonic dystrophy.
Correct. Identify the syndrome based on the 3 cues given below.
Time up. Time up. Time up.
Correct, plus 10. We'll
Fine,
consider
that's
this
it. Can we have the points? 40. Right, so team AAP. Ayushi, are you ready?
Yeah.
Team AAP, are you ready? Okay. Your time starts now.
Most common is finding an acute traumatic optic neuropathy. Is it disc edema, Berlin's edema, or a normal fundus?
Normal fundus.
Please do not prompt. Plus 10. Name the syndrome. You can pass to save time, or you
pass.
Can. Okay. This corneal tomography image represents keratoconus. Is it true or false?
False.
Correct. Plus 10. What was used to deliver the lens in the first documented ICCE? Was it Aruga forceps, wire vectors, cryoprobe, or none of the above?
Aruga forceps?
No, the answer is none of the above. It was the thumb of the surgeon. Identify the ophthalmologist from the cues below.
Harold Redley.
Correct. Plus 10. What is the spot diagnosis? This is the corneal.
Fuchs endothelial dystrophy.
Correct. Plus 10. What is this arrow mark?
Time up.
Shows?
Time up.
Codador's line.
Yeah,
Correct,
we'll consider
correct,
this one.
correct.
Plus 10.
Right, so can we have the marks for team AAP? 50. Great. Right, so we usually always save the best for last. And that brings us to the best part about ophthalmic wars, the extempo round.
And nothing has been revealed to the team still.
So
now.
nothing, yes, nothing
this
has
time
been.
Election Commission is very fair. बीजेपी को भी नहीं कल रात को पार्टी की तब भी नहीं.
So each team will nominate one participant to speak extempo for 1 minute. An image with a statement or a question will be put in front of them. They must read the statement, and following that, they have 15 seconds to think about it. 15 seconds later, I will tell them to start, and they have 1 minute to speak. All right? Nothing controversial, all in good jest. So, figures that are shown here are for representative purposes only. I would like to call the first participant. So, Team BJP, can you nominate your participant? First put 15 seconds.
For ideas, you can call them. But you have to speak.
1 second, wait.
Yes.
My team members.
Yes, yes, absolutely. We'll wait for you, sir. आप ready हो? सब कुछ पानी वानी कुछ चाहिए? चाय हाँ ठीक है.
And reminding judges again, audience cheer will have the maximum impact on your scoring. So, audience, please cheer for the best skit that is going to entertain you.
Right. So, Team BJP, I will be putting up a photo on the screen, like I said, and there will be a statement or a question. You have to speak on that after 15 seconds for 1 minute.
Just speak on it.
Just speak on it, right? So, this is your image. So after a fresh rhegmatogenous retinal detachment, you find out that someone is your VR surgeon. Someone's photo is in the thing. So you have 15 seconds.
So अब की बार 400 पार, 400 VR सर्जन, 400 सर्जरीज, एक सर्जन 400 सर्जरी करेंगे इस बार. हमारे मैनेजर हैं ये, तो मैनेजर को we have taken with us and he has set a target of this, है ना? इलेक्शन मैनिफेस्टो भी उसी हिसाब से बना है हमारा. आम या आलू को हम चांद पे नहीं उगा सकते, ठीक है? ये सब चीजें नहीं है. हम जेल नहीं जाएंगे, बट ये काम जरूर अच्छा करके दिखाएंगे. एक्सीलेंट सर्जरीज, एक्सीलेंट रिजल्ट्स. अब की बार मोदी सरकार.
You still have 20 seconds. You have to speak till you finish.
अगली योसिकॉन G20 के जैसे करेंगे, है ना? यहीं कराएंगे, हाँ? या इससे और जगह लेंगे, 5 हॉल लेंगे साथ में, हाँ? 10 हॉल लेंगे, देखेंगे पैन इंडिया प्रेजेंस करके 1000 डेलीगेट्स लेके आएंगे.
1 minute up. Can we have a round of applause for Team BJP? So thank you, Team BJP. I would like to invite Team INC. Team INC. So once again, you have 15 seconds to think, and then if you want, you can start yourself, or we will tell you when 15 seconds are up. You have to speak for 1 minute until I tell you you can stop speaking. Right? So this is your image. So someone is insisting for LASIK for his mother's cataract. Who is this someone? You have 5 more seconds to think. Right, you can start.
Question before I start. This someone of these guys?
Someone is looking at you.
Someone is asking me.
Yes, he's come to your OPD.
I have to act like the whole thing. तो आप सब जानते हैं लेसिक के बारे में, आप सबने सुना है इसके बारे में, है ना? पैसे उनसे लेते हैं, जेल उनको डालते हैं, सब ये सब ईडी के पीछे पड़े हैं, है ना? ईडी यहाँ ले आते हैं, थोड़े तो सेटल हो सकते हैं ये लोग, थोड़े से सेटल हो सकते हैं, है ना? आराम से कीजिए, बीजेपी का काम आराम से कीजिए, सामने क्यों कर रहे हैं, है ना? इनको बोल रहे हैं कि लेसिक करो, इनको बोल रहे हैं ये करो, ऐसे थोड़ी होता है. और मम्मी पे बात आ गई है, मम्मी को लेकर लेसिक के लिए ऐसे थोड़ी होता है, लेसिक थोड़ी, ये छोटा भीम का गेम थोड़ी है, ऐसे थोड़ी चलेगा. ये गलत है. अब हम सबको बोल रहे हैं भारत जोड़ो, एक साथ आओ, प्यार लगाओ, पर तुम लोग बोल रहे हो जेल में डालो ऐसे थोड़ी चलता है. गलत है, गलत, बिल्कुल गलत है. मोदी जी मेरे से डरते हैं, सॉरी करण जी मेरे से डरते हैं, ये गलत है. और वो डीएमके साहब बोलते हैं कभी हमारे पार्टी में, कभी उनकी पार्टी में, फिर आ जाता है उनके पास ईडी आ जाता है तो उनकी पार्टी में चले जाते हैं. ये कौन सी वॉशिंग मशीन ऑन की है, कौन सी वॉशिंग मशीन ऑन की है? गलत. लेसिक नॉट.
Time up. So can we have a big round of applause for Team INC? So that brings us to Team DMK. Team DMK, can you? Right, so same rules. I will be giving you a photo. After 15 seconds, you can begin. So someone wants a permanent cure for glaucoma. You have 15 seconds.
दुनिया 3 चीज़ों पे चलती है, एंटरटेनमेंट एंड एंटरटेनमेंट. तो ग्लॉकोमा का परमानेंट क्योर चाहिए, देंगे? क्यों नहीं देंगे? अब बीजेपी वाले अब कांग्रेस वाले बोल रहे हैं लेसिक करो कैटरैक्ट के लिए, ठीक है, वो भी कर सकते हैं. बीजेपी वाले बोल रहे हैं 400 VR सर्जरी, तो हम क्यों नहीं दे सकते ग्लॉकोमा का परमानेंट क्योर? बिल्कुल देंगे. कैसे देंगे? हम देंगे साउथ इंडियन स्टाइल में, डांस करके. एंटरटेनमेंट एंड एंटरटेनमेंट.
If we have some music, please.
You still have 30 seconds. Dance कर लो.
ग्लॉकोमा का हम ही सब ट्रीटमेंट कर रहे हैं और हम डांस करके ट्रीट करेंगे. डांस से एक नया स्टडी निकालेंगे. डांस करने से ग्लॉकोमा ट्रीट हो सकता है, ग्लॉकोमा का परमानेंट क्योर हो सकता है. ये सब दवाइयाँ तो सब बेकार है, तो आप डांस करिए और ग्लॉकोमा का परमानेंट क्योर पाइए. थैंक यू.
एक्चुअली ये लोग ना सब बाकी पार्टी वाले अभी तक अपने लिए तो कुछ क्योर कर नहीं पाए हैं, तो हमारे पास आ जाते हैं सारी चीज के लिए.
1 minute is up. 1 minute is up. So can we have a big round of applause for Team DMK?
Referees can make a comment. Can referees make a comment?
Absolutely, sir. Absolutely.
See, there was a case in which one guru promised came with misleading ads, and he was asked to put large apologies of the size of advertisement. So if you promise something and if you are not able to fulfill, that comes under the ad category of magical remedies and misleading ads. You have to be careful.
Team DMK, see Team AAP, who's your speaker? Okay.
Dr. Sanand.
Right. So once again, same rules apply. Are you ready? Right. So someone wants bail on ophthalmological ground.
तो जेल में तो हम पड़े हैं, लेकिन हमारे पास हीजेपी वाले हैं जो पाँव छू के हमें गिराते हैं, हमारे पास डीएमके वाले हैं जो डांस करके हमारे ऊपर चढ़ के हमारी आंख फोड़ देते हैं, हमारे पास कांग्रेस है जो लैसिक करके और इसके बहाने से हमारे को कैटरेक्ट सही करना चाहते हैं। तो इतना कैसे मतलब बेचारे हमारे आम आदमी के मतलब नेता झेल पाएंगे। तो उनका कॉर्नियल टियर हो गया, उनका स्क्लेरल टियर हो गया, उनका लेंस बाहर आ गया, अब बेचारे को क्या करना है। अब हमारे डॉक्टर्स अंदर जेल में गए, उनको देखा तो इतना बुरा हाल था उनकी आँख का। तो इतने सारे पॉलिटिशियंस जो हैं उनके पीछे पड़े हैं बेचारे के हाथ धो के। तो क्या कर सकते हैं, अब जेल से बाहर निकालना ही पड़ेगा, स्क्लेरोकॉर्नियल टियर करना ही पड़ेगा, आर्टिफिशियल लेंस डालना ही पड़ेगा। आँख तो बचानी है, आगे देश भी चलाना है, इतना बड़ा दिल्ली है, दिल्ली भी चलाना है।
59 seconds, your time is up. Right. Thank you so much, all four teams. Can we have a comment from...
सर जेल से छोड़ेंगे इनको? रेफरीज जेल से छोड़ेंगे इनको?
Referees, comments on...
See, if he had applied on ophthalmological grounds, we would have released him.
Yes,
but he did not apply on that ground.
Yes, sir. They never do. They never talk on the topic.
He applied on ground that he was not given insulin. So insulin does not come under ophthalmology.
Right. So that brings us into the ophthalmological wars. We hope you had a great time as we did hosting it. Can we have an audience here for all the team participants and all the innovations that have come across? Can we have a round of applause for the judges who took out time painstakingly to judge all these medical videos, surgical videos, quizzes, as well as the skit. And finally, a final round of applause for our referees, our mentors, who took the time out to come here and be a part of it. So can we have a comment from our international judges while we are taking up the marks on what they felt about this? Any comments? And the election party. Ma'am, can we have a comment from you?
So I learned, I'm Zan from the Philippines. I learned now that YOSO is not just all academic. We can all have fun, we can be friends here and learn so much from each other. So we can bicker, we can make jokes, but in the end we're all just colleagues and friends.
Right, thank you so much. Tetsi sir.
Okay, thank you. I'm from Nepal. So I don't know about Azam, but do you understand Hindi? A little bit. Okay, so I understand Hindi a lot. So I think rest of the judge was a little bit confused in the skit person, and I enjoyed a lot of it. I understood a lot. So yeah, let's see what the results are. And unfortunately, I was not in the first two sections, so I've refrained from voting in the first two sections.
All the teams
because
are.
I was a co-chairperson in another session. That's why.
All the teams are saying, "Hum dekh lenge aapko."
Hello, I'm Niti from Thailand. Okay, it was very fun, very informative, and thank you for having us here. Yeah, too bad I don't understand Hindi, so I don't get much what you're saying in the skit. So if someone could translate for me, you can WhatsApp me later.
We'll have.
He was saying INC was the best.
Okay.
Right. Sir, can we have one comment from you?
Hi, I'm Mazdam from Maldives. This is very, very interesting and very fun, I think. And I'm also very curious to see who will win this time.
Hi, I'm Dr. Saminder from Sri Lanka. So this is quite interesting. I mean, so the first time I saw a war kind of thing with the political backgrounds and all. So I mean, it's quite interesting. So how the ophthalmology related to politics, and so having a war. So it's, I mean, I wish you all, and so it's great pleasure that we came here, we participate the event, and so we can, I mean, the friend with a lot of people, and so we can communicate, and so hopefully you will come to Sri Lanka one day also. So we will have this kind of meeting in future. Thanks a lot.
Thank you so much, sir.
There is a different theme for every year. So last team it was on mythology.
I just want to say that this thing cannot be replicated in Sri Lanka. Then he will be in jail.
So basically we have a theme every year. Last year was mythology, and we continue. Next time we'll have another theme.
Sonal ma'am.
Yeah, so a big cheer and applause for all the organizers who worked so hard and created such interesting scenarios and slides. The only submission that I have is that we should have, given a little bit of background to the international judges so that they understand the context that we are talking of. We all had great fun, and I hope that we can just explain to them also, a little bit about the whole thing.
Right. We'll have a comment from Nikun sir. And then is there any volunteer who would like to explain India's political situation right now? Take that risk.
Yeah, I think we'll ask Bhavya.
Bhavya can try.
We can ask Bhavya for that, and he'll have a comment about it. So, so amazingly organized ophthalmic was. Last year I was part of it, so I know that it is always fun to be in this kind of session. I hope everybody enjoyed, and we can have this session again on the bigger stage every year. And I congratulate all of the YOSI team.
Thank you so much, judges. Dr. Bhavya, would you like to take a shot at what's happening? So, on request of Sonal ma'am.
INC has always taken a lot of shots.
So BJP is currently the ruling party, and the International Congress was the ruling party before that. And the Aam Aadmi Party and DMK are state parties, so they are also competing. And they are national party. I'm so sorry. They are also a national party and ruling party in a small union territory. Right. Just a quick word on what's happening after this. So 1:30 to 2 p.m. is lunch, and we commence once. Lunch is Karan sir.
Lunch is going to be served on the right of the registration area. It's in the same floor only. Okay. And 2 p.m. we will gather back. We have back-to-back sessions in all the halls still continuing. Here we are going to have the international YO session. Okay.
So, judges, referees.
I think what do the teams besides BJP feel that they have any chance left? They are asking me to announce. That's why I'm asking. That's what. Because even the judge admitted he did not know which team is going to win. So it was all rigged. BJP has rigged probably. So do you want me to announce?
Because you
sure? Okay. Then come on.
I think, I don't know about the results of the general elections, but here we have a massive
win for Congress.
For Congress. There is a huge upset. See, BJP is nowhere in the scene. I don't know. So massive win for Congress. Congress is number 1. Number 2 is Ab Ki Bar, behind the bar. And third is BJP.
Regional party. It has to be.
Yeah. And fourth is DMK. You have to, Prasanna, you have to distribute more lungis in north if you want to make an impact.
नहीं, उसका हाथ busy रह गया, इसलिए he couldn't get the votes. His hands were busy.
So prizes will be given in inauguration. So we'll take one group photo. Yeah, sir, can you come?
Yeah.
She can't believe Congress won.
Ma'am, you won. So everyone please come. Yes, fine, sir. Nice to see you again.
Good. साला आज क्या करता है
They are, yeah, true to process, yeah. Thank you, sir. Thank you for being a part.
You organized very nicely. तेरे साथ फोटो लेते हैं. You take very nice selfie, ना? एक ही मिनट.
We'll take it in that background. That is yellow light.
All right, good afternoon everyone in the hall and people watching on the live stream on our YouTube channel. We're now going to start the afternoon post-lunch session. Hope you all had a short break. And in this session, we're going to talk about the international YO activities that are going on across the globe. We are extremely lucky to have with us, eminent young ophthalmic leaders from across the globe. And to begin with, we'll start with Dr. Chris Zana, who's here from the Philippines all the way. And thank you for being here, Chris. And we look forward to hearing from you about the activities that are going on in the Philippines.
Thank you so much for having us. I am Chris. I'm also known as Zan from the Philippines. So this would be my report about the Philippine Network of Young Ophthalmologists, or PNOY. So for most, or for some of you, Pinoy also means Filipino. So when you say I am Pinoy, that means I am Filipino. So this is like a double meaning. So Pinoy as a Filipino and as part of the young ophthalmologists. So it's a affiliate subgroup of the Philippine Academy of Ophthalmology, or PAO, which was established in 2020, and it aims to empower Filipino YOs, those younger than 45 years old. So we just changed this. It was initially 40, but then we moved it up to 44. It is done to promote leadership, camaraderie, and excellence. It is an ad hoc committee that reports directly to the PAO Executive Council, and the PNOY chairperson is appointed by the president of the PAO. So our vision, which we just had a strat planning about this, we were able to make up our vision, which is to achieve excellence in eye care by empowering Filipino YOs, by fostering supportive community and providing opportunities for professional development. Mission is to foster an inclusive and diverse community that empowers, inspires, and supports Filipino YOs through collaboration, advocacy, and volunteerism. Our objectives are divided among the short-term, mid-term, and long-term. For the short-term, that includes resident representatives, like what I'm doing now, networking events, empowerment workshops. As the midterm objective, we'd like to be able to be a standing committee that would be able to lead PNOY resident board exams, reviews, leadership development programs or plans like the LDP. And long term, we want to be a standalone committee. We have an executive council. Most will have learned or have met Dr. Chaitan Lapko, our chairperson. And the executive committee is divided into 4. We have education and advocacy that creates topics for PAO-YO segment and webinars, gives access to educational resources, and also makes support groups for residency and fellows. We have the social media subcommittee that curates or works on our PNOY Facebook pages and Instagram accounts for promotion engagement. We have the external subcommittee for extracurricular activities and sponsorships. And we have the membership committee that would establish our bylaws. So these are just some of our activities. We have the social media platforms. We have Instagram and Facebook, which has now more than 700 members. So this is our main form of communication that give news and announcements, release polls. We put up scheduled posts and cases and even reels. And this fosters connections, encourage engagement and inspiration to and among the members. We have a Motivation Monday wherein we post inspirational quotes. We also have Pinoy of the Week where we features our young ophthalmologists and how to be yo, which will feature mentors. Here an example is Dr. Ruben Limonchon, who explains why he became an ophthalmologist and why he chose external disease and cornea. We also have cases that we present here. These cases are from the YOs, those that they see in real life and in their clinics. We also show different pictures from the YOs. It is also our source of announcing new and giving news. So for example, if it's a glaucoma month, we would showcase that. There's also a thread for pre-loved items. So anyone from the YO can actually sell their items online. We have a Pinoy electronic bulletin where the YOs write up are posted. And the e-focal point, that is the official publication of the PAO, has a YO section. We also have a YouTube channel where the videos that are seen in the closed Facebook page are posted for public viewing and sharing. We make contests to be joined by the YO. So we had an ROP infomercial with different prizes. We have the photo contests. And in the annual convention, we also have a little tarp or a little part in the convention wherein the most number of likes in Instagram or Facebook will win a prize. So as you see here in the far right picture. We have webinars, which we do locally and in collaboration with other organizations and societies. So for example, with YOSI, we had that before. This could be academic or non-academic. The non-academic could be an example here, Adulting 101, which is a tax guide for doctors. YO sessions in the ASEAN Ophthalmology Society and the Philippine Academy of Ophthalmology Convention was just done. So we had 2 sessions. One was about the foreign fellowships, the ASEAN experience. And we also had one about YO empowerment for fashion, tech, and AI. We also had a cocktail night wherein we invited mentors. They were in stage, and then we interviewed them live. Of course, there was drinks, food, and everything in between. And we also have YO representation in various international events. Those in the APAO Rising Stars, we had those in the Taiwan Society of Cataract and Refractive Surgery, YO International Leaders Meet and Greet, the YO Global Summit in Singapore, the APAO events, just like one in Bali, and the LDP. So these are just some of the pictures. For future plans, we would like to establish our bylaws. We want to finalize our directory of fellowship and all YOs. We want to have more training and research opportunities and representation in international events and projects. Thank you again for having me.
So I think that was a very interesting, a lot of activities you're doing, and I particularly like the Binoy of the Week concept. And you're featuring about almost every week somebody is there that you're featuring, or how?
It's not usually every week. It depends on how stressed or toxic we are. But usually at least once a month there's a YO that we're featuring. So if we have YO that's presenting or won a contest abroad, so we will post that, and then we will tell them how she or he got that award, the fellowship, opportunities, etc.
All right. So that's pretty interesting. I also like the kind of integration you have of the seniors with the juniors, and so that's also a good thing that you're doing there.
Yes, thank you.
Excellent presentation, Dr. Chris. I would want to ask how YO has transformed at a ground root level at your place. So how things have actually evolved over the last couple of years when you have actually started doing your activities, and how do you actually look up with respect to having exchange programs, since as I saw the last slide which you said you have representations to different platforms. So what do you actually as a society would incur with time, that this is what will help us both ways, as at a ground root level as well as to an ophthalmologist per se?
Yeah, so as you know, the Philippines is made up of several islands, so it's very hard for us to go from one place to the next, traveling. So most are done through social media. We use Viber, we use WhatsApp, we use Facebook. So that's where we announce, that's where we interact with the different YOs. For me, for example, I'm 12 hours away by land from Manila. So it's difficult for me to actually join the meetings unless it's online. So that's why most of the executive committee members are within Metro Manila. So it's easier for them to really meet up, because it's still different if you're doing the meetings, face to face. So mainly social media was able to give us a ground to be able to know the different YOs in the different islands. So we also have representatives from different the different regions. Yeah, so we have like a point person, and what we do is, if for example a YO was invited as a standalone person, not as a YO representative, was sent to, for example, the Taiwan refractive cataract surgery. So we would ask if he can also stand as a YO, represent the YO. So he gladly did that. So he would usually also add it in his slide, or he would also put it up in his page, and then we could also add it in our page in the YO. So that's how we do it. It's more of partnership and connections.
We should also look at ways how YOSI and Philippines can collaborate further. We'll discuss that. Yeah.
Yes, yes. I think that's why it's really good that, for example, Dr. Chai has been very active, and collaborative with the different organizations. So we're looking forward to partnerships and collaborations. Thank you.
Thank you, Dr. Chris.
Thank
Zana,
you
for that lovely talk. And let's hear a perspective from the Maldives now. So, Dr. Azam, if we
Dr.
could
Azam, yeah.
have you come and tell us about the YO activities in the Maldives.
वो था तेजू का था is there. Last.
So thank you very much for your kind invitation. I would like to thanks to Dr. Divakant and Dr. Karan, and also congratulations for YOSI for having such a fantastic conference. So I was given a topic actually to speak about the training opportunities for young ophthalmologists in Maldives. And unfortunately, most of the ophthalmologists are already old. There are very few young ophthalmologists. And there's nothing much to speak in this sense, so I will also speak about my journey as an ophthalmologist in Maldives. And I will also tell about what young ophthalmologists are doing in my country. So, how many of you have been to Maldives? Divakant, you have not?
Not yet.
Yeah.
You've not invited me as yet.
I am inviting you now in front of everyone, please. So everyone is invited to join us. So I'll show you some videos. So this is a drone captured video that I have made just very recently. And this is our country. It is divided to atolls, and atolls are divided to like thousands of islands, small islands. And we usually travel between the islands in a speedboat. And this is our capital city. It is highly congested, I would say. A lot of population living in a tight, crowded space. And we have people from many nationalities, expatriates, Indians, Bangladeshis, a lot of Filipinos, and a lot of people from Thailand, in fact, and working in Malé and in resorts also, and also Sri Lankans here. And our country, we are best known for the highest rate of divorce. So if anyone is interested to get your second wife or your, another spouse, you know where to come to. It's open. And I'm actually very blessed to live near the water. This is just 2 minutes from my house. And in the evenings, you can just go out and sit and just relax, although finding the time is the problem. I work in government setting and private setting also. So on the right, you can see Dharmavanta Hospital. This is actually an annex building of the first government hospital, Indira Gandhi Memorial Hospital, which was actually an aid hospital by Indian government. And this is the view from my office in the annex complex. And this is my team. I am leading the team here now. And we have few ophthalmologists and few nurses actually in our hospital. And we also have some private hospitals which cater to our population. We have roughly around 12 to 13 active local ophthalmologists, but then we have some foreign doctors also working for us to fulfill the lack of doctors. Going back to my student life, we did not have any medical university at the time, and even now also we do not have any post-graduation program. So I spent 6 years in Russia initially to do my MD program, and then after that I did a rotation of my internship in Bangladesh. I did my MD ophthalmology from Nepal for 3 years, and you can see some of my friends here, and I think you know some of them. And this is my classmates, and I also did some trainings here and there. You know, locally we could not find anyone to mentor. This is actually our the areas which we lack. Got to experience a lot of camps, how things are done, and learn many things from many people from various levels to bring back and implement in our country. So what I learned and realized is you can learn something from anyone. You can learn any advice, you can learn even if it is something small and simple. Learn everything from each and everyone. These are some of my mentors. I'm very fortunate to have mentors who are always available, very readily, always helping in anything needed. If you need any instrument, if you need any guidance, anytime they are available. So I'm very fortunate and blessed. Once I came back to Maldives, I had a huge challenge because I had to be I'm the only vitreoretinal surgeon in the country, so which was very challenging. So I started vitreoretinal services and ROP screenings, injections, lasers, and everything. And I also helped the government to get funding from there was Chinese aid, and we opened another ophthalmological center in a nearby island, which is actually connected to Malé, part of Malé. It's called Hulu Malé. Right? And I think this is one of the highlight of my career. I would say I had the pleasure of hosting SARC Academy of Ophthalmology in Maldives last year on September. And I think everyone really has enjoyed. Could you put some music? Is it coming? Right. Could you put the volume music? Okay. This was from the event. I just wanted to show everyone. Lot of people came from India, Bangladesh, some from different places, and everyone has really enjoyed. And I think this was the highlight. We had a beach party, beach dinner. And what you see is our traditional dance and dress. I think and Karan has somehow convinced me that I have to wear a traditional dress tonight. So I guess I need to do it. So when I'm not doing ophthalmology, this is who I am. I'm a fisherman at heart because, our parents, our grandparents, and everyone before them, they are fishermen. So I love to go out in the water, spend some time in the ocean, and that gives me calm and peace. And you know, we have abundance of fish, so whenever we go, we catch a buttload of fish. And of course, we have to cook it and eat it. That is the best part. These are some of the dishes that I've cooked by myself. And of course, food is always enjoyed best with company. And try to come and visit Maldives to enjoy. This was just done about 1 month back. You can come and swim with the sharks, enjoy. You know, I think everyone will really enjoy, you know. And you don't need to know how to swim. You just need to know how to float. And we will put, if you don't know how to swim, we will put a life jacket on you. These are swimming with manta rays. So this is a very special person. He is my mentor actually. He does not know how to swim. He was just with me recently. And look at him. He's like Superman underwater. This is his first time trying to dive. And he really enjoyed it, and I think he really loved it. And I think all of you can do this. And you can see the underwater beauty if you come and enjoy with us. So this is an open invitation for everyone. So please, I hope you enjoyed my talk. Come and have some time with us. Hopefully I will also try to arrange some conference. Maybe you could couple it with something. I know how hard it is to get away from work, and all of you must be very busy also. Once again, thank you for inviting me here. If you have any questions, please.
Thank you for taking out the time and coming, and thank you for giving us a glimpse of, you know, what we are missing by not being in the Maldives.
You should come, absolutely. You must come.
And
it would be my pleasure to show you around, please.
I think that day will come. We'll hopefully be there. But it's also very interesting to see that I mean, there are a lot of opportunities within the Maldives itself, as you are showing, both in the public and the private sector as well. And so how is the healthcare system? It's primarily public, or it's primarily private, or it's really about 50-50?
So what we have is, we have the insurance actually, government insurance is there, which is actually a very good thing. At the same time, it is bad also. What I mean is, like, for example, let's say in terms of ophthalmology, let's speak. For the things that you cannot do in Maldives, the government mandates them to be covered in insurance. So usually people sent to India. Of course, India is the closest. They go to India or to Sri Lanka, sometimes Malaysia, and our insurance scheme covers the procedures which are not available locally. But this is also very bad for us in some ways, because then there is no need to develop these things locally also, you know. And this is one of the reasons that I am advocating to try to develop our local doctors. Before me, there was no subspecialist. And since I came, I have managed to convince 2 people. One person is going for a glaucoma fellowship and already left for glaucoma fellowship, and another one, you know, Dr. Numa, she has already gone for pediatric ophthalmology. So I think this is a good beginning, and I am also trying to convince someone else to go for cornea and oculoplasty, but still struggling. But I think something will happen. Let's see.
Excellent, Doctor. I think this is the way ahead. We have Dr. Bhavan Kule sir here. He is a part of the national faculty, which we have the AIOS. So having an exchange program is the next thing to actually have a next generation of preparedness, because now people are going into more specialty based work. So having exchange programs where you can send in for fellows, so if you can have, and we can send mailers, and somehow we can get through YOSI or maybe with the portals, and then we can get people from here, or we can send people either ways where they can go and enjoy as well as work.
This is actually a fantastic idea. So the problem I mean most of us have faced before is that there was no person to guide. No one is acting as a bridge. This is what I faced. Getting a fellowship, there is no mentor, no senior to guide me, to advise me, you should do this, you should do that, you go there. Like once I trained and came, this is what I wanted to become to the rest of them. Since I did not have a mentor, I want to mentor them. I want to guide them. I want to tell them you should go and do this. We need this. We have the data, get the data from the government, the insurance schemes, you know. So I think we are going towards the right direction now, but it will still take some time. So if I can be the bridge, of course, this would be a wonderful opportunity to all of us, I think. Please.
Our international international relation president is Professor Dr. Lalit Verma.
Yes.
Okay.
Yes.
So this year we have adopted one island called Samoa, which is close to New Zealand. So henceforth we will be we are going for the first time. Me and President Sir are going to Samoa for giving some medical facilities and helping them out with some backlog of cataracts and retinal diseases. And it is going to be an ongoing program for that island. We have decided to adopt on behalf of RANSCO. People approached us and they asked us to adopt that particular island at this point of time. So I think it's a nice opportunity. You have a good relation with Dr. Lalit Verma. Yes. So if you write to us in formal, we would definitely have people with you who we can send young brigade who can help you out in means at least tackling the backlog of various diseases once you study what is the backlog. And we would be happy to cooperate with you as well.
Thank you so much.
May I next invite Dr. Niti from Thailand. So he'll be telling us about the various YO activities that are happening in Thailand.
I want to go to Bali again.
So AIOS is now in talks with, I think, SNEC Singapore for an exchange program. So similarly, hopefully, AIOS will also have collaborations with other countries and institutes for similar collaborations.
The only challenge with us is about the exchange. Means exchange is between
both
the universities. That is the challenge. We would have to look into that particular part of it. But yes, for any form of assistance, and rather than using a word assistance, we can definitely be a part of adopt, because otherwise also Maldives has always been like a one of our friendly countries. So we will definitely associate with them, and any other such countries which you come across, we will put it across to our international relation president, Dr. Lalit sir, and he is very keen to do all these things.
True. Yes, please.
Okay, good afternoon, everyone. I'm Niti from Thailand. Okay, so I'm sharing you with everyone the activities we are doing in Thailand. Okay, so I'm telling you a little bit about the history of the Thai VIO. Okay, in the past, there were attempts to create the Thai VIO network, but unfortunately, it didn't survive. So then I and my team created a Thai VIO network as a part of the APAO LDP project last year. So we are just created about October 2023. So we are less than 1 year old. So we are still an infant society. Assam has sold the Maldives, so I'm selling you Thailand too. Okay, this is called Wat Arun. Okay, this is the riverside temple where you can sit at the riverside dining while watching this view. And you can also take the cruise around in the river. It's called Japaya River. You take the cruise and you can get this view also. Okay, I'm selling you my country also. Okay, so we just elected to have a Thai VIO committee. There were a president, a vice president, a secretary general, that is me. and a treasurer along with 11 additional committee members. And we got 2 advisory consultants from our Royal College. And for the photo, this is the Royal Palace. This is the in the past where the king lives in Thailand. And in below, that is one of the staple of the Thai food, that is pad Thai. You might have tasted that. I think there are a lot of good Thai restaurants in India also. Yeah, you should try that if you haven't tried it. It is kind of, yeah, nice to try. So, what have Thai Bio has been doing so far? We had the first ever Thai Bio session back in the October last year. There were introductory sessions with our mentors and special lectures by Dr. Carol Shields from the Wilshire Hospital in Philadelphia from the USA. And we are lucky to continue our activities in the Thai Bio. We were successful in continuing our biannual conference in conjunction with the Royal College of Thailand. And we also had a Thai Bio logo contest just last year also, and here's the winning logo. So we now have the logo. We are very new, so I'm sharing you the story how we created it. Okay, and there's a lot of scientific sessions going on, and like this is the FACO session, and that's me on the stage. And we also have the networking sessions to connect all the Thai bios. Okay, and same as other societies, we also launched an official social media channel to facilitate knowledge sharing and to provide updates pertinent to young ophthalmologists. And here's our Instagram, vio.vio.thailand. So if you are okay, you please pick up your phone and type vio.vio.thailand and follow us. We need a little bit more followers. Thank you. vio.vio.thailand. Okay, and now we are expanding our society to have the internal collaboration. Yeah, we are lucky to finally be a part of the APAOYO just this year. Okay, we had a lot of fun with the bios, with everyone here. I have met with most of you before. Yeah, back in Bali and back in Singapore. Yeah, I still felt a little bit dizzy looking at this photo. That night was very wild to remember. And it's going to happen again tonight, right? It's going to get crazier. Oh, it's going to get crazier, okay. You bet it. Okay, and back in January, we also attend the second Global Young Ophthalmology Summit in Singapore. Yeah, thanks to Dr. Marcus for inviting us. We had a lot of networking and we had a great time there. And not to miss YOSIcon, yeah, just last night. Yeah, we had a dinner with the faculty. Yeah, thank you for inviting us again. And that is me in the trying to meditate in one of the place. I forgot the place name. Yeah, that photo was from yesterday, yeah. And so that's what I and my fellow bio committee did in the past year. So I think it would be great to have more collaborations with all of you guys, like the MOU, international bio meetings, skill exchange, and doing some research together. And as you can see here, coming to Thailand is not very expensive. Yeah, there's a lot of direct flights from Delhi, from Manila, from Nepal, from the Maldives also, from Sri Lanka to Bangkok. Yeah, so maybe at one time, I invite you all to Thailand too. Thank you very much. And here's the QR code. You can scan and see what happens. Thank you.
Thank you so much, Dr. Niti, for the wonderful overview of Thailand, not just as a country, but as what all you are doing for young ophthalmologists. And what exactly do you want to do in the next maybe 1 year for young ophthalmologists, apart from what you've shared here?
Yeah, I think the next step for the YO is to, I would like to create a mentorship program in my country where the young ophthalmologists can keep connect with the mentors for some of the skill exchange and the research opportunity and also the training opportunity. Because, yeah, you know, after the training in the residency, there's not a lot of fellowship opportunity yet in Thailand. Yeah, we are trying to expand it.
Thank you so much.
Thank you.
Next, I would like to invite Dr. Saminda to share the YO activities in Sri Lanka.
Good afternoon, everyone. So first of all, I would like to thank YOSIcon to having us here. So this is a great opportunity to meet the people and communicate with the international delegates and all. So, and special thank goes to Dr. Divakant and Dr. Karans to communicate with us and so having us here. So actually, as two others are saying, our young ophthalmology society also very new, so it less than 1 year old. So because of that, you know, our country is having a lot of financial troubles and the political troubles. Because of that, I mean, we haven't had that much of opportunity to do much of work during the last year, but this year we are planning to do much work. So I'll brief out what we have done in the last year. And actually, we were trying to establish YO for a couple of years back. I mean, Dr. Sagara was started YO Society, but it didn't last long. So, but after having few talks, we thought, okay, we need to initiate the program, and we have a lot of opportunities with the internationally and inside the country to power the young generation to go beyond their limits. So because of that, we established the YO in 2023. First president was Dr. Chamara, and this year I was elected as president, and I have 2 joint secretaries and 8 council members. So as past activities, so we have done a glaucoma workshop for trainees. Actually, in Sri Lanka, not like other countries, we are part of college, the main college. It's not I mean, we are not an independent body. Because of that, every time they are doing workshop or something, we get a chance to present and all. So because of that, it's less number of Y or only activities. So this is one of that. So we have this is our past president of the College of Ophthalmology, Dr. Kapila Bandhutilaka, which he was a well-known VR surgeon, and so he was a mentor to start the YOSL in Sri Lanka. So, and we organize a glaucoma workshop for trainees, and we invite a lot of speakers around the country to give the knowledge to them. And these are the initial YO group. And the next, what we have done is a motor rally. So basically the college is doing much of the work, educational work. So we are getting opportunities. Because of that, we thought, okay, we need to go with some social activities as well, because we need to get together and have communicate with the seniors. And for those kind of things, we want something different rather than having a night or something. So because of that, we plan a motor rally. So for the motor rally, we I mean, gather with the families, and we had a lot of fun, and we had mix with the seniors to share our ideas and share what we can do and everything. So this we have done with the night to celebrate with. And then we have conduct few leadership programs. So because Sri Lanka, we have lot of places we can visit and do leadership programs. So because of that, we thought, okay, I mean, we go more beyond the educational limits. So we plan few leadership programs. These are the pictures of the leadership programs we had and YOS are enjoying. So actually, those are the things we have done in the last year. And so this year, after I'm being the president, so the first few months was a little bit of in silent because of we had a lot of things going on the main college, and the activities are starting from this month. So we planned lectures for the trainees, and we started doing small group discussion programs for the who are sitting for the exams, because you know our ophthalmology community is very small. So the last few years, I mean, every time only 1 or 2 will be passing out from the exams. Because of that, I'm the senior ophthalmology crowd is very small, so around 40 to 60. So because of that, now only the people are passing out the exams and the trainings are coming out. Because of that, we thought we need to empower them and we need to give assistance to them. Because of that, we are planning a lot of educational programs for them, and the small group discussions and the activities with the cases and all. And the same times we need to get together and have some fun, and we need to communicate with the people and the senior guys and mix with the senior guys. Because of that, we are arranging a lot of fun activities with mountain trekking and those kind of things. And the same as the leadership building programs. And we thought of having a YO Day, academic event with the fun activities probably. So we are in discussions, so probably we might have international delegates as well. So I would like to invite all to participate if you have the opportunity. And the same time, this year we are having Colombo, Sri Lanka College of Ophthalmology meeting. So a lot of foreign delegates are participating with the local ones. So I would like to invite all to, if you can manage the time, please participate. You will get a lot of knowledge from the. And the same time you can visit, it's a small country, very beautiful country. You can visit a lot of places and you can have a lot of fun other than the academic things. So this is some of the pictures from my country. So maybe a lot of people have visited from India. So if you haven't visited, or so if you like to visit again, so please visit. So I would like to invite you all to participate in the college meeting, and so enjoy in Sri Lanka. Okay, thank you. Thanks a lot.
Dr. Minda. Now, may I invite Dr. Teju from Nepal to come and give his perspective. And yours was a very interesting meeting, and I think Sri Lanka again has a great friendship with India, and I'm sure we'll have lots of collaborations going forth as we both grow, our US societies grow further. So, but in interest of time, let's move on to Dr. Teju now.
Presentation, please.
Good afternoon, everyone. So today I'll be presenting about youth leadership in ophthalmology. So I'm Dr. Tesu Singh Malla. I am a Apawa YO Standing Committee member. I'm an executive member at Nepal Medical Association and a treasurer at Nepal Ophthalmic Society, and the founder treasurer at YO Nepal, and a founder member of Young Doctors Association. So, why youth leadership is important? So, leadership development is most neglected subject in our medical studies. And after graduation, at times we found ourselves in situation where we are required to lead an institution, but despite our good medical knowledge, we fail. Like Azam, he is a good surgeon, but maybe he didn't get so much youth leadership skills, and now he has been given the opportunity to lead the ophthalmology field in his country. So, but still, we lack the knowledge of administrative and management, law and policy, public speaking and media, communication and conflict resolution, which is essential component of good management and leadership. So, Robert Hart's ladder of youth participation means there are 8 steps of youth leadership. And the first step is manipulation. Manipulation means the youth does as the seniors instruct. And only at wrong 7, step number 7, youth initiate and are directed. And only on the 8th, youth initiate a shared program where they and the adults or seniors work together. So I often like to tell leadership is like a team taking a gym membership. So some take it by choice, which is an interest, and others due to peer pressure. You should represent us. That's the word. And some shows up daily in the gym, which are they take active parts in meetings and discussions, while others never show up and they always have an excuse. And some get up early to make time. So time management is very important. We often hear people saying that I don't have time. So time management is very important. And others make excuses, but that they're too busy. So it's all about priorities. Some go and work out the full time in the gym. So that is efficiency, while others goes and spend most time gossiping. They are in the gym for 2 hours, but how effectively they are working. And some focus in overall development. There is a leg day, there is a chest day, there is a bicep day. So that is a routine. While some focus is only on a few things, maybe only on biceps. So that's opportunities and self-development. So, but whatever matters is your consistency. It may be few months or few years, but the result is achieved. And 80% of success is showing up. That's what Woody Allen told. And this is Joe Biden, 46th president of USA. So he became the president at the age of 78 years old. While this is Theodore Roosevelt. He was the 26th president of USA. And he became the president at the age of 42 and had already retired at the age of 50. So this is Barack Obama. So he was the president at the age of 47 years. And his vice president was 67 years old. So in leadership, I believe that age is just a number. We need to break the myth that leadership can be taken only with certain age, similarly to once believed myth that men only can lead. So what is leadership? So leadership is influence of personal power that creates progressively advancing community to achieve the common goal. And you can't rule the people in the 21st century. You need to motivate them. Leadership is an active, living process. It is rooted in character, forged by experience, and communicated by examples. So leadership develops daily, not in a day. And it is a group effort and should not be dependent upon only one person. And leadership on paper is not a leadership. Leadership in action is a leadership. So the main foundation of leadership is trust. And once it is broken, you can never get it back. And good leadership requires you to surround yourself with people with diverse perspective who can disagree with you without the fear of retaliation. So successful leaders have the courage to take action while others hesitate. The best leaders are passionate about developing emerging leaders because true leaders don't create more followers, they create more leaders. So how you guide your path in leadership depends upon yourself. So, leadership development is an important for overall success of any organization. And in order to lead an organization, first we need to develop ourselves, lead ourselves, then we lead others, then lead an organization. So there is a bounce in leadership. In our earlier field, in our ophthalmology or any field, we focuses on technical skills. But then there comes a critical point when we focus more on leadership and strategy skills. So there are 5 practices of effective leaders: challenge the process, inspire a shared vision, enable others to act, model the way, encourage the heart. So what are the qualities of effective leaders? So there are lots of qualities, maybe more than 20. But for me, it's trust, time management, empathy, just service, and unity. So my name also comes with Tetsu. So these are the initiation. So TEJSU. I always remember that. It's a mantra for me. So there are lots of leadership styles. One is dominance, consciousness, steadiness, and influence. So, but whatever the leadership styles may be, a leader should know law and policy, communicate and conflict resolution, media, and public speaking. So there are lots of important leadership skills: team building, emotional competency, first thing first, that is time management, advocacy and negotiation, networking, listening, public speaking, and dealing with difficult people. We often find this kind of problem in our organization. So I will skip the team building part. Okay. So there was a project Aristotle about what makes a team very effective by Google. And it was found that it was a 3-year study. About 180 Google teams were part of it. And there was over 200 plus interviews and analyzed over 250 team attributes. So the first thing was psychological safety. Psychological safety is that your team knows that you have their back. And structurality and clarity, dependability, meaning and impact. Let's skip this part. Okay. So we need to build a team so strong that they don't know who the leaders are. So this is my team. I'm very actively involved in Lions Club, and all of them are potential leaders. They are next in the line for presidency, and it's a very strong and effective team. And this is my team in YO, Nepal. So there is our president, Dr. Kausal, Dr. Rosiza, Dr. Anadi, Dr. Ravindra, me, myself, and Dr. Amit. And we have all been elected as executive member in Nepal Ophthalmic Society a few years back. But then I was the only one who persuaded further because of time management. So our So, okay. So, so what our team is doing as a YO, I would just want to add for a few minutes. So right now, we have just registered our team. Although the YO Nepal was initiated in the year 2022, we are still working. We were still working on the legal aspect, and our YO society is independent from our ophthalmic society, Nepal Ophthalmic Society. So although we work closely, we have our own process of work, organizational structure. But we work very closely with Ophthalmic Society, Nepal Ophthalmic Society, and they have presented us with lots of YO session. So recently we had a conference in Biratnagar where there was a YO session, and it was a very nicely initiated, and people loved the session. And similarly, in the we are planning for a YO night, maybe a YO conference, and we look forward to collaborate with different YO organizations. We have had YO mentor session with the newly residents who have just entered in the field of ophthalmology, and we guide them whenever they need our help. And we are looking forward to have another session of YO mentoring the residents maybe in 1 or 2 weeks, because currently a new currently a new resident session has been initiated, and right now there are fresh residents who have just entered ophthalmology. So my take-home message is that anyone can become a leader irrespective of their gender, birthplace, and background. So you too can become a leader. Thank you.
So wonderful insights from all the YO leaders, particularly in the Southeast Asia region, and thank you so much for being a part of this session. At the outset, let's get everybody on the stage for a group picture, and I would conclude the session. I hand it over to the next people. I think the next session is the finance session. His flight is changed. Start karo.
Hello, good evening, everyone. So, welcome to this session on finance for young ophthalmologists. I welcome the chairperson, Dr. Bhavik Panchal, co-chairperson, Dr. Neeraj Shah, and my fellow panelists, Dr. Nilesh, Dr. Prakar Goyal, Dr. Raki is here, and I am Dr. Madana Gopal. So, to begin with, we'll have Dr. Sandhya Makija Madam to speak about FBS and what's the benefit for young ophthalmologists. Please. You ready?
Hello and good afternoon, everyone. Good afternoon, young people. I feel young here when I'm here with all of you and feel so good here. And I congratulate Dr. Karan and the whole team for a wonderfully organized conference and inviting me here for this finance session. So basically, just for an intro, for the background, that we have this scheme through AIOS, through our AIOS society that's called Family Benefit Scheme. And we've been talking about this scheme for quite some time and quite so many forums for people to know. But I guess we don't have many young members still in our scheme. And we want to know that how it is beneficial for younger people. So we thought that we'll have this as a keynote, and pardon me if I exceed my 7 minutes. I hope it's acceptable.
Solace and compassion.
So here it is FBS AIOS scheme, we protect your family. So just to have a background, we started in year 2004. This scheme was started by our members and for our members. All Indian ratified AIOS members are eligible. There are death benefits for all causes except suicide and homicide, of course some little clause. Each member pays a one-time admission fees depending on whatever age. There is an yearly contribution, and yearly contribution is given to the members who are deceased. These are the FBAOS, AIOS initiators, our stalwarts. And then there is an executive committee members. Then there are zonal representatives from each zone. I mean, this is the organization chart I'm telling you. Then there are like one representative from every state. You know, we call them state representative. And I am also one of them from Delhi. So all states have their representatives. And so this is a scheme one can join at any age. It's a hassle-free online process. And there's some add-on accidental benefits also, which once you go through it, go through the terms and all, you will know. And all 100% claims are settled. So first of all, it's a society formed by AIOS members for the protection of families and members of society. A small amount of yearly contribution, and as the membership increases, the yearly contribution will keep on decreasing. Death rate will reduce with time, and average age is increasing with time. So the contribution, suppose today we decided that we'll give 25 lakh to every deceased person. So if there are more deaths, so more people have to call. So that 25 lakh will be divided into whatever number of members that society has at that moment. So if there are more number of deaths, so, you know, more contribution will be required from each member. Whereas if there are less number of deaths and more number of members, you analyze, you know, much less contribution will be required from each member. We are increasing in very good rate since 2018, and last year we had successfully added more than 169 new members in our society. And new members are constantly increasing with increasing year. And since 2004, till date, FBS has provided more than 65 crores to more than 235 existing members. So this is the age-wise distribution. If you see, we have maximum members right now above 60 years. You know, at younger age group, we have little less members. But now when the people will take membership and, you know, as in and towards later, more and more years advance, we'll have more people in higher and lower age groups also. Just the age distribution, above and below 60. Gender-wise distribution, 20% we have only women. We want women representation, women membership to rise also actually. So this is year-wise death numbers chart. You know, as you see, it was only during 2021, that was a COVID time, we had maximum number of deaths, but over on average, we have 10 to 20 deaths happening in a year from our members. Below 60 years, there were 20% casualties, and above 60 years, 80%. So mostly people who deceased were above 60 years. So this was just for, you know, age and just to know the distribution pattern. Fraternal contributions, we have given lot of crores of fraternal contributions. So what is fraternal contribution? Like every deceased family will be given a certain amount, which will be divided into all the members. So this is what we call fraternal contribution, FC. So now coming back to the question, why you have to join? What is the benefit for younger ophthalmologists? Now we just look at the doctor's career progression and their financial awareness. A doctor will typically graduate by the age of 23 or say 25, and then complete their post-graduation by say approx 27. Then they go on to pursue their senior residency or fellowship or whatever, and usually they complete by 31 or 32 years of age. By this time, most doctors have practically little or no knowledge about finance and investments and stocks and shares and everything. Believe me, even we don't have much of knowledge at this stage. As a result, doctors often start earning and building their financial portfolios later, once they are probably established in their practice or their jobs or whatever, whereas as compared to other professionals in other streams. I think many of you will agree with this. And then they start, you know, having a background and learning about investment schemes. Previously they have no idea about it. So what are the advantages of taking FBS schemes or any other schemes early? I will compare FBS scheme with other schemes also. Young doctors will get orientation about finance, and it will help them in financial planning. Their family will get secured. There are tax benefits, less joining fees. Mind you, I mean, when you start early, the joining fees are actually much less. You know, you can go through the website and I'll show you the screenshots also. Less fraternal contribution, that is the yearly contribution that I just explained, and handsome amount of returns. Membership benefits, assured amount, like presently we have decided the assured amount is 25 lakhs, means it is 25 lakhs, I mean no less, no more. And with time it will increase. Growing membership, there are about 4,500 AIOS family members are connected with FBS, and benefit to the family increases as the membership will grow. Because today, when we are more members, in future, suppose when I pass away, my family will get benefited with more members contributing to it, you know. One has to invest less and get more benefits through FBS schemes. Comparing with other schemes, like before and after COVID, the fee had gone up in other schemes, many other schemes, but here the fees has gone down. Earlier, when we started with the scheme, the fees was something like 5,000 rupees, something now 2,500. And now some special schemes are going on where it's even much less, and even probably 500 for younger people. It is very hassle-free, less than a 1 month time when all the documents are submitted, and the family will get all the claims and all the no hassles, no question asked, nothing. You know, other companies will make you run around paperwork and so many things. You know, it's so difficult to get the claims. And one more thing, other insurance companies pay, say, something like 99.2 if you talk about Max Life, 98% and other insurance companies, but FBS will pay 100% of contribution to the deceased family. There is no smoker or any other health kind of penalty. If you go through the clauses of other insurance companies, they have, like, you know, if one is smoker, they will give you less claim. If one is that, some cardiac problems, stent, they will give you less claim and all those things. But here there are no clauses, no penalties for that. There are reduced admission fees. Fraternal contribution is, say, something like 600 per year probably, and if you have more members, you know, it's even less. But yes, if there are less members and more debts, it may rise also, so that is a different thing. And competitive pricing, other insurance company may initially charge something like 10,000 or something, and they continue to charge that amount every year, which can add up to a lot of you know, amount over time. Whereas if you go through in this FBS, the amount yearly amount actually comes down to very less as compared to other insurance companies. No term insurance has an exit scheme, but here FBS has an exit scheme. Suppose one has an emergency or something and one wants to exit the scheme because of whatever reason, so there is an exit scheme. Okay, I will not go into the details of exit scheme. Let me go further. It is user-friendly. If you see the website is very easy and very user-friendly. Once you become a member and then you log in, you get a dashboard, and things are so easy. You can make payment through dashboards. The receipts are generated through your dashboards instantly. You can download them, save them, or whatever. So it is a very secure and easy payment gateways. If you take membership now, again saying the benefits are increased admission fees after 40, because after 40 the admission fees rises a little. So before 40, for you people, that is the right time to get get started with these schemes. There is a lifetime coverage, tax-free death benefit, increased benefit with more members. So this was the screenshot from the website I've taken, and you can also go through it, and the joining fees has been reduced, and there are some schemes going which is further showing reduction in joining fees, and there are more mortality benefits. So FBS is to provide care and support to the family after the demise of member of the scheme. It aims to lessen the financial burden on loved ones. A handsome amount of benefit is provided to the family, and in return, a small deposit that every member makes during his lifetime every year. It's a form of term insurance with small amount of premium, which is much lesser than any other insurance policy. There are tax exemptions, just coming down to the concept of mutuality. Just a small thing on how to become a member. It's very easily shown on the website. Any ratified Indian AIOS member can become. You need a proof of AIOS life membership and a certificate. Application can be downloaded from the website fbsaios.in. These are the phone numbers. Certain documents that are needed, some medical certificates, self-declaration, nominee details that is needed. So again, in the end, admission process is easy. I just told you. One can join at any age, even as early as 25 years, 35 years. Less than 40 years is advisable because the joining fees is lesser. Hassle-free, very secure. The claims are processed immediately. Believe me, no questions asked. After forms and documents, whatever are submitted, it's very easy. More the members, lesser the contribution, and more the benefits to your family. No salaries of the executive member. Whoever are working for this society, they work selflessly, whereas in other insurance, they will charge you service fees, and whoever are working, their salary and all those things. It is run by your own people. If you have any doubt about it, you can always go back to your own people and you ask them that why is this happening, what is this happening. If you have any problem, you can easily approach them. There are no hidden costs, no surcharges or service fees. Tax benefit, exit scheme is there, and no age limit for benefit. So let's increase our members, let's increase our financial strength. Log in today on fbsaios.in. I appreciate your interest in financial benefits and scheme for AIOS members. We are committed to providing financial security and peace of mind to our members, and look forward to continuing to serve the medical community. Thank you.
Thank you, ma'am. Thank you so much. In fact, I would say our FPS scheme is one of the best, if not the best. So any questions from the panelists or from the audience? If I may, ma'am, when a youngster joins a little early, would it make sense to give them a little more benefit? Is there something in the works? I mean, as you've been contributing for a long time, so.
Yes, that's what I also said in my talk. Once you join early, number one, your joining fees is less, your contribution is less, like you make more members. So in future, more the members, you will benefit everyone and your family also in future.
Like ma'am, some of the people.
Yeah, let's see who are already members of FBAIOS scheme. I'm the one. I can see some members who are not members of this YOSI society. I mean, at least they should be a member by now. And even all you all also, you know, who are the members of YOSI, you must take the membership of FBO. It's actually a better scheme as compared to a lot of other insurance companies.
So ma'am, I had this question in mind. Like I am the member of FBISOS and this scheme since last 4 years. So I just wanted to ask, like other term insurances, they pay a good amount of money, like around 1 CR. I have a term insurance also. For that I'm paying 12,000, 13,000 rupees a year. And that is for 1 CR. And here also we are paying almost the similar amount because we are paying every 4 months. It comes down to 12,000, 13,000 rupees only yearly.
It's not every 4 months. It's till last year it used to be every 6 months. But now, yes, if we have more members, then it will be probably once in a year. And even that will be reduced to a much lesser amount.
Yeah.
And if they commit you 1 CR, you know, in your insurance, whatever insurances, term insurances that you have taken, if you do a comparison, how much amount they will cut and reduce it, they're not going to give you 100%. This is the only scheme which gives you 100% returns. If they commit 100%, they will give 100%. And the settlement of claims is much easy. They are not going to ask you a lot of questions. There, once you submit the documents, they will give you so many clauses. Was the patient smoker? Was the patient had any cardiac surgery? Was the patient, this? Was the patient that? Was there any trauma, any surgery? They're going to cut a lot of things from there.
Yeah. So if more and more members joining, then we can expect that the FC will reduce and the benefit will actually increase.
Absolutely.
With time, then it will be more
that is the main thing.
Thank you.
Thank you, ma'am. Thank you.
Thank
If
you.
there are no more questions, I'll ask our next speaker, Dr. Bhavik Panchal. He'll be speaking on Keep It Simple, your one-page financial plan. Dr. Bhavik. So this is a unique session where we have a mix of speakers, people with diverse backgrounds in private practice, in teaching institutions. So everybody would have a different financial plan for themselves, and every financial plan has to be individualized. So we have a lot of space for discussion. I encourage you all to ask questions if any, so that we can have constructive discussions. Dr. Bhavik, please.
Yes, so I hope everyone is awake and not sleepy post lunch. So let's begin. So it's a very simple talk. It's about one page financial plan. How can you collect and put your entire worth, right, your income, expenses in one page, and can you make it interesting in terms of what goals you have set? Can those goals be achieved? That is what we are going to look at. I do not have any financial interest and there is no conflict of interest here. So basically what Carl Richards, if you have gone through his book, he says that one page financial plan isn't about getting things right. It's about realizing that you will always get things at least little wrong, right? So life will happen. So why do I need a one page financial plan? It reminds you of your clearly articulated goals. It provides simple and concise next steps for you and your family. It helps you save time, reduce stress, and once again pursue your goals. The goals can be short term, long term, we'll look at it. So financial planning basically is a process of managing your financial resources in a way so that your short term and long term goals of the family or the individual are met. So let's look at a business. Okay. So short term goals will be to carefully formulate a business plan. Say someone wants to start a hospital, right? We'll come to that example as well. To raise capital for financing the business and implement it within the cost and time estimates. Both are important. You have a budget, you have a time limit which is there, you should not cross that. Okay. And this involves capital budgeting to achieve operating and financial performance comparable with your peers. Avoid debt until its debt servicing ability is established. So that means avoid risky debts. Especially ophthalmologists seeking to be their own must keep financial risk to manageable levels, because our main work is patient care, okay, and along with that, if you go into finances, we may compromise there. develop partnerships to share investments capabilities, and this will minimize your risk as well, right? Look at profitability, that is cash flow. That is very important. How much cash flow is happening? Eventually, business should not go out of business, right? And you should mitigate by constant innovation. How to strive further. Long-term goals for any business or any hospital would be growth. Or we have right now a lot of mergers which are happening, acquisitions which are happening. So a good profitable exit is something which we are looking at. So you should focus on things that matter or things you can control, which are in your hands. Whereas if you look at an individual, the short-term goals are meet your day-to-day financial needs, implement your financial plan so that your future goals are through, okay? Like set up an hospital, that should be your plan for that, okay, how you're going to plan it. Real estate ownership, family requirement like your education or your children's education, health, etc. Insurance, what we just discussed right now, term insurance, life insurance, health, vehicle, business as well, right? So work out financial requirements for you and your family, looking into the very long-term horizon, and implement or investment insurance plans that meet those requirements. So one thing you need to consider that, see, if you are earning 50 lakhs rupees today, if you look at 7% inflation, 5 years down the line, that 50 lakhs is going to be 35 lakhs, and so on. The numbers are written here. Okay, same way our expenses are going to increase. So out of 50 lakhs, if your expenditure is 25 lakhs, with the same amount of inflation, these numbers are going to rise. So that is where you need to balance it out, that okay, this is, if I'm earning this much, this is my expenditure should be in the next 5 years. So the planning should be started early, okay, and by your 50 years of age, you should say that okay, if I have earned this much amount, by retirement I can lead a very good life. So start investing early. Okay, we'll go into details maybe of what kind of investment that will be during the panel discussion. If you look at the 20-year returns on various types of assets, okay, equity is around 18%, gold is 12%, and this is in the last 20 years. Real estate is 9%, and debt is 7.2%. Correct. So if you look at, if someone wants to start up their own hospital, once you have accumulated enough wealth, enough capital, be it your post residence, you're working, and now you have, okay, this is enough capital I have to start my own hospital. First is formulate a good business plan. Okay, work out the realistic estimates versus the cost which is required. Okay, your hospital should have a positive net present value. That means what you are achieving, it should not be negative. Okay, avoid debt in the beginning itself. This will help for your continued excellence. Start your financial planning journey today, and your resources will be deployed for enhancing the vision for the people. I have just 2 examples here in terms of how this one-page financial plan looks like. Okay, so what you need to understand here is that this is for an individual or a family as well. Chart down your annual income, put your monthly debt payments, monthly expenditure, how much surplus you are generating. Based on that, you have your action items. Okay, which mutual funds you want to invest into, whether you want to step up your SIPs or not. Okay, what other investment do you want to look at? Like you want to invest into gold or real estate. What is the right time to do that? Okay. Similarly, the debt management is important. If you have previous debts, if you have surplus, clear all the debts rather than going into further expansion. Okay. So risk mitigation is important, and be clear with your taxes. This is a simple example of another type where a cash flow summary is there, with what comes in and what is going out in very simple status. And along with that, you match it with your goals. That okay, I want to take a family trip, international trip every year. I want good education for my child at say 5 years, 10 years. For that, you need to start early. Okay, because I think most of us here post residency, when you get a job, you miss out on that train that okay, if I am not going to start investing early, good opportunities may miss out. But it's never late. You can always start the day you think, okay, I need to put my finances into a proper structure. So that's it. That is from my side.
Thank you, Dr. Bhavik. I'm sure we'll have a lot of questions for you. Meanwhile, I'll request Dr. Neeraj Shah to deliver his talk. Only time will tell SIP and compounding. Dr. Neeraj is the director of Shankar Eye Hospital in Jaipur.
Good afternoon, everyone. So this session was specifically planned because my friend Dr. Prasanna was crying one day on my shoulder, saying that he wanted to be a wealthy genius like Edison rather than a poor genius like Tesla. So I'm going to teach you all how to become a wealthy genius like Edison. So first and foremost, all of your kit bags have a pen and a booklet. So please get out your pens and a pen and a booklet. पेन एंड पेपर रेडी करो सब लोग हाँ so only time will tell. So compounding, even the genius Einstein says that compounding is magic. This is just a very rough example that suppose you have 100 rupee, if you have 100 rupees right now and you compound at a rate of 15%, after 5 years it will be 200, after 10 years 400, 30 years it will become 6,600. So that's the magic of compound interest. So we'll start with a small exercise. This is the formula for compound interest that you see there. So like I said, get your pen and paper out. So here what we need to calculate is, suppose you have 100 rupees and you want to invest it for 3 years at a rate of 10% per annum. So how much money will you have at the end of 3 years? So here P principal is your 100. So start putting the formula. P is 100, then brackets, within the brackets 1 plus R upon N. So R is interest. Interest is 10%. So that is 0.1. So put 0.1. And we are going to give you interest only once a year. So N is 1. So 0.1 upon 1. Close the bracket and the, what is that called here? NT. So N is again number of years, 3 years. Number of times the interest is given, that is 1, sorry. N is 1 and T is 3. So 1 into 3 is again 3. So now P is 100. Within the bracket you have 1 plus 0.1, that is 1.1 and raised to 3. So 1.1 raised to 3 is how much? 1.1 into 1.1 into 1.1. How much is that? Calculator bhi nikalo. हाँ, 1.3. 1.3 into P, that is 100. How much is that? 133. So at the end of 3 years, your 100 rupees became 133 with compound interest. Now, if you look at what would have happened in simple interest and compound interest, if you would have gone by simple interest, you would see that at the end of 3 years, your 100 rupees would have become 130. But compound interest gives you 133. Since this is a very small number, 100 rupees, and very small duration, the difference does not look very significant. But superimpose larger numbers and longer durations, and obviously you will have a windfall. So if you use the same formula for compound interest, this also applies to wealth generation in a way. So FV is future value, PV is present value. Again, 1 plus R is the return rate, interest rate, and raised to the number. So this is how your investment and how much your, suppose let's say you take 1 lakh rupees as an investment and you keep it invested for, let's say 10 years. So at the end of 10 years, how much money would you have? So this is what will give you. So this is the same compound interest formula, but just in a different way. Okay. So just like us doctors, even these accountants have different ways of looking at the same thing. Coming to SIP. So of course, what is SIP? That on a monthly basis, you store away a fixed amount for a really long duration. And usually it's in mutual funds. I am primarily going to talk about mutual funds because SIP is concerned with mutual funds. And I will tell you how SIPs is better than doing a random investment here and there. Of course, my talk may look like I am a representative of HDFC Bank, but I am not. I am a practicing ophthalmologist, trust me. Okay? So how do you work around and generate wealth with your finances? So there are 3 ways to go about it. Of course, save more. Everyone has been telling us, our parents have been telling us since time immemorial. Invest for a long term and invest right. So in these 3 aspects, how do you go about it? So when I say save more, look at the first 2 lines. So if you invest 10,000 rupees and at the rate of 12.64, this figure 12.64 is the average rate of return that is being given by mutual funds in India. This comes from the mutual fund authority body in India. This is the average rate. So suppose you invest 10,000 rupees at 12.64% for 20 years, you will generate about 99.4 lakhs. Suppose you invest twice the amount, that is 20,000 at 12.64 for 20 years, you will get 2 crores almost. So obviously you can see very clearly that you save more, you will definitely earn more. And of course, don't do useless expense and this and that, and don't buy things that you don't need, and of course all that. So second point is time. So again, here there's a very clear example of how time works in your favor. So let's say there are 2 people, one is 25 years old, one is 45 years old, and both of them are planning their retirement at the age of 60 years. So 25-year-old has his retirement age of 60 after 35 years old, after 35 years. And the 45-year-old guy will be retiring in the next 15 years. So suppose the 25-year-old guy invests for 10,000 rupees per month for 35 years. His total amount invested would be 42 lakhs. But the amount generated at the end of, at the age of 60 would be 6.4 crores. Now the same guy, 45-year-old, even if he invests twice the amount, that is 20,000 rupees per month, but a very small duration, that is 15 years. So the amount invested would remain lesser, but the amount earned would be much, much, much lesser. That is only 1 crore. So obviously it is very clear that the less amount of time that you remain invested, your chance of growth is highly, highly limited. And of course, that is what we are talking here about. Another example of the same thing, suppose 20,000 rupees at 12% invested for 15 years, you'll generate only 1 crore. But 20,000 rupees at 12% generated for 30 years, you'll generate 7 crores. Can I continue for 2 more minutes? Yeah, I'm helping you earn money. So again, invest right. So these are the different examples: gold, petrol, diesel, milk. Of course, don't invest in diesel. But what has inflation done to them from 1990 until 2023? So obviously the inflation in gold, in the way the growth in gold is only 9.3%. Petrol, diesel has grown respectively 7, 10%. Milk is more expensive by 8%. And look at the chart there on your left, on your right. That is, suppose in 1990 you had 1 lakh rupees. And in 2024, the value of that 1 lakh rupees is only 10,000 rupees. So your money has shrunk significantly. Okay. So what is shrinking your money? Obviously inflation. And look at what different investments have given you in the last 40 years, 1982 to March 2023. These are proper validated industry figures, not made up by myself. So gold has only grown to, 29,740, but this, look at the last column, that is the Sensex. Sensex has, suppose you had 1,000 rupees in 1982, that money has become to 27 lakhs now, 2.7 lakhs. So the amount of growth in different assets is very different, and you need to invest properly. So that is what we were talking about. A lot of people talk about that stock market is unpredictable and all that, but you can clearly see from the chart, this chart is showing the stock market growth from 1992 until January 24, until last 3 months ago. And it has just been going upwards. So the blue line is the Sensex, that is the Bombay Stock Exchange, BSE. So how has BSE grown? Again, talking about volatility, that Ukraine war, this, that, COVID, everything happened. What has happened? You can see the blue line, it's just going up. This is data from the last 30 years. Another thing, a lot of people will say, Acha, when the market will go down, I'll invest. When the market goes up, I'll sell. Trust me, I am an aberration in my family. My entire family is in financial markets. I am into medical science. So you can never time the market. In the sense, you can never buy it at the bottom and you can never sell it at the top. It is impossible. So if you look at, even if you assume that you buy at the bottom, your CAGR is much lower. Even if you assume that you sell it at the top, your CAGR is much lower. But if you invest SIP wise randomly, you are basically averaging your risk, rupee averaging that's called, and your CAGR is much more better. That is 12.79. That is almost twice the amount of inflation rate. This is another example of SIP, like I was saying. I'll just give one example of SIP. These are real values. Suppose you invested 10,000 per month in 2001. So that would be 1.2 lakhs per year. And in March 2001, suppose you invested from 1st April 2001. After 1 year in March 2001, your money would have actually shrunk by 15% because the market was down in 2001. 2002, your market slightly went up, so your money only became 4%, still lower than the inflation, so you are not growing. Again, 2003, money was not growing. 2004, suddenly the market went up and your money grew and your investment actually increased by 36%. You can see the green row there. 2005, again 36% growth. 2010, 27%. And if you look at 2020, 23, and if you average out in the last 20 years, you would have grown at approximately 16% if you would have invested 10,000 rupees every month for the last 20 years. These are actual market figures and not just a random imagination. This is a table that I would say all of you should take a very, very keen look at. On the left side here, it says that how much is the money that you aim for. Let's take the middle row, that is 1 crore. Let's say you want a corpus of 1 crore. Look at the tenure, 5 years, 10 years, 15 years. Let's say you want 1 crore at 15 years. So, and at the 15-year column, there are 3 different calculations, 8%, 10%, 12%. 12% is actual documented gains that is actually happening in the Indian markets as of today. 8 and 10 is just for discussion purposes in case someone is very skeptical. So let us even say 10%, let's average it out. So if you want 1 crore after 15 years, so to 24,900. Do you see that figure on the slide there? 24,900 is the amount of money that you need to invest every month for the next 15 years for your corpus to become 1 crore. So this is a very, very relevant chart, and I think all of you should really pay a lot of attention to this chart and start figuring out what is your capacity of investment. The very interesting thing of this chart is if you look at the very last column, 25 years. So let's say people who start investing by the age of 25 years and look at the amount that they need to invest. Looking at the 1 crore row, and suppose you even consider 10%, they only need to invest 8,000 rupees per month to generate a corpus of 1 crore. So that is the magic of compounding in SIP. And since obviously most of us don't have the time to understand markets, go into the market, it is very, very important. If you all have not paid attention, Tendulkar and Dhoni have been right all the while saying mutual fund sahi hai. So SIP karo, hai na? So another tip, so as to say, there is another method called top-up SIP. In the sense, instead of just investing, let's say 10,000 rupees per month, if you just, obviously your income, everything is going to roughly grow, let's assume 10% every year. So you should also increase your investment by 10% every year. So last year you were investing 10,000 rupees per month, considering 10% of 10,000 is 1,000. So you should start investing 11,000 rupees per month this year, and subsequently 12,100 and all that. So every year if you increase by your investment by 10%, the growth is magical. So let's say, look at the green bar. Suppose you would have invested only 10,000 rupees. The corpus generated after 30 years is only 3.5 crores. But suppose you invest 10,000 with incremental investment of 10% every year, the corpus at the end of 30 years would be almost 6 crores, practically twice the amount. So instead of, every year, suppose your income is growing by 10%, instead of increasing your spending by 10%, you could rather consider increasing your savings by 10%. Okay. There's a very interesting book called The Psychology of Money by Morgan Housel. And he says the biggest problem that most people have is, every year, almost everyone, most commonly, most people end up having increased earnings every year. But they fall into a trap that every year they upgrade their lifestyle also according to their earnings. As long as you keep upgrading your lifestyle, your wealth will not increase. So you have to start understanding whether you want to upgrade your lifestyle or whether you want to upgrade your investments. And this is just the trailer of what I told you. I can go on and on. This is just some random formulae that I am showing you. These are some very, very important formulae and concepts that you need to understand. And we cannot definitely go into detail here, but you should definitely consider discussing this with your financial consultants. Thank you.
Thank you, Dr. Neeraj. So we've had some wonderful talks. So let me just kick off the discussion. I'd put a question to my panelists. So looking back from where you stand now, on a financial point of view, there are certain things which you would have, which you would be proud of that you did in your younger days. Some things that you would rather not have done. So looking back financially from today, what would you tell your younger self, the younger person who's just completed MBBS, what you should do, what you should not do from a financial point of view? Anyone, please.
So, sir, I am in my 30s right now, but when I look at myself, I think that I should have, started investing just after MBBS. I have recently started investing in the markets and SIPs, but I think even if it would have been 8,000, 10,000 per month, that would have made much more of a difference than what I am earning right now and investing more. So as sir rightly said, that I would just advise my younger self to, start investing early.
Yeah, to my younger self, so I started investing in equity during my PG break, the study leave which is there, because studies were done, I was bored, so started reading these books and started investing in equity. So that time I realized this could have been done during internship, during MBBS days itself. So I will say that if I had gone back and I can invest in equity.
And what would we have not done?
That list is endless.
At some point you have to enjoy also. You have finished your MBBS, you have finished your PG, and MBBS days are the golden days of your life, because now if you realize, if you want to take out time for that, to enjoy your life, it becomes really difficult. And now it's like that is the time when you are enjoying on your parents' money. So I think that is the time you can enjoy, because when now I earn, now I don't like to spend. But that time I used to spend like anything. Okay, it's my dad's money. So at one point, yeah, it is very true that you have to start investing at a right time, and doing SIPs as little as 5,000 rupees a month is also a very good way in your early life. But in early life, I don't think you have to go on investing heavy and not enjoy your life. But then, yeah, that is what I think.
I think when he said about right time to invest is now. Now means today. As he clearly mentioned, there's nothing as you wait for the stock to go down or stock to come up and all. No, just invest. If you feel you have money today, you invest. Simple as that.
Investing early has also one more aspect that we often overlook. We always look upon compounding. But when you start investing early, you are investing with a very small amounts, 500,000, 10,000. Better to do all the mistakes that you will do with a lakh of rupees rather than do that with 500,000. Learn how the market works, and then when you have more money to put in, then that will make sense. You won't make that mistake. So starting early, as I started investment. I started with mutual fund and then stepped on to equity and everything, and I have failed miserably in the first 1 or 2 years. But now when I am managing more money, then it becomes very helpful. Those mistakes are not getting repeated. So risk will be less, I think.
So valid point that he said. Nowadays we always hear about equities and mutual funds that dominates the market. But as youngsters, we really don't know whom to look up to or where to get the actual information from? You have WhatsApp channels, you have YouTube channels. Every random Tom, Dick and Harry can give you advice on stock markets and equities. So my question would be, when you're looking at investing in equities, we're all professionals, we're all held up with our work and surgeries and all that. So how do you actually go about it? Is there a single point of contact or a person or a method that you would follow when it comes to equities and the markets?
So it's different for different people. One thing before answering this, I just wanted to say, people who are planning to invest now and looking at the market, because market is at all-time high these days, and in last 1 year, the profits what people have got is enormous as compared to what it has been in last 15 years or 20 odd years. So don't look at market in that way that it is going to stay like this forever. So that is the other thing. But for me, my dad used to invest, and he was an investor. My younger brother, he used to invest. So for me, I didn't have to go anywhere else to take that advice from. But then there are a lot of platforms, and you should be you should talk to those people. You know how a person, you should talk to multiple people who are investing and then decide where to invest, because there are a number of YouTube channels, there are a number of people who will try to tell you invest here, invest there. Sometimes you will look at the G Business or news channels and just invest, and you'll see other 15 days the market, that stock has gone down miserably. So don't do that. You talk to multiple people and then decide where to approach and how to do the investments.
So one thing I would like to add here is, like, we also started late, like thinking about financial planning and things like that. So initially I was also watching so many YouTube channels, but I was not getting a clear image. So finally what we did is we hired a certified financial advisor, and actually if you can, that's the best thing, because it really made a difference. What we were thinking and what they were thinking and how they sorted our life was something different, because they had plans for, my daughter is 8 years now. So they made up a plan where she becomes 16 years, when she is going for +2, how much money we'll need to invest for her higher secondary education. Then if she fails in her entrance, and if we need to take her MBBS seat, how much money we need. For that he sorted out what all mutual funds and what all other investments we are going to do that. And then for her marriage, for her degrees. So something like that, each stepwise they had decided on which all mutual funds, what all other type of diversifying our assets, everything, like how to take on real estate, when to buy a house. So that was something different, which I think we as medicos may not think that much widely.
Absolutely, absolutely. So what she says is leave it to a professional.
Yeah, I'd like to take Neeraj's opinion on that same question.
One formula that I would want everyone to know about is something called as IRR, internal rate of return. There are a lot of formulas. One is real rate of return, nominal rate, all that. Whenever you take up any scheme, every day all these bank guys, they think that all doctors are very wealthy. They'll come and say that you invest in this, after 10 years we'll give you this, after 20 years this much. So I'll just give you a very live example from what happened to me and my brother about 2 weeks ago. So we had gone to HDFC to open one account for some work, and then he started us with one scheme wherein you invest certain amount and all that. So we listened to him patiently. At the end of that, we told him, let's put it in Excel and let us calculate by IRR. So IRR would tell us that after 20 years, how much would his scheme give us, the rate of return. And the rate of return was only 5.4%. That is a very stupid scheme, obviously, because even if you assume that the inflation is 6 or 7%, your rate of return is less than the inflation rate. And most people don't understand that. It just becomes very, when someone bombards you with so many numbers and a long-term plan, and that after 20 years will give you 2 crores and all that, you just get bamboozled. It's difficult. So always apply IRR and always try to understand what is your real rate of return. What I mean by real rate of return is rate of return when people will tell you that your rate of return is this much. For example, they say your rate of return is 10%. Does it discount for inflation or not? So please ask this very valid question. And once they start discounting it for inflation, you might realize that your rate of return is hardly 4-5%. So that is a very important thing that you need to consider.
So, sir, I just had one question to Bhavik, sir, as well as the other panelists. As you mentioned that, you know, you used to save enough and then go for a private practice. So, my question is like, for example, I'm sure many other people in the audience would be like me, who are a second generation ophthalmologist, and they are not they don't have a family to take care of, and we might be planning a second center. So, I would want to save, and then, but I don't want my money to, you know, just rot in the bank, you know, because the percentage of return is very low. So how to plan your investment, like what part of my earnings should I invest and what part I should keep in the bank, so that 5 years down the line or 3 years down the line I can plan a second center? How do you go about it?
So there is a concept of reverse EMI that will come into play. So you have to calculate that after 5 years. You have to take into account inflation also. So say if your center is going to cost around say 2 CR to start that second center, then you just get the reverse engineer it. So every month how much you will have to there is goal calculator in all the SIPs. So just fill in that you want that. And if your goal is around 5 years, you don't want to take risk into equity market. You will have to put it in some safer instrument, so returns will be less, around 12%, 10 to 12% will be. So calculate that, and then you just start saving. So it becomes reverse EMI. Instead of taking loan at the end of 5 years, you save some money and then you invest that amount. So that is the reverse EMI concept.
To expand upon his question, he said he has cash in hand, and how is he going to deploy that sometime down the line? My question would be, if there is a youngster who doesn't have cash in hand, but he desperately wants to start out with his private practice. The challenges in front of him are two major challenges as far as finances are concerned. One is instruments, and one is, you know, real estate or the infrastructure as such. So assuming there is no cash in hand right away, no cash which he can obtain free of interest from family or something like that, what are the best avenues? What can he do?
I was in a similar situation. I was thinking about this when you don't have cash in hand. Like a friend had approached me for the similar question and we were discussing. So in certain cities, there are options available where you need not buy even a phaco machine, neither an OT as well. The OT is on rent, phaco machine is on rent. You have your OPD, you take everything, OCT machine is on rent, laser machine is on rent if you're a retina surgeon. Okay, you get OTs with a vitrectomy setup which is ready for you. Obviously, your profit earned in that will be lesser, but then you don't have that pressure of the EMI, right? That I have to. So basically, you're not going towards an unethical practice. Eventually, people may succumb to it. So that is one option which I have in mind. I don't know if others can add into it.
Yeah, so the crux is that until and unless you have a clientele, don't, you know, burden yourself with too much of a loan or something like that.
On this, I would like to say that if you want to start a practice and you really don't have any money right now, then don't think of starting a practice right away. You wherever you want to start a practice, just go to that city, start with some corporate hospitals, earn a good amount of money, earn a good amount of name in that city itself, and then earn some amount of money. I just think that wasting too much money on place is one thing. Paying a rent becomes a very big burden on you when you start a new practice. Apart from that, when you're talking about instruments buying, these days companies are giving a very good thing about PDCs. PDCs are a post-dated checks. Post-dated checks means you buy a machine for suppose 20 lakh rupees. You just pay an amount of 2 lakh, 3 lakh, 4 lakh rupees in advance, and then you give them checks for every month. And these are interest-free post-dated checks where they do not charge any interest on them. And as long as some companies are ready to pay you those PDCs for 3 to 4 years also. So depending upon what you can, how much do you think you can actually earn, depending upon that, you can slowly invest in each and every machine step by step. So that is one way where you can go with PDCs.
And also you will have to have multitasking, like you have to cut down the fixed costs. So if you are going into a periphery and starting your practice, the rent will come down, the real estate will come down, manpower will be cheaper. Then you have to have multitasking person, so that same person is going into your OPD and then assisting you in OT also, so you don't have duplication of staff. So those kind of cost cutting you will have to do initially to get that corpus. Once the corpus is there, then you just build on that. So that is one way to go.
I think group practice can also help when you don't have money. You can, like, if you have trustable friends, everybody can put in money, and once you are good enough, then you can separate and start on.
So I would also agree, sir, as you said that in our city also, you get machines on rent. In fact, there's an OT assistant also that you get on rent, like 800 rupees, you get the OT assistant also. So I think I would agree to that.
Any questions from the audience, please, before we wind up? Okay, one last question to my fellow panelists. So all this requires a lot of time and effort from our part. We are professionals. We have to attend conferences like these. We're all family people. So how do you juggle all this? How do you, try to strike a balance? A quick word on your daily schedule or a weekly schedule?
For this asset management or money management, hire a professional. If you're earning that much amount and you're going to go into a bigger corpus, it's easy to give them that much amount of money so that they can generate more wealth for you, rather than you sitting down with that and your balance sheet and all. That balance sheet is important, but at least the decisions which are required to be going to in the nitty-gritties of it, the professionals can take care of it.
So one thing I can say as a female, one thing you can do is you should divide your time into time blocks and religiously follow that. So what I do is morning 1 hour is for my exercise, and I'm a classical dancer, so I practice classical dance. That is for my well-being. Then few time is for my family, kitchen and things. Then the work time, 9 to 5, I can't do anything. That time I am completely in work. But afternoon, usually I have little, less patience, so that time I'll try to do some research work, whatever is possible. Evening again is for my family, and that time nothing else should happen. And then after that also 1 or 2 hours you can spend for yourself, your me time. So that you have to divide yourself.
So for me, I had an experience of A and B testing where you have two strategies. So my mother gave me the corpus when I returned back. She gave me some money that this is the money your father had fixed and now the FD has matured. Now you are into investing. So you manage this for me. So I invested the money in few stocks and few mutual funds for her, and I left it at that, and it was growing. And then for my portfolio, I kept churning every 1 or 2 months. I kept buying and selling stock. And at the end of 1 year, what I saw is my return was 14% and she was sitting on 26% of return. So for me now, it is an yearly ritual in June because the season is dull. I don't have cataract operation to do. So for 1 month, I do all the research and put it on SIP. So even through IND Money, that is an app, you can do SIP into stocks. So direct stocks, ETF, mutual fund, whatever I have to decide, I decide in the June, and next June I review. And what I do whenever I see the market is up, the news flashes market is up, I just open my portfolio, see that it is growing well. When the market is falling, I don't open it at all and just be happy. And at end of 1 year, it gives a decent amount of result. So not much of time spent throughout the year.
So take home message, in June, give Nilesh a call. Thank you, fellow panelists. It was a really interesting session. Request you all to join us for a photograph.
All our finance experts, huh? बाद में देखूंगा स्लाइड ऑन वीडियो हाँ क्विज
ये मेरे पास करण
So the next session is the quiz. I would like to welcome Dr. Prashant Bavankule sir and Dr. Akshay Nair to the stage, please. So this quiz is supported by Microvision. 1 minute stage. I would also, at the request, Dr. Prashant has to leave, and I would request photographer, please. I would request our honorable president, the official photographer. So I would request our immediate past president, Dr. Digvijay Singh, to please give a token of appreciation to Prashant Bavankule sir. Thank you, sir, for your tremendous support towards YOSI as always. You have really helped us a lot. Yes, sir, you're a part of YOSI.
Thank you. Thank you. Thank you.
We will take a picture with sir. You also quiz masters.
Yeah. Thank you. Chalo, let me take leave because I might miss the flight. Delhi sana bharosa nahi hai.
Hello, hello. Connected HDMI type C HDMI.
ऑडियो चाहिए?
नहीं ऑडियो नहीं चाहिए, वैसे भी HDMI आ जाता है ना.
Can I see some excitement here for the quiz? I'm doing your job.
No, we still have one session going on there. I know it's very important, oculoplastics, but you can ask them to wind up. All right, so we have the quiz in two halves. The first is a few MCQs that we'll go through, and you all have your voting pads for your fastest fingers first. And the answer, you plug in, put in your answer the moment you see a question. We have 40 questions, 10 seconds each. Okay. So from the moment we say your time starts now, you have 10 seconds to vote. The first answer that you press in is registered, and that will stay as your final answer. Not only are you going to get scored on whether you get the correct answer or not, it also depends on how fast you get it. We'll wait for 5 minutes. We'll try to gather more people. So not only whether you get the maximum number of answers right, also it depends on how quickly you answered them. The inbuilt scoring takes both into consideration and puts it up. So we'll just wait for a few more minutes. Once we go through this entire exercise of about 40 MCQs, which will take about 10-15 minutes, we'll pick out the top 5 who then join us on stage, and we have a few rounds here, and then we pick the top 3. The top 3 get cash prizes, and the top 7 get, the number 4 to 7 get additional gifts, surprise gifts from Microvision. Pen drive, yeah. So there is something for everybody, and we have some audience questions also. नहीं तो हम लोग हाँ हर 10 क्वेश्चन के मैं जब बोलूँगा ना कौन कौन है तो आप दिखा सकते हो, स्विच कर देंगे ना तो चलेगा. परफेक्ट. अच्छा क्वेश्चंस आपकी लैपटॉप से आ जाएंगे, ठीक है चलेगा. पर ये तो मेरा लैपटॉप है ना, ये मेरा लैपटॉप. ओके चलेगा. हाँ ऑडियंस के लिए हम लोग देंगे. ऑलराइट अवनीश शुरू करें. 5 मिनट, 2 मिनट, 2 मिनट्स. बोल दिया. अरे इतना मैं नहीं खाऊंगा. अच्छा ठीक है. अरे क्रैकल तो मैंने रोस्ट आमंड ठीक है. Does everybody have your voting pads? Everyone put. Okay, we'll wait. The group is taking selfie. Okay. Everybody has voting pads? No, no, agreed, agreed. Everybody has voting pads? Anybody who doesn't have voting pad? We are handing them out. All right. There's still some people outside talking. We'll try to get them in also. All right, so I think we'll go ahead and start. Right, so what we're starting off with is a trial question. So before we go over that, we'll start with the rules. Remember, Quizmaster is always right. There are two parts to the quiz like I explained. First we go through the MCQs. We have voting pads which will also register not just the right answer but also the time from when the timer starts on the screen till you press the right answer. Both are factors that will be generating the score. And finally your cumulative scores will be taken. Top 5 get to come on stage for part 2 of the quiz, where the winners, the 3 winners, get cash prizes. The quiz has a lot of specialities involved, so if you are in doubt, refer to the first rule. All right, so everybody is set to try out if it works. All right, so the question on your screen, you can start voting after I say your time starts now, and that's when you will see a timer go up. No, this is not the नहीं है question. क्या कर रहे हो? वो आंसर अभी गूगल मत करो. वो वार्म okay. All right, we have some new people coming in. Voter pads. Warm-up question. Some more voting pads. अच्छा, मतलब हर स्पेशलिटी का एक चाहिए आप लोगों को. उसी के सबसे ज़्यादा क्वेश्चंस हैं. Okay, so as it turns out, we don't have a warm-up question. We directly go into the question that you saw on stage, on the screen. All right, so rules are clear. I think all of us have done this n number of times, and I mean, this group is fairly tech savvy. So we start, we'll swap. Your first question is, after performing punctal cautery, what is the expected rate of recanalization? Your time starts now. Timer? Yeah, you see that time? You've got only 10 seconds to answer. All right, so everybody said, majority have said C, and C is the right answer. So punctal cautery does have a recanalization rate of 20 to 30%. So we had about how many? 49 pads responses collected. I think there are more than 49 people with pads over here. So try to get your question in time. Okay, some people are still collecting their answer pads, so we'll wait for them to get settled in. All right. Oh, oculoplasty, and you missed the first question. All right. Anyway, question number 2. What is this device? And your time to vote starts now. Oh, wow. Lester Jones tube, a mini Monoca, a Master Ka, or an Express mini glaucoma shunt. And majority have said, well, I like the people who said this is a glaucoma shunt. Yeah, that will definitely reduce the pressure for sure. It is a Lester Jones tube used in a canalicular DCR, and it's about 1.5 centimeters long for those people who are wanting to implant this as a glaucoma shunt. Right. So your third question on your screens is, a carotid or cavernous fistula causes all of the following symptoms except, and your time starts now. A, bruit. B, pulsatile tinnitus. C, proptosis. D, blood in Schrem's canals. Remember, it's an except question, the ones that we hated. Yeah, and yeah, finally, people have said D, where the right answer is B. It does not cause this. So it causes everything except pulsatile tinnitus. Pulsatile tinnitus is not, tinnitus is ringing in your ear. That does not happen in a CCF. Yeah. All right. Your next question is this: which of the following is not used to treat this condition? So you understand what the condition is and what is not used. Your time starts now. A, interferon. B, mitomycin. C, 5-fluorouracil. D, vincristine. See, some can be some googlies also, so think and answer. Yeah. So at least that googly part worked on 7 people. Vincristine is not used topically. Vincristine is used only as an injectable anti-chemotherapy. Don't worry, retina is coming. I was just warming up now. Yeah, it's coming. Hey, Avastin is the answer na. Kya hai? Biosimilar. Chalo. Okay, question number 5. Teprotumumab is an FDA drug approved for A, BRVO, macular edema, C, B, wet ARMD, thyroid disease, or intermittent uveitis. Your time starts now. नहीं पता नहीं यार मेरे वो मैं हंसना नहीं चाहिए था पर ऐसे लग रहा है कि लोगों को फिर भी 5 लोग तो होंगे जो गलत आंसर करेंगे. देखो 12 से 14 लोग थे यार. Very good. All right. Question number 6. So it's see see, this is not plasty. B scan of a patient with loss of vision shows this. What is your diagnosis? Your timer starts now. RP, adenoCA, metastatic choroidal mets, hemangioma or a melanoma? Wow, okay. So melanoma, everybody, most of the people got it right. That is the correct answer. Question number 7 is, this OCT finding is associated with which of the following? So you've got an OCT image and you've got a raster scan or image there, a red-free image. Your time starts now. Choroidal mets, hypotony, neuroretinitis or posterior scleritis. I think the OCT is very characteristic. Yes, most of the people got this right. Gross hypotony, the lumpy bumpy appearance as well as the neurosensory defect. Alright, our question number 8 is, which beverage should come to your mind when you see the CT scan image? Your time starts now. The option C should be Long Island iced tea. So sometimes I put this question which just to see how many people will get it wrong. And there's always one person who gets it wrong, who's put Red Bull. So I like that. Makes my day. Yeah, so this is the Coca-Cola bottle sign. It's the appearance of the extraocular muscle that's tapered at the top and widens as it goes posteriorly. Tendon sparing enlargement of the extraocular muscles. Alright, so we go to question number 9, which is, this is the fundus picture that you see. At this point, what is the most appropriate investigation for this patient? Your time starts now. Is it CD4 counts? Is it RT-PCR to assess COVID? Do you want to get a serum cholesterol level checked or a blood pressure assessment? The right answer is a CD4 count. So what is this condition? CMV, yeah, see, one person has to, okay, this is at stake. So if you shout, then I can give this out. And yeah, abhi, ho gaya. Next question. Nah. If and the ones left behind at the end of the quiz, I get to keep them. So, question number 10 on your screens. Karl Kohler in Austria in 1884 used a chemical compound for anesthesia in the eye. Which chemical did he use? Your time starts now. Now, Rituja, don't say these things are also there in the Yonite. Right, so the right answer is what the majority got, cocaine. His name was Karl Kohler, and he used to be such a big proponent of cocaine. He was nicknamed Coca-Cola because everywhere he used to go, he used to talk about cocaine and coca. So after 10 questions, we'll see who are our leaders at this point. Yeah, so top 5, who's 146? Excellent. 146, number 5. Who's number 5? Yo, Bappi, not allowed. तू यो है क्या अभी भी? अच्छा. नहीं, मैं यो है तो तू यो ही है. 67. Yeah, this group, something is happening there. Huh? All of y'all are doing collective. 163. Okay. Someone in the front. Great. And leader at this point, 24. Very good. He's killing it. Chalo. Now, of course, see, things can change. 90 pe 4 log hai. So, you see these scores and the time taken is what is deciding number 2 to 5. So, it's a tough fight here. All right, we switch over and we have our question 11 on your screen now. Bitemporal hemianopia may be seen in. Your time starts now. Tilted discs, bilateral ischemic optic neuropathy, dermatochalasis or sectoral retinitis pigmentosa. Wow. Because that is the only thing you treat, right? Dermatochalasis, yes. Great. All right. So, one person got it right. Okay, this one, yeah, you can come and correct. It's only you got it right. All right. Question number 12 on your screens, on this screen. Who is credited with the invention of the binocular indirect ophthalmoscope? Your time starts now. Sometimes I feel questions should have only 5 seconds, not even 10 seconds. Bappi, how many will get this wrong? 50%. 19, 25, 35, almost 48% got it wrong. Not bad. Charles Keepens is the right answer. All right. So question number 13 on your screen is, you see this picture of the cornea. Which of these conditions is not associated with this finding that is being highlighted? It's more evident on the first picture. Your time starts now. Is it A, keratoconus? Is it B, acanthamoeba keratitis? Is it C, Fuchs dystrophy? Or is it D, limbal stem cell deficiency? Which of this is not associated with clinical finding? It is limbal stem cell limbal stem cell deficiency. What is the finding that was shown there? Enlarged prominent cornea. No, not prize questions. Enlarged corneal nerves, that's right. Okay, 14th question on your screen now. The most common site for the optic nerve to get injured, which results in traumatic optic neuropathy, is any of these four. Your time starts now. Intraocular segment, intracanalicular segment, intracranial segment, or intraorbital segment of the optic nerve. And thanks to some loud yelling, everybody's got B right. Very traumatic for the quizmaster. Don't give out such answers like this. All right, our question number 15. What percentage of the population have a serioretinal artery? Your time starts now. 30. Oh, afsos. Everybody got, no, still there will be someone who get it wrong. नहीं चला तो चलो, अब चल गया, चलने दो, तेरा जादू चल गया. Let's see. Now we should have hope in humanity. See, these things make my day. Now they made my week, man. I mean, you show the answer and tell them to press the key. I think the bar has started already somewhere. Right. Okay, so next question, and we'll get it right this time. Which one of these drugs is most likely to cause an optic neuropathy? Your time starts now. Sahi question pe time chala. Chloroquine, ethambutol, thiauridazine, or vigabactrin. Most likely. All right. Everybody, almost everybody got it right. Chloroquine causes maculopathy, retinopathy. And I think those drug names I just put randomly. So, yeah. Ethambutol causes optic neuropathy, first sign being color loss, loss of color vision. So, question number 17 is, what is the duration of action of proparacaine? Your time starts now. 20 minutes, 12 minutes, 25 minutes, or 7 minutes. Think of the time that you need to do a topical phaco. Not 1 hour, right? Mixed bag. Right answer is 20 minutes. Question 18 on your screens now. In asteroid hylosis, the vitreous particles are made of. Your time starts now. Your time has started. Ta-dang! Okay. The sound didn't come, so I had to do that. Okay. Yeah, everybody got it right. It's calcium. Your question number 19 is on your screen now. What is this object better known as? Your time starts now. Is it a Malyugin ring? Is it a B-hex expander? ए उधर पीछे सेशन चल रहा है क्या? आवाज कम करो ना. I can't hear myself. A is the right answer. It is a Malyugin ring. Hex nahi hai, it's not a hexagon. So, question number 20 before we have our next viewing of the scores. After undergoing an uneventful cataract surgery, a patient is found to have a refractive surprise of -3. Which of these could most likely have caused the error? Inadverting pressing on the cornea while doing A scan, previous myopic LASIK, a silicone filled eye, or use of SRK1 formula. Your time starts now. Little complicated options, so I read them before starting the time. All right. Right, A. Where's Zen? Zen is not there. Oh, okay. Good, because I stole his question. Okay, so we'll have the next viewing of the scores. Do we have the same guys on top? Oh, is there a change? No. 5th place, 31. Who is 31? Okay, from infamous group there. Number 5, Bappi. 95. You all have swapped remotes? No, okay. 24. Hey, you are buck up now, 2nd place. 163. All right. Oh, you're still there. Great. Okay, so 2-3 changes here and change at the lead also. See again, number 1, number 2 is only time. All right. So question 21, we have enough time. A 70-year-old man underwent cataract extraction with phaco and a PCIOL. The first day post-op, he comes back with stromal edema and moderate epithelial edema. Which of the following is least likely to cause this? Your time starts now. Is it TAS? Is it elevated IOP? Is it as a result of excessive phaco energy? Or is it due to surgical trauma to the endothelium? The right answer is simple elevated IOP. Your next question 22 is on the screen. What is true about Schirmer's test that is performed after instilling a drop of anesthesia? Your time starts now. It measures reflex tear, it measures basal tear. It should be used with 4 drops of anesthetic and should be performed before drying the conjunctival cul-de-sac. You're right, everybody, most of them got it right. It is basal tear secretion. Without anesthesia is the reflex tear secretion that is measured. So number 23 on your screen, you use diochrome to refine a patient's refraction. The patient says red letters are better, appear clearer than the green letters. Your patient is, your time starts now. Okay, so I'm going to take one. All right. So question number 23, this is over plussed and I think everybody said over minused. Question 24 on your screen. What is the most suitable treatment for this? That is stage 1 diffuse lamellar keratitis. Your time starts now. Do you give a short course of topical steroids? Do you lift the flap and irrigate under it? Topical mitomycin C, or you'd want to take the patient up again and do a PTK. Yeah, someone is there who said they want to do a PTK for this. Very nice. So topical steroids is the best treatment for this course, this condition. Question 25 on your screen is which IOL formula is most accurate for short eyes? Your time starts now. Hoffer Q, I think almost 86%, 44 out of 47 or 49 got it right. Question 26 on your screen. Is your patient is taking oral medication for symptomatic, it's so symptomatic that it comes twice, benign prostatic hyperplasia. Which of the following is the least effective in dilating the pupil? Your time starts now. Intraocular epinephrine, iris hooks, Helon GV, or manual stretching. Least effective. Least effective is manual stretching. Manual stretching or dilating the pupil won't help in these cases. So that was the wrong answer, because it won't help. So 27 is this question on your screen. The pathology of phacolytic glaucoma is blockage of the trabecular meshwork by what? Your time starts now. Is it lens material? Is it blood resulting in erythrocytes? Is it inflammatory lymphocytes? Or is it larger white blood cells or macrophages? It is macrophages in response to it's an immune response to the phacolytic episode that macrophages enter and block the trabecular meshwork. Your 28th question is on the screen. The steroid that is least likely to cause PSC, and your time starts now. Loteprednol, triamcinolone, dexamethasone, or prednisolone. Least like Loteprednol is the right answer. Hey, discussion in less volume. वो discussion से तो top 5 में कोई नहीं है. बप्पी के अलावा क्या करो? Thank you. All right, 29th question. Which of the following does not cause uveitis? Your time starts now. Rifabutin, Cidofovir, Amiodarone, or Latanoprost. Which of the following does not cause uveitis? Amiodarone. What does amiodarone cause? Vortex. Come, you won. I heard you give out the answer first. Okay. Right. So 30th question, before we have a look at the scores on your screen. 30th. We are suturing a lid tear at night. I mean, you can suture it at day also. Which of the following needles would you prefer? Preference doesn't change with day or night. Your time starts now. Is it spatulated? Is it reverse cutting? Is it round body? Or is it tapered? Everybody got it right. It is reverse cutting. Reverse cutting is the one that goes easiest through the tarsus, so you would prefer that. Least atraumatic when you pass through the tarsus, so you'd prefer reverse cutting. For residents who are interested, that's the cross section of how the needle looks. All right, we'll just have a look at the scores. Number 5, 148. Wow. 48. Oh, new entrant. 95. Old party. 163. Same. 24. Same. Okay. Very good. So, Bappi, क्या कर रहा है? Where are you? Number 5. ठीक है. You are roundabout there. Same score but slow answer. Chalo. Question, last 10 questions to go before we move on to the 5. Do we have the video from Microvision that we play now? Is it there? Yeah, it is. There is one question based on the question, the ad. So. It's not there? Okay. So we'll play it at the end between the two rounds. All right. 31. Regardless of the etiology of the ulcer, the group of drugs that is always indicated in corneal ulcer is, your time starts now. Corticosteroids, you give every patient of ulcer. Cycloplegics, you give every patient of ulcer. Antibiotics and antifungals. Now, you know, someone is thinking, "Oh, dete to sab log hai hum log." The right answer is cycloplegics, and that is regardless of the etiology, you give it in all. Right. So, question number 32 is on your screen now. What do you associate the word Herbert's rosette with? Your time starts now. Is it sphenoid wing meningioma? Is it endophytic retinoblastoma? Is it active trachoma? Or is it herpes zoster ophthalmicus? Yeah. देखो rosette से धोखा खा गए, rosette से धोखा खा गए. It is active trachoma. So these little blobs that you see on the limbus are Herbert's rosettes. Alright, so not every rosette you hear is retinoblastoma. Question 33 is, identify this visual. Time starts now. Alright, good. The audience participants have got it right. It is Terson's retinopathy, and the next slide is, I think, an answer about Terson's retinopathy. We go to the next question. Alright, identify this, the spectrum of this condition. Your time starts now. Retinal metastasis, tractional retinal detachment, retinopathy of prematurity, or isolated VPRTs or vasoproliferative retinal tumors. This is the classical ridge that you see in ROP. So this was retinopathy of prematurity. Your next question, 35. Which statement about this image is true? Steroids are the treatment of choice. Patients may have type A personality. Age of presentation is 50, or a myopic shift is seen. Your time starts now. So first identify the question in eye condition in your minds and choose the most appropriate true statement. It is, most people have type A personality. This, what is the appearance? Stokes snack occurrence. Smoke means you will give answer. Okay, question 36. Next question. Which one of the statement is not true based off this condition? Your time starts now. Not true. Right, that is correct. What is this condition? Optic disc melanocytomas, optic nerve head melanocytomas. चॉकलेट, अच्छा ठीक है, ये शेयर करोगे तुम लोग? अच्छा दो सेठी साहब, ठीक है. So they rarely turn malignant and rarely need active intervention, much like me. 37. Cretin protocol is used in which condition? Your time starts now. And in case you are wondering what is this, this is the traditional dress of the island of Creta. So, right. So it is the Cretin protocol is used in keratoconus and collagen cross-linking. Wow. All right. 38, 39, 40. Last three questions. 38. In A scan, A stands for, your time starts now. No. How many will get it wrong? 10 people, 5 people, 3 people. 9 people. I underestimate people. 9 people got it wrong. A scan is amplitude scan in your IOL calculation. Yeah, nice. Okay, your next question on your screen is 39. 22-year-old post LASIK on day 5 with visual acuity 624 and IOP 25. What is your diagnosis? Your time starts now. Flap displacement, pisak, satak, pisak, dalak. Which is, मतलब flap displacement हुआ तो सटक ही गया होगा. It is pisak. What is the full form of pisak? What induced? Okay, is it right? Then you can take it. All right. As you may have guessed, I don't do refractive surgery. Question 40, your last question to come on the screen, on the finals. Identify the syndrome associated with this condition. Your time starts now. Usher, Noonan, Kane Sir, Golden Har. The right answer is Usher, and that's what most people have got right. All right, are we ready with our top 5? Has the top 5 changed, or is it going to remain the same? We'll have the scores. In 5th place is number 184. 184. Please introduce yourself. Right.
Hi, I'm Dr. Pranita Sahai. I'm working as assistant professor at Guru Nanak Eye Center, MAMC.
Yes, please join us on the stage for the finals. Number 4, 148. Please introduce yourself and join us on the stage.
So I'm Dr. Bhavya Gokani. I'm with ASZ Eye Hospitals.
It'll take half an hour. Number 95. Please introduce yourself and join us on the stage. So 3 of y'all can be there and 2 of y'all can be here.
I am Dr. Isha Gupta, Senior Resident in Guru Nanak Eye Center.
Excellent. Please join us here. So Associate Professor and Senior Resident will fight it out. Same unit? No, that would have been more exciting. All right. No, you can't sit here. No. Number 163. Please.
Hi, I'm Dr. Avni from Guru Nanak Eye Center. So
I'll
have to sit with either of the two.
So you get to decide whom you want to sit with.
Sir, anyway, you tell me.
No, I'm not. You have to be screwed, not me. You will decide. She will now decide whom she likes more. And number 24.
I am Dr. Kausik Tripathi, ASD Eye Hospital, Kolkata.
Please join us on stage. A round of applause for the top 5. Yes. All right. No, we need that mic here. Okay. So what we're going to do is, give me a second. All right. ये presentation डाल सकते हैं? All right. So we've switched over to this. So I also need all of you all to have a pad and a pen and a paper, because I'm going to need you all, and also keep it close to you, because there's going to be a round where I'm going to have you write down something as well. Okay. So you 3 of you all will be sharing those 2 mics, and both of you all will be sharing this mic. So we've got 3 rounds, and we'll go over these 3 rounds. It's a bit of opthal, it's a bit of general medicine, little non-ophthal, non-medical as well. Different rounds, different rules. As we go ahead, I'll explain each of them. I need someone to volunteer as our scorekeeper. Yes. So you please be our scorekeeper. Right. So in this round, this is infinite bounds, where we put up a slide or a picture or ask a question, and if the person, the question is directed to team or person 1, team A, if they answer it, the next question goes to team B. Team matlab person, yeah. So if Dr. Kaushik doesn't answer, it goes to you, and if B doesn't answer, then it goes to C. But if C answers, the next question starts with team D. This makes sure that there is no fixed order, and it makes it dependent on who answers it and mixes it up. So there is no favoring tough questions, easy questions. It goes with the mix. So this is, so Rutuja, when I say plus 10 to team A, or so I'm referring team A, B, C, D, E. We'll keep those names. I know team is one person, but yes. All right. So are we ready? Kaushik, your first question. Yeah. Do you all have a, yeah, keep your mic with you. And you have about 10 seconds till I tell you your time is up. Only the first person gets the time. The other people don't get the time. You guys need to answer, or I'll move quickly from person to person. And audience, please no shouting. I have separate audience questions and all of this. All right. So Kaushik, this lesion you see
nodule
is leash nodules. Before I could complete the question, plus 10 to A. So leash nodule is seen in neurofibromatosis. All right. So Dr. Pranita, right?
Yes, sir.
Your next question, your question is on the screen. What is this Google Doodle celebrating? Audience, please keep it quiet.
World Health Day.
Is incorrect. We go to C. D. All right. It will come to you. So what does it celebrate?
His birthday, his birth anniversary.
All right.
Centenary.
Is centenary birth. We will give plus 10 to D. It is Dr. Govindappa Venkateswamy's birthday or Dr. V's birthday. Google Doodle celebrated his centenary birthday with that doodle. So that was plus 10 to D. And now the next question is to E. Ma'am, this is an image. What is your first differential diagnosis? Into the mic, please. Retinoblastoma. The first round is supposed to be simple. Plus 10 to E. ये क्या है? All right. So Kaushik, this comes to you. Your question is, see, the first round is just warm up. We want everybody to have points in their account. So what is this mode of imaging?
Autofluorescence.
Autofluorescence is correct. Plus 10 to A. Rituja. All right. So B, Dr. Pranita, your question is on the screen. What is this seen in, or what is it that you see? It will come to you.
Choroideremia.
Choroideremia is incorrect. C.
Please do not prompt.
Yeah. Thank you for doing my job, but yes. All right. E. D, sorry, D. No, E. Optic nerve avulsion is correct. Plus 10 to E. This is a classical optic nerve avulsion with the disappearance of the disc with peripapillary hemorrhage. Avulsion of the optic disc. So D answering means Kaushik is going to answer the next question before I can put on the slide.
Morning glory syndrome
is correct. So plus 10 to Kaushik. And morning glory syndrome or morning glory disc was what we were looking at. All right, Dr. Pranita, the next question for you on your screen. Looking at this image, what one word that also describes the photography equipment comes to mind? No prompting from the audience, please. So, clearly there is a bony lesion or a disruption or something of that sort. What word that also describes photography equipment, a piece of photography equipment comes to mind? I have to move to C, D, all right, E. Can't give that much time. Kaushik?
3D reconstruction.
3D reconstruction is the image that I've seen, but there are no negative marks. So audience, okay, yes, yes, yes. Tripod, yes. All right, okay. So it is a tripod fracture. For bonus points, can you tell me the bones involved in a tripod fracture? Zygoma? Maxillary? And frontal. My God, I would have given you one more, but no. Thank you. That is correct, because the temporal bone is the fourth one. So, one question, 1 point for the quiz master. B, my Dr. Pranita, the question comes back to you because nobody answered this one. Why does this typewriter have such few keys? Audience, please hold on. This is a typewriter, but it has only 6 keys with one large key in the center.
For blind people, for braille, typing in braille.
Is it to read or write or type?
It is to write braille.
I'll give it to you. It is a braille typewriter. A round of applause to Dr. Pranita. That is the correct answer. That's a braille typewriter that you can use to place the dots in different configuration. Since B has answered that question, the next question goes to C. All right, so this is a slit lamp image. What is this classical description of this condition called?
8-ball hyphema.
8-ball hyphema is the word we were looking. So she's also opened her account. A round of applause. Dr. Bhavya, your question is on the screen. This is a picture of Peter Ebdon, a former snooker player and world champion. Very often towards the end of the game, he asks a referee for help to overcome an handicap.
Color blindness.
So a snooker player is colorblind.
Handicap.
He is correct. He is colorblind. So to differentiate between the colors of the balls, he has to ask the umpire or the referee what ball he is hitting. That is correct. So plus 10 to Bhavya. And while Dr. Rituja tabulates and gives us the score, I think, do you have the scores ready? Please.
So in first place right now is Dr. Kaushik with 30 points. Second place is a tie for Dr. Bhavya and
Avni. Yeah.
With 20, and Dr. Pranita and Isha are at 10 each.
All right. So not too much separating them. Now we will slightly up the level of questions, some more infinite bounds, and this time we start with Dr. The team E, so Dr. Isha, Avni. Isha is Avni. All right. So slightly more difficult questions, but again it's essentially image based. So this is the image on your screen. What condition are we looking at?
Racematosis, angiomatous racematosis, seen in Wyburn Mason.
Is the word I was looking for, Wyburn Mason. So you get plus 10.
Plus 15. Sir.
Plus 15, yes, plus 15. Yes, you're right. Plus 15. I was just checking. All right. Plus 15 to team E. And Dr. Kaushik, your next question. Since Avni answered that right, the next question comes to you.
Eye stent.
Stop.
Glaucoma.
All right.
Eye stent and its other versions. Eye stent inject.
Okay. Before I could ask the question, I was hoping there would be some joke cracked on that crazy shaped device, but Yeah, you know what it looks like. I'm not going to say it. But they're all eye strength. They are all used in trabecular bypass. They are used for reducing the IOP. Plus 15 to Dr. Kaushik. Dr. Pranita, this is your question on the screen. Can you give me the name of this instrument? I need the name, full name.
It's an exophthalmometer.
That is given. I will not be able to give you points for that. Hey.
Lude's exophthalmometer.
I will give you 15 for that. I would have been even happier if I had heard double Lude's exophthalmometer, but Lude's is good enough. All right. Dr. Isha, your question on the screen. What is the condition, not the imaging modality?
Optic disc drusen.
Optic disc drusen, all right. And for brownie points, not actual points, what is the mode of imaging? Autofluorescence. So optic disc drusen is correct. Plus 15 to Dr. Isha. Dr. Bhavya, your question is this. This is a fundus picture. A 17-year-old boy who's coming for a regular checkup. 20/20 vision, normal, everything else except the fundus. What should be the next step that you're doing? All right, Dr. Amni.
Leopard spots, a peripheral smear.
Peripheral smear is incorrect. Kaushik?
Basically, colonoscopy should be done in multiple CHRP cases, which are atypical CHRP, but this is typical CHRP. So basically, we should do colonoscopy for this.
So you're telling me a 17-year-old boy comes to your clinic and you're telling me you want to do a colonoscopy for him. You should have, yeah. As absurd as it sounds, not surprisingly, that is correct. This is CHRPE that is seen in familial adenomatous polyposis. You would see multiple colonic adenomas which have a risk of turning metastatic, so you would want to rule that out, and also other members in the family should also get them checked. All right, so Dr. Pranita, your question is on the screen. You get full points only if you name 2 systemic conditions that you would look for in a patient with this fundus finding.
So basically, that's a capillary hemangioma, and Sturge-Weber syndrome, VHL is what we are suspecting, and so cerebellar hemangiomas
is one,
and renal. We'll like to look at the renal hemangiomas. Renal involvement can be there.
All right, I'll give it to you. Cerebellar hemangioblastomas and renal cell carcinomas are 2 of the systemic conditions they would associate with VHL. You identified that right. Other conditions include pheochromocytoma, pancreatic cysts, endolymphatic sac tumors, and cystadenomas of the epididymis. So plus 15 to Dr. Pranita. All right, so Dr. Isha, this is your question. I'm putting up 2 images. One shows the clinical sign and the other is of a gentleman, and one is named after the other. I want the keyword that connects them. The audience, please don't say it. Even if you whisper it, the sound will travel.
Edward
Edward is incorrect. Bhavya? Zerm is incorrect. Dr. Avni? All right. Kaushik?
Khuda dost.
Khuda dost is correct. That's the Khuda dost line, and that's the Iranian surgeon who described it, Dr. Khuda dost. That's the word we were looking for. Plus 15 to, you didn't see the line?
I didn't see the line.
So plus 15 to Kaushik and cornea, sir. No wonder you sat there. So your next question for Dr. Pranita is on your screen. Camera. All right, so this is the serial, the natural progression of this condition.
Best disease.
Best disease is the answer I want to see. Best answer gets 15 to Dr. Pranita. And Dr. Isha, your next question is this. So, which organism was first written by an Italian priest and biologist who named this organism after a holy water sprinkler, because the microorganism looked like this, the holy water sprinkler. So that is a sprinkler which you dip in the water and you spray, the water comes out of the tip. So what organism did this biologist Pier Antonio Micheli see under the microscope that he named after a holy water sprinkler, because the appearance was like that? All right, Bhavya. Okay. Dr. Avni.
Candida.
Candida is incorrect. Dr. Kaushik.
Proteus
is incorrect.
Bacillus.
Bacillus is also incorrect. All right, audience. Aspergillus. Yes, I heard that first. So you get this. Okay, so this is the Pope throwing water from an aspergillum. Now do you know? Congratulations. That's a great answer. So that's the aspergillum. That's called an aspergillum. And you can see why he named this organism aspergillum. That's why it's called the aspergillus. All right. So that was a question for Dr. Isha. You get this question again because it went round and nobody answered. Okay. So this is a monograph or a paper that was written in 1920 that described a new eruptive fever associated with stomatitis and ophthalmia. I blocked out the authors' names. I need the names of the authors whose names I have blocked out. This is description of a fever associated with stomatitis and ophthalmitis. Just put those three together, you'd get the names. All right, Bhavya, since Isha has said no. So this is the names of the authors or that have been blackened out from this paper. The paper describes a new a fever that is associated with stomatitis, ulcers in the mouth and ulcers in the eye. Dr. Avni.
It'll be wrong. I don't know. Stephen Johnson.
It is correct. Stevens and Johnsons are the authors who wrote this. That's why I said it's right there in your face. So a wonderful answer. Plus 15 to Dr. Avni there. Dr. Rituja, do we have the scores now?
Yeah.
All right.
So currently last is Dr. Bhavya with 20 points.
All right.
Then Dr. Isha with 25. Then is Dr. Avni with 50 points. And after that is Dr. Pranita with 60. And Dr. Kaushik is leading with 75.
Wow. Round of applause. So we got the scores. Okay, oh wow, we have an audience question. Or do we? Yes, we do. All right. So, in which product logo do you see this? So this is a part of a product logo that I've zoomed into. Pharma product. Seti, you should know. No, so see what is happening there. That's so. वो तो पता है answer क्या है? Answer. Otherwise, I'll open this and eat it in front of you all. I have to person. Oh, अफसोस ये गलत जवाब. समय समाप्ति की घोषणा. तो सुना नहीं ना मैंने. Ozudex, that's where the Ozudex is eating. Tukka tha, lekin nahi chal gaya. Okay. So for this round, I'm going to need the mic here. And what I'm going to do is all right. So the next round is something called as progressive glasses. So in this round, I'll be getting progressive hints, which is I'll give a hint and I need you all to raise your hands. I'll come to you all, see what you have written and tell the scorer whether you've answered it right or wrong. The reason you can't shout out your answer is because there are other hints and others may want to answer at that time. So if you get the answer right at the first hint, it's plus 15. But if you get it wrong after the first hint, it's minus 10. If you go on to the next clue, if you already answered at plus 15, you can't answer again. But otherwise, you can answer again, you get plus 10, and if you get it wrong, you get minus 5. At the third attempt, you get only plus 5, no negative. Raise your hands, write down clearly only one answer that I'll see. So basically, to give you an idea, this is like a trial question. Time magazine named her one of the 100 most influential people in the world. She's a Padma Shri awardee who won the Miss World crown 20 years ago. So 20 years ago would be 2004. So answer is yeah. So you should raise your hand. I'll come and see what you've written. For Aishwarya Rai, you will get minus 10. For Priyanka, you may get plus 15. But only one answer you can tell me at that time. So if nobody else or only one person gets it right, we go on to the next clue. In an American TV drama thriller, she plays the role of Alex Parrish, who's an FBI agent. So you got it right. And the third is she's a lead actress in many remake movies like Dawn, Zanjeer, Baywatch. So you get the idea. The answer we were looking is Priyanka. I will not be asking questions like Priyanka. I will go on to, if one person answers because they are writing it and only that person and I know what he has written, I will just tell her if he's got it right or wrong. Others can answer and you can move on. And in the next clue, even you can answer again. Then everybody can get points. Yeah. And multiple people can get the answer right at the same question. All right.
And if you get a negative answer, then
you can answer again and get that 10 back again. Yeah. All right. So ready? Okay. So these are slightly difficult. Sometimes you may even call it obtuse because the connect may not be. But itne paise mein itna hi hoga. All right. So this is the picture of a German ophthalmologist. See, it's difficult to get it at the first guess, but that's why it's plus 15 and minus 10. His name bears work in glaucoma, in trauma, and in corneal surgery. His name is very prominent in all three branches. Okay, so Bhavya is trying to go for plus 15 minus 10. And he gets minus 10 for now. Let's see if he can get that back. So I'm going to the clue number 2. There is an arrow that is pointing to something. All right. Kaushik, for plus 10 versus minus 5, show me what you've written. No. So then he just gets minus 5. Kaushik gets minus 5. I have... Okay, I think I'm going to get my step count done today. Okay, and what have you written? Is okay. All right, so these three get plus 10 each. So they got this right. And we go on to the last clue, which these three can't answer. This is the clue. So, which is why I think the audience needs to be a little more considerate. So plus 5 to both of them and the audience, generous audience member there. So this is how everybody scored, but you see how different people can score different points and it can change the leaderboard, especially with the negative markings. So that's Eric Seidel, it was Seidel's scotoma, and that's the Seidel test. All right, next question. Connect. This clinician used to document his findings of the fundus on oil paintings to show pigmentary changes on the posterior pole due to onchocerciasis. And Kaushik gets plus 15 on this one. So I'll just make it a little easier. He's not known for his fundus related work, but he used to see this condition and draw oil paintings to document fundus findings because that time there was no fundus camera. His statue is the only ophthalmologist to feature across all the Madame Tussauds museums. Kaushik, you already got it right. You don't write again. Across all the Madame Tussauds museums in the world, his statue is at the Sydney Madame Tussauds Museum. as the most celebrated ophthalmologist to feature in wax. All right, your last clue is rarely known to the world by his first name. Nicholas performed this surgical technique in the 50s, but it received FDA approval only 30 years later in 1981. He performed this. Okay, I'll open this up to the audience if someone can raise their hand. Gas is wrong. You're looking for a more solid answer. Nicolas Cage is incorrect. Okay, so I think that Harold Ridley is the right answer. Nicholas Harold Lloyd Ridley was posted in Africa and India as a military officer. He studied onchocerciasis. He drew these diagrams and he implanted the IOL in 52, but the IOL finally got FDA approval in only 82. So Harold Ridley was the answer I was looking for.
Basically, he was not liked by his colleagues, and it is said that he was sent to other country, Africa, for like a penalty post. So that's where he did this before he put the first IOL inside any human eye, which was also not received very positively initially.
That's right. All right, your third connect. This is the picture of an Italian anatomist. Now, the reason why he is important in ophthalmology is because his area of study was the eustachian tube and its physiology. Now think of how the eustachian tube and its physiology and what could be his name and why he is important to ophthalmology, or more specifically retinal surgery. Plus 15 to SETI. All right. We go on to clue number 2. These are his first drawings of what he studied and how this structure changes pressure. All right. So Bhavya wants to go for plus 10 minus 5 and he gets plus 10. All right. And clue number 3. Any hands going up? Okay, I have 2 for plus 5 over here and both get plus 5. Madam is getting right, the SRs are not getting right. All right, audience. Oh, okay, audience is miming it out for the people on stage. Seti got it right, he got plus 15, so I'm going to give an audience prize to him. This is Valsalva maneuver. The Italian anatomist was Valsalva, and that is Valsalva retinopathy. Congratulations. Inner tube, and that's how it works, right? Okay, the next connect. This is the everted eyelid, and you clearly see one structure over there. All right, okay. He's written something, he's written something. So we are going for plus 15. Try to cover your answer so others don't see it. He's not writing. He's not written. All right. So we go to clue number 2 with plus 15 for all except Bhavya. So Bhavya, this clue is only for you. There is a surgery that involves transplanting the distichiatic lashes from the lid margin and pushing it 4 millimeters behind, which is called the anterior lamellar repositioning, and it's a surgery that's even performed to date to treat trichiatic entropion. Bhavya has also got it right, so he gets plus 10. Audience? See, everybody got plastic question right. Okay. For audience, the clue is clue number 3. Alt triangle. It's Alt's line, which is seen in trachoma. Alt's surgery for lamellar repositioning, and Alt's triangle is the geographical arrangement of the KPs. All right. Your next connect is the scientific rationale behind this sign is the nasociliary nerve because of the common innervation. So Bhavya is showing me, and he gets plus 15 for this one, and Kaushik and Pranita both get plus 15, and Dr. Avni is also raised her hand, and she gets plus 15 as well. Okay, so as the questions are going, everybody's getting it right. So Dr. Isha, the second clue is only for you. The three features in this set are interstitial keratitis, malformed teeth, and 8-nerve deafness. This set bears the name of the answer that I'm looking for. What is this set? All right, so let's see if you'll remember the name on the third clue. This is ophthalmologist, dermatologist, venerologist, and pathologist. So that gives you an idea of this disease affecting all of these.
More difficult to hit.
Yeah, I know. More difficult to hit.
This is more difficult to hit.
So I thought, I didn't think this would come to the third clue, so I had to put this. Alright, so what disease affects the eyes is a sexually transmitted disease, affects the skin, and you see this classical pathology. It is, the word we were looking for was Hutchinson. It was Jonathan Hutchinson who's described syphilis in detail. It was, and also herpes. It was Hutchinson's sign and Hutchinson's triad. All right. So our next connect is this. Dash, that is the word that I'm looking for, is a word referred to a Roman soldier who is in charge of 100 other army men. So this is the word that's relevant in ophthalmology that refers to a soldier who is in charge of 100 other men. All right? Anyone from the audience for plus 15? No, you're not. Okay, I'll come to you. Google people. No. All right. This condition was called so because of the similarity in the nasal structure between these patients and the description of the Roman warriors from their statues. So patients with this condition have a similar nasal structure to the Roman warriors whose statues they saw. And that's why the name is the same. So what condition, what disease, what syndrome are we talking about based on the appearance of the nose? All right, clue number 3. This system has active Sentry technology, which is the only handpiece with built-in pressure sensor that gives you real-time IOP to allow you to operate at physiological IOPs. And he gets plus 5 for this. And she also gets plus 5. Dr. Pranita and Kaushik both get plus 5. And I think, yeah, so I'll see if there are any answers. This is incorrect, no loss. You get plus 5. Dr. Avni gets plus 5. And the answer I was looking for is Centurion. It is Centurion syndrome, which is the appearance of the nasal bridge because of the anterior medial canthus. Centurion is a word for a Roman soldier who leads a century of army men. And Centurion is the latest phaco system from Alcon. We'll go to our last connect before our, I think our, rapid fire. The etymology of this word came into use in the 17th century from Latin. When translated literally, it means nipple. Minus 10 to Bhavya. He saw the word nipple and jumped. But unfortunately he loses 10. The Latin word for nipple is something that is commonly heard in ophthalmology. This is found in many parts of the body, including duodenum, tongue, heart, skin, apart from the eye. So where on the epithelium, so you see these on all of these structures, the tongue should be a big giveaway. Not big, that is, so Bhavya gets his 10 that he lost. And I'll move to clue number 3. In the eye, we are looking in the relationship. We see this in relation to this word. What do we see here? Right, Dr. Avni, you're scribbling something, yeah, but that's incorrect. You don't lose anything for that. Dr. Isha. All right, Dr. Pranita. Yes, so +5 to her. And papilla. Papilla is the word we are looking for. Papilla is the word, Latin word for. No, he didn't. So we give our question there, and.
So does it literally mean nipple?
It does literally mean nipple. तू ले लिया, मैं उसको ले रहा था. So papillitis means disc edema only. I mean disc inflammation only. Don't get ideas. All right. So so I think we now will go on to our rapid fire round. Or we have one audience question and a rapid fire. So this is Harold Ridley's lens that he implanted. I have blacked out the name of the company that dispensed or created that lens. Alcon is wrong. Yes, Kaushik. Rainer is the right answer. Rainer, who has a stall right outside, did not pay me for this question. All right. So Rituja, before we go to rapid fire, can we have the questions? Rapid fire is going to take 4 minutes, 5 minutes, 1 minute each. Scores.
Dr. Isha with 50 points. In fourth is Dr. Bhavya with 55. Third is Dr. Avni with 95. And second currently is Dr. Pranita with 105. And at first place is Dr. Kaushik with 130 points.
Wow. Big round of applause. So in fifth place is Dr. Isha. Fifth place is Dr. Isha. So we start the rapid fire with you. The rapid fire is 8 questions, 1 minute, plus 10 for every right answer, minus 5 for a wrong answer. You can pass, and if we have time, we come back to you in that 1 minute. Can I request someone to keep a time? Because Rituja will be adding score. Dr. Avnish, thoda kaam kar lo. No, we start in fifth, fourth, third, second one. No, each one, the one set of questions to one participant. 8 questions, 1 minute. And your time starts after I finish the first question. All right? Avnish, the time starts after I finish the first question. Time, acha screen, timer screen pe aa jayega. Perfect, excellent. Plus 10 minus 5. Very good. So, मैं पहला question जब खत्म करूँगा तब you start the timer. All right. So, Dr. Isha, your set of questions starts now. Intravitreal injections are used in the treatment of retinoblastoma. True or false?
True.
Is correct. Expand the acronym SMILE.
Small incision lenticular extraction.
Is correct. Dysport, Xeomin, Myoblock are different marketed names for which drug?
Sorry, can you repeat this?
Dysport, Xeomin, Myoblock.
Pass.
The effectiveness of which drug was studied by the ATOM studies, ATOM?
Atropine.
Is correct. Dacryology deals with which part of the eye?
The lacrimal drainage system.
Is correct. Which organism is most implicated commonly in canaliculitis?
Staph aureus.
Is incorrect, minus 5. Traditionally followed eye trauma terminology system bears the name of which city?
Bets.
Which city?
Birmingham eye
is
trauma.
Correct. I'll give it to you. What is the field defect first seen in papilledema?
Enlargement of blind spot.
Is correct. Dysport, Xeomin and Myoblock are different marketed names for which drug?
Atropine. Pass,
is
pass.
Incorrect. You lose 5 for that. I did hear atropine. So Dysport, Xeomin and Myoblock are names for? Botox is another brand name. Botulinum toxin. Botulinum toxin and actinomycetes is most commonly involved in canaliculitis, but you got 6 correct with 2 wrong. So that gives you a total of 50 in this round. Well done. A big round of applause, please. All right. And in 4th place is Dr. Bhavya. So this set of questions comes to you. Your time starts after I finish the first question. EDOF lenses work on the principle of a single elongated focal point rather than several different foci. True or false?
False.
Is incorrect. Expand GHPC.
Pass.
The Honaver's classification is associated with which disease or condition?
Retinoblastoma.
Is correct. The term that is indicated by the number of vessels passing over the optic disc margin in optic atrophy is known by what name?
Pass.
What is the most common presenting sign of ocular myasthenia gravis?
Ptosis.
Is correct. What is the most common organism in traumatic fungal corneal ulcer?
Pass.
Which drug or substance is injected in photodynamic therapy?
Vertiporphin.
Is correct. What is the most common field defect in non-arthritic ischemic optic neuropathy?
Pass.
Which is the most common organism in traumatic fungal corneal ulcer?
Candida.
Is incorrect. Your time is up. GHPC, can someone expand that for me? Giant or geographic, both are correct. You got Dr. Honaver's classification system correct. Ptosis was correct. Vertiporphin was correct. So that's 3 right and Candida and the true and false wrong. So 3 right and 2 wrong.
What was the answer? Just curiosity.
Right.
For the optic disc, I forgot the ratio.
Kestenbaum's index.
Kestenbaum.
Kestenbaum's number or Kestenbaum's index. And altitudinal field effect is most common in NAION. All right. So in 20 for him. In 3rd position was Dr. Avni, right? Or Dr. Pranita?
Me.
Dr. Avni. All right. So your set begins now. Your time starts after the first question. Eylea or aflibercept is a monoclonal antibody for treatment of ARMD. True or false?
True.
Is incorrect. Expand DSAEK or DSEK.
Test stripping automated endothelial keratoplasty.
Is correct. Retisert and Utic are the names of intravitreal drug implants for which drug?
Steroid.
Can you be specific?
Pass.
What is the name given to iris lesions associated with neurofibromatosis?
Leash nodules.
Is correct. Use of absolute alcohol in an evisceration is to prevent the chances of what condition?
Sympathetic ophthalmitis.
Is correct. What is the single most important determinant in selecting a choice of surgery for correcting ptosis?
LPS action.
Is correct. Fox pentagon and Crawford triangle and double triangle are techniques of what?
Sling surgery.
Is correct. Which ophthalmologist is known as the father? I've started, so I'll complete. Which ophthalmologist is known as the father of macular diseases?
Pass.
Oh, okay. So, Retisert and Utic are intravitreal steroid implants of which drug? टाइम क्यों निकाल दिया उसमें? वो तो अभी हो गया, बीच में ही निकाल, बीच में मैं अपना इनका ये देख रहा था, वहाँ पे टाइम चल रहा था, यहाँ पर ये हो रहा है, वो बड़ा स्क्रीन पे टाइम डाल दो यार, मेरा ब्लाइंड स्पॉट में आ गया टाइम.
So anyway, pass. I don't know.
So that was fluocinolone acetonide. You got aflibercept is a recombinant fusion protein consisting of which blocks or traps VEGF. It is not a monoclonal antibody. So that's incorrect. That you got DSEC right. I cannot accept steroid as an answer, but that's not incorrect. So you don't get or lose points. You got Lish nodules, you got sympathetic, you got levator function, and sling correct. So 1, 2, 3, 4, 5 right and 1 wrong. 45. And the father of macular diseases is Gas, Donald Gas. That was the solid answer that I wanted. All right. So Dr. Pranita, your set of questions. You need a... All right. So your set will start after, your time starts after the first question. Fuchs endothelial dystrophy is mainly sporadic and rarely associated with genetic inheritance. True or false?
True.
is incorrect. Expand SLKC
Superior limbic keratoconjunctivitis.
is correct. The effectiveness of which drug was studied in the Marina trial
Ranibizumab.
is correct. Which muscle that receives innervation from the sympathetic nervous system is responsible for eyelid retraction?
Which nerve?
Which muscle?
Mueller's.
Is correct. Which is the most common orbital malignancy in children?
Pass.
Which extraocular muscle is affected by the canine tooth syndrome?
Superior oblique.
Is correct. Calcium particles in the eye are commonly seen in?
Steroid hyalosis.
Is
and
correct.
BSKs.
Which is the most common field defect associated with the pituitary adenoma?
Bitemporal hemianopia.
Is correct. You have time to answer which is the most common primary malignancy in children in the orbit.
Hemangiomas.
Is incorrect. So you get 2 wrong and 6 correct. That gives you a score of 50 for this round. Well done. Fuchs is associated with genetic inheritance, and rhabdomyosarcoma was the answer we were looking for.
Sporadic and sometimes genetic.
Yeah. No, mostly. So it is not rarely associated with genetic. It is significantly associated with genetic. There's a strong genetic preponderance. All right, Kaushik. So your set of questions starts now. The CRASH trial that studied steroids in traumatic optic neuropathy showed greater visual recovery in patients who received steroids. True or false?
False.
Is correct. Expand MUDES.
Multiple evanescent white dot syndrome.
Is correct. What is the systemic drug of choice for eyelid capillary hemangiomas and orbital capillary hemangiomas?
Propranolol.
Is correct. A Hollenhorst plaque is composed of what material?
Cholesterol.
Is correct. What is the most common eyelid cancer in the Indian subcontinent?
Basal cell carcinoma.
Is incorrect. Which is the only FDA approved drug indicated for eyelash growth?
It is prostaglandin, nematoprost.
Is correct. The surgery CARES is performed to treat what condition?
For corneal, this is a LASIK for keratoconus.
Is correct. What is the inheritance patterns of Leber's hereditary optic neuropathy?
Mitochondrial.
Is correct. You have 1 wrong and 7 correct with that answer. So that's 65 points to you. And yeah, we have 6 seconds left. So while Rituja is calculating, or do we have the scores? I hope there's no tiebreaker. No, okay.
So in 5th place is Dr. Bhavya with 75 points. In 4th place, Dr. Isha with 100 points. In 3rd place, Dr. Avni with 140 points. In 2nd place, Dr. Pranita with 160 points. And the winner is, of course, Dr. Kaushik with 205 points.
All right. Thank you so much for staying till the end for the quiz. Yeah. Oh, okay. Photo.
So we have the GBM going to start in Hall B. So all YOSI members can join the GBM.
And a round of applause for the quiz master.
Oh, yes. Prize. 6, 7 prize.
So top 10, we have our top 10 here. Right. So all the top 7, the bottom 7, sorry. No, top 7, top 4th to 10th. The bottom 7 sounds dirty. 4th to 10th get thumb drives. So do we have our numbers 4 to 10? Do we remember? 4, 5 है यहाँ पर? All right, please. Oh, 4, 5. 4, 5 नहीं. हाँ, 4, 5. Yes, correct. So please, Dr. Devakant to Dr. Bhavya and Dr. Isha. Photo लो, photo, please. कुछ नहीं. अरे तू गलत टाइम पे आ गया.
Vaibhav for helping out that group.
Helping the group that got it right.
Yeah, that got eliminated.
All right, and Dr. Isha in next place. Yeah. चले वो उस पे क्विज 5 वाला लेना तो 15 वाला ले. ऑलराइट, डॉक्टर भाविक, उनको भी थंब ड्राइव है. Who are our 7? Dr. Sethi, क्विज मास्टर. तो ये ऐसा आ रहा है for photo. Please come, ma'am. Dr. Sethi, please give out the. ये ऐसा ही फोटो के लिए आ रहा है. No. पक्का ना? हमको नाम लिखा नहीं तो सब कोई भी आके लिख जा रहे पेपर. जीबी देख के ले लेगा. All right. In third place is Dr. Avni, and she gets our prize of 5,000 rupees. Dr. Pranita is our second place winner with 10,000 rupees. And Dr. Kaushik, whose bulk of source of income is quizzes. Declared and undeclared everywhere, and now future banned contestant from all quizzes. Dr. Kaushik Tripathi wins 15,000 rupees. अभी next quiz master है तुम. हाँ. मैं आएगा पार्टी से.
नहीं रात को प्राची आएगी मेरे परफॉर्मेंस वो यही तो है 7 बजे से 7 बजे से इंडियन स्टैंडर्ड टाइम पेनड्राइव में क्रिप्टो
समय है ना अभी से वो पढ़ता था एमसीक्यू ये है ना
वाहिनी जिष्णुनुते भगवति हेशिति कण्ठकुटुम्बिनि भूरि कुटुम्बिनि भूरि कृते जय जय हे महिषासुरमर्दिनि रम्यकपर्दिनि शैलसुते
जिया चले जा चले जिया चले जा चले నేను తలే ధుమా చలే
പുഞ്ചിരി തഞ്ചി കൊഞ്ചിക്കോ മുന്തിരി മുത്തൊളി ചിന്തിക്കോ മഞ്ചണി വർണ്ണ ചുന്ദരി വാവേ തങ്കിണ്ണക്ക തകതിമിയാടും തങ്കനിലാവേ പുഞ്ചിരി തഞ്ചി കൊഞ്ചിക്കോ മുന്തിരി മുത്തൊളി ചിന്തിക്കോ മഞ്ചണി വർണ്ണ ചുന്ദരി വാവേ തങ്കിണ്ണക്ക തകതിമിയാടും തങ്കനിലാവേ
ജിയ ചലേ